Alo, Tiến. Alo, check, check, check.
Alo. Morning. So nice to see you all after 2 years. It's really exciting for us, and thank you so much for making time and being here in person. So I'm Pooja Raisam. I'm one of the organizing secretaries along with Dr. Deepa Bhatt. And I just want to give you a quick overview of the session. So we have today on day one, we have two pre-conference workshops. The first pre-conference workshop is a patient interactive session where we're going to have patients from with different disorders coming up, and we're going to have clinicians, genetic counselors, everybody interacting with them, followed by a panel discussion. Our second pre-conference workshop is on genetic counselor, genetics and genomic education and training. So we have about speakers from around the world who are going to be sharing how the genetic counseling training scenario is in their own countries and how it is in India. Again, followed by a panel discussion. And over the next 2 days, we have 6 sessions, genetic counseling in musculoskeletal disorders, cardiology, oncology, neurology, reproductive medicine, and ophthalmology. So we have experts from around the world participating with us. So thank you all for being here, and we are already happy to see so many faces. So I'm without any further ado, I'm going to hand over to Dr. Shweta, who's going to introduce the first session. Welcome once again.
Seeking the blessing of His Holiness. Good morning all. I'll just brief about genetic counseling. Genetic counseling is a communication process which aims to help individuals, couples, families to understand and to adopt the medical, psychological, familial, and reproductive implications of the genetic contributions to specific health conditions. Genetic counseling not only involves testing, but also providing a comprehensive guidance for the affected one and their families. So in this regard, we would like to hear the experiences and life of individuals who are affected by several genetic disorders. So now you will experience several cases in genetics from the patient, family, clinician, counselor, and the psychologist perspectives. Along with that, there will be an added on opinions and direction from the policy specialist and as well as from the rare disease specialist. So with this, let us begin the first session. I'll hand over the dais to our moderator of this session. For the first moderator is Dr. Angel. Madam is Senior Scientist, HOD, Genetic Counselor at the Department of Medical Genetics, Ramaya Medical College Hospital, Bangalore. And the next moderator, Dr. Subhadra Purnima. Madam is Consultant and HOD, Certified Genetic Counselor Level 2, Department of Genetics and Molecular Medicine, Kamineni Life Sciences, Hyderabad. And third moderator is Mrs. Subhashini, Junior Genetic Counselor at Molecular Diagnostic Counseling Care and Research Center, Coimbatore. So I'll hand over the dais to the moderator. And I have a request, please keep your mobile in silent mode throughout the session. At the end, there will be a question and answering session. At that time, you can ask your queries. And also the posters, it is available in the booth in the basement. At your free time, please free to stop and view the posters. Thank you.
Good morning. We welcome you all. I would like to invite our chairpersons for the first session. Prasanna Shirol sir, he's an MBA graduate, co-founder and executive director of ORDI, Organization for Rare Diseases India. And he is a father of a daughter diagnosed with Pompe's rare disease. And his challenges in diagnostics and management of his daughter brought him to this rare disease advocacy field. And he has many achievements to his career. He won Ashoka Fellow in 2018 and a Rare Champion of Hope 2019 from Global Genes USA. And he's an advisor to several non-profit organizations. We welcome you, sir.
Hi everyone. I'm happy to introduce Mr. Ritvik S. Kashyap, Assistant Professor, Department of Clinical Psychology from JSS Medical College. He has done MPhil in clinical psychology from Speaker Academy of Rehabilitation Sciences, Secunderabad. Currently, he is pursuing PhD from University of Mysore. He is passionate on mental health, resilience, parenting styles, and social cognition. His career highlights include being a professional life member at Indian Association of Clinical Psychologists and the World Association for Psychosocial Rehabilitation. He is also an associate member at Indian Psychiatry Society. Also, he has published various national and international. We heartily welcome you to this session, sir.
Dr. Jaya Vyas, ma'am is a consultant and senior research officer at Vadia Hospitals for Children at Bombay. And
गांडू है जे कैमरामैन है ने वो गांडू है काफी नाके हैं और तो
PhD from Mumbai University, and she has a 20 years of experience in diagnostics, research, and counseling. And to her career highlights, she is a member of AMP Fellowship 2018 and 19, Monza Fellowship 1997, and she is secretary to the Board of Genetic Counseling India. And she has many publications to her career highlights, and she's also a member of Indian Society of Human Genetics. We welcome you, ma'am.
It's my immense pleasure to welcome Dr. Moha Chakrabarti. Dr. Moha is a rare disease policy researcher, EST Center, ISC Bangalore. She is a member at WHO Global Cooperative Network for Rare Diseases. She has completed PhD in DNA barcoding in Assam Central University and completed postdoctoral in IBAB, Bangalore. Her interests are analysis of orphan drug approval system, policies involving health, education, research, innovation, and technology. Her career highlights are she is a member of STIP Secretariat, TSC India, Honorary Associate, Institute of Public Health Bangalore, Scientific Advisor for ORTI, and she has published around 10 papers in national and international journals. It's also my immense pleasure. I welcome Dr. Chakrabarti onto the dais. It's also my pleasure to welcome Dr. Giriraj Ratan Chandra onto the dais. He is a scientist. Welcome you, sir. He is a scientist and group leader, CSIR Center for Cellular and Molecular Biology, Hyderabad. He is a member of National Academy of Medical Sciences. He has completed PhD from Osmania University, Hyderabad, MD Biochemistry from Institute of Medical Sciences, Banaras Hindu University, Varanasi, DNB Biochemistry, National Board of Examination, New Delhi, and MBBS in R.K. Garg Medical College and Hospital, Kolkata. His interests are in complex diseases of pancreas like chronic pancreatitis, type 2 diabetes mellitus, and associated traits like obesity and insulin resistance. His interests are also in gene nutrition interaction and epigenetics, basics of complex diseases. He is a recipient of Andhra Pradesh Scientist Award for AB State Council of Science and Technology in 2007. He was selected for the Sun Pharma Science Foundation Research Award under the Medical Science Clinical Research category in the year 2021. He was awarded the JC Bose Fellowship in the year 2022 and has more than 90 publications in national and international journals. We welcome you, sir.
Now I request Dr. Jaya ma'am to introduce our first speaker for the session.
Hello and good morning all. Gives me a great pleasure to start this session by presenting two speakers who will be presenting a case on DMD. So the first speaker is Dr. Shastra Panaile, and he's an assistant professor at JSS Medical College, Mysore. And his academics are from Rahul Gandhi University of Health Sciences, Karnataka. His MD is also from the same place. He's a gold medalist at both undergraduate and postgraduate levels. And he has a fellowship in headache by World Headache Society. His interests involve research activities in neuromuscular disorders and has publications on neurology at national and international level. He is interested in working on headache, stroke, and epilepsy. His career highlights include as being a special faculty in international conference and one national level neurology quiz at NIMHANS in 2018. He's won Best Paper Award in ANACon 2018 and multiple research outputs in various national and international journals. At the same time, accompanying him is Dr. C.H. Amulya, and she's presently pursuing DMA Neurology at JSS Medical College. She's done her MBBS from NRI Medical College, MD from Kamilini Institute of Medical Sciences, Hyderabad, and DMM at JSS Medical College. Her interests include research activities of movement disorders and stroke. And career highlights are dissertation on incidence of dyslipidemia and assessment of CIMT in stroke patients, and presentations on inflammatory markers and their correlations with severity of early stages of CVT, and presentation on prognostic role of low T3 syndrome in acute stroke patients. She has presented a poster on neurology, double trouble by an infectious cause also. I welcome her also. Please. Thank you.
Good morning to everybody. It's my proud privilege to present the case of muscular disease on this platform, and I wanted to thank all the organizers who had given me this opportunity to present this case on this international platform. I'm Dr. Amulya, a senior resident DM Neurology in JSS Medical Hospital. I'm going to present a case of a neuromuscular disease. Child is a 14-year-old male residing in Mysore, middle class socio-economic status, and information was given by mother, which is reliable information. He presented to our hospital with a chief complaints of weakness of both lower limbs since the age of 3 years and weakness of both upper limbs since the age of 4 years and frequent falls since the age of 4 years. He is a known case of G6PD deficiency and global developmental delay, and mother noticed to have difficulty in walking of child since the age of 3 years, and child used to trip and fall frequently on walking fast and running. He had difficulty in getting up from squatting position and even difficulty in getting up from sitting position, and also difficulty in climbing stairs, and he used to require the support of railing while climbing stairs, and he used to walk upon himself to get up from sitting position. However, he could able to insinuate the toes into the slippers, and there is no difficulty in gripping and no slippage of the shuffles. There was progressive worsening of the symptoms, and by age of 5 years, he required the support of 2 people for ambulation, and he also had difficulty from standing up and from sitting up position, and he had to climb upon himself, which is suggestive of Boer's sign from the history perspective. Mother noticed that there was progressive increase in thickness of his calf muscle along with thinning of thighs, and that he had noticed mother noticed that child had a lurching gait, for which he had swaying to either side with tripping of both bilateral hips on either sides. At around 4 years, mother noticed that he had difficulty in combing his hair and reaching the objects at a higher level. However, he doesn't have any symptoms pertaining to distal muscle weakness like buttoning, unbuttoning his shirt, opening bottle cap, and mixing and eating food without any difficulty. Currently, since past 3 years, child is wheelchair bound and he is unable to walk even with the support, and he has to be lifted from the bed by 2 people and he has to be transferred onto the wheelchair. He required assistance for all these daily activities, and he developed abnormal curvature of the spine and also dynamic contractures of bilateral ankles and knee joint regions. This is negative history. There is no history of any stiffness of limbs, no difficulty in toe walking, no muscle cramps, no diurnal variation, no history of any head drop, twitching of limbs, and no difficulty in releasing objects after gripping, and no history of any breathlessness, no cranial nerve involvement, no seizures, no sensory and autonomic abnormalities, no cerebellar involvement, no bubble in bladder, and no high colored urine.
These histories are asked just to add for certain reasons. So we wanted to note any of this, if there is any possibility of metabolic myopathies, or if there is any history of any neuromuscular junction disorders. That is why the history of muscle cramps was asked and the devaluation was asked. And basically, the respiratory environment has to be ruled out in this case. That is why recurrent respiratory infections are important. And palpitations, because if there is any cardiac involvement along with the skeletal muscles. And the environment for the cranial is because certain muscle disorders can have affection of orobulbar apparatus or the cranial bulbar apparatus. And obviously, if there is any multi-axial disease, that is why we have to ask about cerebral involvement. And high color disease is basically because if there is any history of myopia biliaria. So these are the importance of this asking negatives in a case, because as a clinician, it is important for us to rule out and zero out what is a possibility, because before investigating, you should have some certainty and before going further. That is the reason for asking all these negative histories. Go forward.
Natal history, child was born via non-consanguineous marriage. His first child, term delivery, LSVS was done in view of amniotic fluid leakage. Birth weight was around 2.7 kgs. He cried immediately after birth, and suck and swallow reflex was normal. There is no history of any jaundice, no history of any neonatal seizures, no ICU admissions. Developmental history, there is significant delay in motor and language domains. Immunization history was given according to the schedule. Coming to past history, at 3 years of age, he was diagnosed to have G6PD deficiency because he was admitted for fever and had ecchymosis and purpuric patches along with hematuria. So he was diagnosed to have G6PD, and currently 6 months back he was diagnosed with polylithiasis, which is a sequel of G6PD deficiency, and he underwent treatment for that also. And family history, mother's sister's son is also diagnosed with the same DMD disorder, and he was currently bedridden. He is 25 years of age.
Here there is actually a double trouble in this case. Child had hemolytic anemia picture as well, had lot of petechiae, purpura and hematuria, which was not related to the primary disease per se. And all the history as clinicians, we start from the perinatal history, because any developmental delay for that matter, it could be multi-axial. So is it a cranial environment, or is it a cranial, or is it peripheral, is it neuromuscular junction, is it peripheral now, has to be reduced. For that reason, as clinicians, you always take ask history from the perinatal period itself, or the antenatal period itself. That is why this history has been asked, because many of the times, hypotonic CT can sometimes make a muscle disorder, and the pernicious marginal disease can make like a cerebral palsy. That is why this particular history is very important in this particular case. Unfortunately, this can have a double disorders in going on with the same patient is purely coincidence than anything else.
This is a summary. 14-year-old male child born out of non-consanguineous marriage and who is a known case of G6PD deficiency with global developmental delay. In serious onset, gradually progressive pure motor, symmetrical weakness since 3 years of age, predominantly involving proximal muscles of both upper and lower limbs, with thinning of muscles and calf hypertrophy, with positive family history and without any cranial nerve, no sensory, no autonomic disturbances, no cognitive disturbances. We would localize it to mainly to muscle in view of pure motor element quadriparesis with calf hypertrophy, which is more suggestive of a muscular dystrophy. We would like to place it in Duchenne's first, and LGMD2B, which is a dysferrinopathy, which also had all these features of calf hypertrophy, proximal muscle weakness, along with same genetic linkage. And down the list, we want to place congenital myopathy and metabolic myopathy at the later end.
Moment the history of hypertrophy comes, certain details will flash to a clinician. It could be a sarcoglycanopathy, it could be DMD, it could be a central core disease, it could be central nuclear disease or a point-based disease. We have to very carefully discover what it could be possibilities. If there is early diaphragmatic involvement or respiratory involvement, we think of point-based. If there are a lot of features of contracture, central involvement, seizures, we think of congenital muscular dystrophies. If it is a flappy infantile syndrome, where there is no achievement of neck control, then we think of congenital myopathies. And if the pattern is very commonly a DMD pattern with a Gowan sign or tripods, and we think of Duchenne's muscular dystrophy. If it is the second decade, we think of Duchenne's muscular dystrophy. That is how we try to deduce as a clinician what could be the possible differential diagnosis. That is why this slide is important for us.
Coming to examination, vitals are all normal. Here we concentrated on respiratory rate to see the pattern of the breathing, whether it is a thoraco-abdominal or any paradoxical breathing, whereas respiratory involvement is more common in anthropometry measurements were all normal. On head to toe examination, we found child is having pectus excavatum with protuberant abdomen. Thinning of all muscles were noted with bilateral calf muscle hypertrophy and scoliosis with exaggerated lumbar lordosis was there, which is secondary to hip girdle muscle weakness and paravertebral muscle weakness, which is common in muscular dystrophies. There is a dynamic contraction of bilateral ankles, and there is no evidence of orthogyropsis congenita, which is a commonest symptom in childhood SMA and adult SMA, and also in some congenital muscular dystrophies. However, scalp, head, eyes, dental hygiene, skin, nails, genital were all normal. There are no evidence of any neurocutaneous markers and no facial dysmorphism. This is to rule out any congenital muscular dystrophies and Fukuyama congenital muscular dystrophy and Walkenberg dystrophies and muscle eye brain diseases. CNS examination, there is intellectual delay with cranial nerves all intact and normal. Coming to motor examination, on examination of the bulk, child found to have infraspinatus, supraspinatus and deltoid hypertrophy with wasting of thigh, forearm and arm muscles with no fasciculations. On palpation, muscles found to be firm with no tenderness and hypotonia is noted on the limbs. And now power examination, we found proximal muscle weakness more compared to the distal muscle weakness with power of 3/5 in all joints. And reflexes were diminished in all the limbs except bilateral ankles were preserved because in DMD ankle reflex is the one which is preserved till the last.
As clinicians, for us, pattern becomes extremely important. What is the pattern of muscle involvement? So if you have vastus lateralis hypertrophy, gastrocnemius hypertrophy, deltoid hypertrophy, and infraspinatus hypertrophy, that almost gives us a diagnosis of DMD. So what is the pattern of flow? Is it a pelvic girdle pattern? Is it a distal pattern? Is it a craniolumbar pattern? Is it a upper limb pattern? That becomes extremely important. And reflexes to tell for the heterogeneous curve pattern that what we have here. So if ankle is preserved, the relation is in DMD. So if ankle is intact and you have a calf hypertrophy kid, we are most likely dealing with Duchenne's muscular dystrophy. That is how we go with the clinical assessment. So the pattern recognition is very important for all clinicians so that we tend to come to a very good conclusion of the clinical case. We have two signs here, Gowan sign and idling gait. This is not the patient photograph because obviously we cannot put it. So Gowan sign is basically child will get up from by himself because he has got a lot of difficulty medication, so that he has to climb on himself to get up from the squatting position. And in idling gait, because of this is also called lurching gait. See here because of pelvic girdle weakness, you know the very well over the pendulum sign that they should lurch on both sides when they walk. So the moment patient walks in like this to our OPD, we almost make a spot diagnosis of a proximal muscle weakness. It could be a radiculopathy, plexopathy or a muscle disease. But we are certain that there is an element of proximal muscle that is getting involved. That our clinical examination becomes much more focused as we go with the case.
Largely, we couldn't able to assess both the Gower sign and Wedling sign as the patient is bedbound since almost 2 years. So this is only for the representative purpose, and we found a pseudo hypertrophy of both the calf muscles. However, sensory, cerebellar, and other systemic examinations were within normal limits. Coming to the summary, this is a 14-year-old male child who is a known case of G6PD deficiency and global developmental delay presented with insidious onset of progressive symmetrical proximal muscle weakness at 3 years of age, with the progressive weakness. On examination, we found that we have symmetrical proximal muscle weakness with calf hypertrophy and thinning of other muscles, with exaggerated lordosis and scoliosis, with bilateral ankle dynamic contractures, with no other system involvement. We probably want to put a diagnosis as X-linked muscular dystrophy, that is Duchenne muscular dystrophy, with the family history confining only to 2 male children in 1 generation. course is initially child was evaluated at local hospital and in view of elevated CK he was referred to tertiary care center where he was undergone this genetic test MLPA diagnosed to have deletions in exon 61 in DMD gene. This is a brief marriage.
I'll just sum it up because of the interest of time. So we have steroids as well as a lot of gene therapies. So steroids we given at 0.75 per kg of dose for DMD, and I can go to the next slide. And basically it is to reduce the inflammation and to prolong the survival. And gene therapy we know very well a lot of things like adalivin and a lot of drugs are being tried. So whatever it is, it's all about the exon skipping and antisense cellular related gene. So we have certain hotspots in our exons, and that will be tried to target in our various therapies. And physical therapies are actually equally important. And I'll open it for chairpersons for any discussion further. Yes, ma'am, please. Yes, ma'am. Yes, ma'am. Yes, yes.
Okay, as a clinician, you got a diagnosis from a reputed lab, CCMB said,
Yes.
there's the exon deletion. What next? You have talked about treatment.
Yes.
Now, what about the counseling?
Yes, ma'am.
As it is in your case, when there is a previous
History of.
history with another sister's child having same thing,
Exactly.
what was the counseling you provided?
Yes. See, this is where your role and our role becomes mutually inclusive. So because it is basically a holistic approach. So we are one spectrum. See, predominantly neurology in earlier days was all about making diagnosis and keeping the disease away. But now it is all about, counseling them, telling what can happen in the future, and what is a holistic approach what we are talking about. So here we try to incorporate a very good communication skill and a holistic approach. So we sat with the family, spoke to them what is the disease, and it is very important to the natural history of the disease because certain neurological disorders we don't know the natural course. And unfortunately for this, we know what can happen as a natural history. And the genetics can tell us what could be the severity of the disease. If you know, 70% of DMD is deletions, and around 30% can be insertions on point mutations. If it is deletion, the natural history is going to be more detrimental. If it is otherwise, it can be a little less. If it is a frame shift, again, it is whether it is in frame or out of frame. In frame is more likely to be severe, and out of frame is more likely to be less severe. Yes.
Counseling to the family.
Yes, ma'am. Counseling to the family is about.
We don't tell them about, it doesn't matter whether.
No. We need to give a little bit of gist what is happening to the kid because the genetic knowledge is also slightly important for attenders. Yes, ma'am, please.
In India, it's an X-linked disorder.
Yes.
We are a patriarchal society.
Exactly.
How do we counsel?
Yes. So
It is
counseling.
more than the deletion, missense, all that. Here you are conveying to a family
Yes.
that this child
Yes.
has got this problem from the mother's side.
Yes.
What do you think is because you are a psychology
I am a
person.
neurologist. I am a neurologist. Yeah.
Okay,
Yeah.
the psychology person, Chanda.
Hello. Yeah, so I think Annie is asking very pertinent question. I will skip the social part of it. As a clinician, I think both of them have presented the case very well. And I think after that, the only limitation I would say is that probably in the presentation there should have been a pedigree chart. Whatever was written over there, I think that's one thing that will link the clinical community with the genetic counselor. The moment the genetic counselor sees the pedigree, they will know what's the pattern of inheritance. They will know whether there is a possibility that somebody is an obligate carrier. Talking specifically about this family, you said that mother and her sister both had affected children, which means that there is an X-linked recessive pattern. And because both of them would have been carriers, so that means that the disease or the mutation would have occurred much earlier. And hence, any other family member would also need to undergo the genetic testing, which will include maybe even sisters, children, or the other siblings which might be there. And I mean, that's what I think probably Dr. Annie wanted to indicate. Just one last point is that whenever these kind of situations arise, the communication is, really very, very sensitive. And that I'm sure that, clinical counselors, they would have done their job in that regard. So for me, the G6PD and the DMD coexistence is something which is probably of a research perspective, but it needs to be investigated because it's a common X chromosome which is exactly from mothers and sister. So why these two mutations or the disease causing mutations are getting it. But thank you for it. Yes.
Jaya, you're saying something? Okay. Good morning. I'm Dr. Lakshmi and from MDCRC Coimbatore. And again, Vice President of BGCI. So as Dr. Chandak rightly pointed out, our pedigree is so much essential.
I agree with you. The only reason why we intentionally omitted it because, see, many of the times, whatever the Mendel, we have a lot of respect for pedigree chart. We are not against it. But in this case, our pure point of view is to express from our clinical perspective how we deduce a case based on their pattern of involvement. Because you are all the masters of pedigree chart, genetics here. So our pure perspective as a clinician, we tend to go with how is the pattern of muscle involvement. That is why this the cases has got a lot of implications on the muscle pattern involvement. Because many of the times our make a diagnosis because although we know very well students have a lot of confusion regarding charts and drawing it and everything. So here our point of view is purely clinical. So how we look into a pattern of muscle involvement. Because in this case, each pattern has got a indicative or it heralds a disease. That is the only reason why that was intentionally omitted.
Understand that perfectly.
With lot of respect to your genetics and pedigree.
This is a genetic counseling conference. The way it would be good is to have the genetic counselor also along with you. And you have to work together as such. This pedigree is so important, and I'm saying this with close to around 15 years of experience in Duchenne. And when you said there was a sister again whose son was again affected. So generally what happens is you see all the muscle in perfect, all that is fine. And for such disorders which doesn't have a cure, there is no treatment. Generally the clinicians say, okay, this steroid, and they go away. No, it doesn't stop. We don't have a cure. It needs to be prevented. Which means you have to work with a genetic counselor, have the pedigree put very clearly, tell them the mother has to have a carrier testing done, of course with her consent, all the female relatives are daughters. So this is so crucial. We don't have a cure, let's understand. And we have mothers having 4 and 5 children affected with Duchenne. Yes, we understand patterns. The muscle, if you see, lots of which the clinicians have said as Duchenne has ended up in LGMD 2E and various other things. So the clinician has a big role here to sit with the counselor, draw the pedigree, understand, yes, it's excellent. Lots of time it's sporadic again, there's no family history at all. But still you do the carrier testing, and the next generation, it needs to be prevented. We cannot have more and more of things. So I really urge the clinical group.
I truly appreciate that because
counselors. Yes.
exactly. Association is more important than dissociation. Yeah. Another thing, I really appreciate that point, sir, because it's EM approach is very important. Because in medical field, a lot of subspecialties and specialties are associated. We have to associate ourselves. That's what is most important. I appreciate Dr. Deepa Bhatti here because she's our genetic person, Jason, and she always makes a point to call us and ask a history. And we always mutually see a patient. That's why, she's one of the organizers today. I appreciate her because that is how everything has to work. And we have to associate ourselves. A clinician's job isn't 10 minutes temperature touches normal and diseases are removed. That is a saying like that. So that has to implement in our society as well. Really appreciate that. Thank you, sir.
Thank you, Dr. Shastra and Andrea.
Sure.
Thank you, Dr.
Thank you, Dr. Shastra and Andrea. Due to the time constraint, we have to move to the next session on thalassemia, written by Dr. Patani and Namrata.
Let's to introduce the speakers in this session. Dr. Namrata, transfusion medicine from say with one that's BI for CMR and she has received national award from CMR for
Thank you, sir.
and I think another speaker this
Thank you. Good morning, one and all. I'm Namrata. And first of all, we'd like to thank the organizers for this opportunity. So let me start by presenting the clinical details of the case under discussion. We're also requesting the father of the patient. He's joining us on the days now to share with us his experiences.
Yes.
So I'll just start with some technical glitch.
Yeah,
So in,
please go ahead with the case.
The case under discussion today is a 19-year-old male. He resides in Mysore. He is currently pursuing his graduation towards bachelor's in business administration. His parents are both graduates, so they're reliable informants for us. And he was diagnosed at 3 months of age. Next slide, please. So the age of presentation was at 3 months of age. So since it was a very long time ago, a lot of the history is actually lost. So we have very little history as to the presenting complaints and the mode of diagnosis. All we know is that he presented at 3 months of age with vomiting, fever, and failure to thrive. He was diagnosed elsewhere with hemoglobin electrophoresis as a case of beta thalassemia. Next slide, please. So the current age of the child is 19 years. There is no significant family history. He's born of a non-consanguineous marriage. So yes, this is the pedigree chart. My apologies that we don't have a second generation pedigree chart, but he's 19 years old. He has a brother who is 10 years old. His father has 3 other male siblings, all of whose children are clinically normal. His mother has 4 siblings, and all their children are clinically normal as well. So there is absolutely no clinical history which is significant. Currently, his hemoglobin is maintained between 6.3 grams per deciliter to 7.2, at an average of 6.9 grams per deciliter. So that's his usual pre-transfusion HB every time he turns up for a transfusion. Serologically, HIV, HPCV, and HCV continue to be negative. His serum ferritin, which was last done in 2017, is elevated at 3,420 milligram per deciliter. His blood group is B positive. So currently, he's on iron chelation therapy with Desirox. He underwent splenectomy in 2015. His age of first transfusion is, of course, at 3 months. And currently, he receives about 1 unit of leukodepleted PRBCs every 21 days. And by ARMS PCR, this was the mutation that was detected. So our diagnosis is, of course, keeping in mind the elevated serum ferritin and his low pre-transfusion hemoglobin, this for us is the final diagnosis, the suboptimally managed case of beta thalassemia. So I'm hand it over to Dr. Pallavi now to lead the discussion further. Thank you.
Very good morning to one and all. Thanks to the organizers for giving us an opportunity to present this case. We at JSS, we are managing around 75 kids of thalassemia every month coming for the routine blood transfusion. And mainly the management depends on the correction of the anemia because they are congenital hemolytic anemias. So we take care of them by giving regular blood transfusions. And then the other challenging part to us is the management of iron overload, where they are treated with chelating agents. And so we have with us the patient father here. He is Mr. Azam. So he would share his experience. And we all know thalassemia is an autosomal recessive. And for us, the genetic counseling is very important because when the parents come with the kids, it's very difficult for us to convince them to have a genetic counseling and go for genetic testing. Because here, the mother was very young when she came to us, and she has a second kid who's absolutely normal. But still, we convinced her to go for genetic counseling, but she has not undergone genetic testing because she said she's not going for any other conceiving thing. And as we got the history, no other kids in the family are affected, but still we would recommend all the other siblings to have the genetic testing done.
Can I just? Yeah.
Yes.
So nicely presented, first of all, but I would still say that this was a little bit, confusing. The child you said was 19-year-old. The splenectomy was done in 2005.
No, 15. That was
15. Okay, I'm sorry. I just, okay, so that's fine. Um, I mean, you have done a good job, but yet I would have really loved to have seen, uh, a clinical profile, particularly hematological profile, and secondly, an HPLC picture
Yes.
of the child, the SIP, as well as the parents. Because you might have got this case as by chance, but many a time, whenever you want to establish anything, it's the first line of investigation which is important. Because again, I'm no more a clinician, but I think a case of hemolytic anemia, first you will investigate in that
Yes.
particular
Sir,
way.
the case
Let me
was-
just finish. I'll just 1 or 2 minutes.
Yes.
Yeah. So probably, like looking at the HPLC profile of the child, if you suspect anything of that kind. And obviously, since you with the HPLC picture, you have an idea. So you know that the parents are obligate carriers. I mean, and immediately, I don't know whether you looked at the consanguinity or not, because I didn't find any sign in the pedigree. So I'm not sure whether it was consanguineous or not. Lastly, regarding the mutation, you got this genetic testing done on your own, or did you contact somebody in the hospital to suggest this?
No, sir. It was done actually as a part of a research for all the kids. So that's where we are getting all the kits done. But previously, it was all on the research basis on which we did.
That's fine. May I just I think that will be good for the audience to know, given such a family.
So yes, sir. Because it is an autosomal recessive, we would say what is the disease per se, first and foremost. What is the chances of getting the disease? That is, 25% of their kids would get the disease, 25% will be normal, and 50% of their kids will be, carriers. So we would suggest them to get the genetic testing done.
I would just like to elaborate on this particular point, although she doesn't mean that way. But if we say this is a problem I have faced in my career also, normally, this is the probability for individual pregnancy. This is not to say that if a family has 4 children, then if the first child is affected, like in this family, then all the next 3 will be normal, 1 carrier and 2 normals. I'm not saying that this audience, I'm sure, is smart enough to understand this, but usually that's the gap that happens between clinician and the patients, and that's where just the previous discussion which happened, that the importance of genetic counselor comes in that particular perspective. I'm sure you would have advised about other things of proper care and
Yes.
testing of the next child and all.
Yes, sir.
Thank you.
Definitely.
Thanks very much. I mean, it's open to questions. You people want to say anything?
Can you please introduce the patient family?
Yes.
Good morning, everybody. This is Azam Jafar. Can you hear? This is Azam Jafar. Actually, my first son, actually, I mean, we didn't have any sort of experience in our own relatives. This thing can ever happen to anybody. The first time at the age of 3, my child started vomiting. I mean, continuous vomiting happened. So we were very much intense, like, why this happening? So we went for doctors a couple of times. They said that the child might have some digesting problems, something like that. But later on, the blood testing was done, and finally it was cleared that, I mean, he was carrying thalassemia. I mean, it was shocking for us. Like, never in our family, I mean, we had this kind of experience. So we were very desperate. Like, I mean, we ran here and there. Finally, I mean, we've been advised to go to St. John's Hospital, Bangalore. I mean, which was first taken care, I mean, for the first blood transfusion of the son. So then things started going on. I mean, from hospital to hospital. So the whole 3 to 4 years we used to go to Bangalore. It was a long journey, and nobody from our family's relatives had this kind of experience, like how this happened. I mean, never carried this kind of disease in our whole family. So it's a new experience for us. Sometimes it's very sad to share, like, I mean, when we felt like committing suicide, like, I mean, we're so desperate and so downfallen, like. And thanks to Allah, I mean, things started coming up. Transfusion started, I mean, holding my son's hand, and things becoming normal later on. So from then, by the grace of Allah, in Mysore, things started working for us. So we got transfusion in other hospitals, Vikram Hospital, the second hospital that helped us for a long time, 3 to 4 years, and then that hospital got shut down. And finally, JSS, I mean, we got into Dr. Pallavi. She took very good care. I mean, she started, helping us with this transfusion in a regular way. So then we parents, I mean, just I'm sharing some very close thing of my family. About our second son, I mean, we had a scare, like, I mean, even our second son may carry this kind of things. So, I mean, we were advised by some doctors, like, we need to go for some tests, some other tests. So that will clear us that the pregnancy is again carrying that same disease. So by the thanks of Allah, I mean, the second time, it was clear that my second son was not carrying anything. So it was a very happy sign for us, like when we had a second baby, a baby boy. Alhamdulillah, now he's 10 years old, healthy, fine, fit, everything. And even the elder one, like now he's around 19 years, he's doing his BBA. Alhamdulillah, he's doing very fine in his college. I mean, he's grown up. Things are going fine. And the corner of our heart still, I mean, we dream that something, a very concrete thing comes up, like, I mean, it cures him forever. That's the only prayers we are doing, that, I mean, things will happen good for my child. Thank you so much, doctor.
Thank you very much. Sir, I would like to share my experience because I've been always interacting with them. So we have a lot of difficulties convincing the patients. So we send to the counselors or the psychiatric because they come to us every 21 days for the blood transfusion. So a lot of stress is there, both on the kid as well as from the parent. So how would you counsel them psychologically, both parents as well as kid? But
So as a part of the genetic counseling or even supporting the family, we have two approaches over here. One is the prevention approach, another one is the intervention approach or the supportive approach. Because both the person or the child who is infected and the family is under a severe psychosocial stress and also economical stress which they are undergoing. So it is not easy to go on convincing oneself to understand that, okay, it is because of genes, it is because of genes, and it is because of genes. It's like carrying a bomb with one person all the time, which we are not able to put it out. So you can imagine how it feels to carry a bomb and you don't have any ways to put it out. So how stressful that can be. And if you have to manage that, you have to shell out a lot of money, which again makes economic burden on the person. So it is not only a heavy on the pocket, but it is also emotionally a burdensome thing. So it is a complete hand-holding which has to happen throughout the process. It's not like our role gets over once the diagnosis is made and we just put the blame on the genes and it's done. No, it's not, it doesn't happen like that. So even across the process of every time they are coming for the transfusion, so we have to put across the positives that is happening with the child, the positive developments that is happening with the child, and we have to go on adding on to the coping strategies of the parents or the caregivers also. And it is not like every time we are trying to, and what happens is, as we are much aware about what all can happen across the lifespan times. So what has to be expected at the childhood with this particular disorder? What has to be expected at the puberty? How this would manifest, and what and all we need to expect. So these are the things which we are much aware. How to put it across to them so that we can facilitate, and they are aware and they would expect, okay, this change, yes, it is related to that. So and we are ready to handle it. So that sense itself will strengthen the person and also help them to cope, and their resilience is built so that they can see. There is absolutely, all of us know that the preventive medicine part is slightly less to other things. So they have to bear with it and they have to live with it. So we have to facilitate living with the disorder more, apart from the prevention also. Thank you.
how frequently would you like to meet them, sir?
Every time. Every time they come for the transfusion.
Every month?
Every time they come for the
Thank you.
So even we may have a very brief discussion with them, but we want to meet them every time they come for the transfusion.
This is to question to Dr. Namrata. In rare diseases or genetic conditions having long-term progressive diseases or long-term treatment protocol, we have seen in other hospitals challenges with migration or transition from pediatric to adult.
Yes.
How do you manage here? Do you have any process? Because we have seen the other day I was in another corporate hospital. Because of the policy, they just given it to adult patient overnight, while pediatric was managing from last 14 years. And there is a lot of issues both from the parent side, also in management and understanding from the medical fraternity on the complexity of the diseases. How do you manage those conditions here?
So right now, our pediatric department is handling all the thalassemia up to the age of 21. We have not transferred the patient to any adult care. So we are, as a part of the team, pediatrics itself is managing the thalassemia kids. I think we should have a clear-cut policy, as you said, because we don't have any chart or schedule put up. So when to counsel the patients at what age, transition from pediatric to adult cases. So we are working on it, and we would like to have support and do it.
Thank you.
Yes.
I think Purnima madam may be aware that there is a whole thalassemia foundation which has come up in Hyderabad, and it is led by a father who has two daughters with thalassemia. And one of the daughter is a clinical psychologist, and she has done the PsyD in clinical psychology, and she is running the whole thing now, supporting all the parents and also the child.
So genetic prenatal counseling is very important for these parents, but prenatal carrier testing is still not very routine in our setup. So we will try to make sure that we'll have more and more of prenatal. Yes.
One more point I would like to add. Yeah, that for those who can afford it, you may also tell them that now there is pre-implantation diagnosis where they can do IVF and test and implant a normal embryo.
Yes,
and also for those who have a young affected child, during pre-implantation, you can select a child which will have the same HLA matching for a stem cell transplant to cure their earlier child. All this is available now in India.
Yeah, depending on the affordability.
Yeah,
Because
that is
most
the
of
main
the
thing.
cases,
That is the main.
those who come to our hospital are below socioeconomic status. So it's,
There is a CSR.
yes,
Yeah, Chandak has to say, but CSR is there, where even bone marrow transplant for low socioeconomic group is being looked after by 5 companies, including Tata's.
Okay. Yes, ma'am, we are aware, but they ask for 100% match.
That's what she's saying, no? That's what she's saying.
So, yeah, I mean, I'm sorry, like, rest of time we have to stop this.
Excuse me, Dr. Chandak, just one compliment as well as comment I would like to do. Just 1 minute. I'm Dr. Chitra Thakur. I belong to Wadia Children's Hospital. I'm telling you the history when in 1985 I first detected a thalassemia major diagnosis. In 1985, that was my first job. I used to cry. We have heard a patient, we have heard a clinician, we have heard genetic counselors, and all of you are sitting here. So at our hospital, I think Dr. Rao is somewhere who knows Dr. Merchant, pediatrician. Okay, so he started a 3-pronged system. It is community awareness. Second was prenatal diagnosis, and third was intervention. And in these 3-pronged project, we work. I worked for 30 years at Wadia Hospital, and then I retired. But what is important here is, Dr. Pallavi, you have a hospital, you have got a big base. All of us, we know that there is a problem in diagnosis, there is a problem in prevention, and there is a problem in intervention also. And everywhere you require definitely a counselor or a genetic counselor. So every situation we are going to handle problems. What Dr. Chandak said, that some people think first child is thalassemia major, other 3 are not going to be. But that is old story now. But our country, the education system is so low. And in that, a person who has not seen a school also, to whom you have to explain what is deletion and what is mutation is difficult. What I want to add and just suggest to Dr. Pallavi, it is a hospital base. You are at big and good hands. So we must try something like a three-pronged project, and that gives success.
Okay, thank you. Thank you very much. I'll just take 2 minutes to summarize this quickly that I think this is no brainer, regarding beta thalassemia. I think this audience is full of that kind of experience. I'll just give 2 minutes to what I felt while, looking at these two presentations. Unfortunately, I have to leave for some other work or so. I think that counseling is a big word, and this has to be split up in several components. What we are expecting, as I understood it, that we are expecting the clinician to be doing everything. Right from the moment that the patient walks in, they have to take history, they have to send for blood tests, they have to first do the clinical counseling, then send it to genetic testing, then genetic counseling, and then also what Dr. Sirol and others talked about, the psychosocial or a social counseling. Now, this is a massive thing. I don't think that neither a genetic counselor, nor a clinical counselor, nor a social counselor all these roles can be amalgamated in one individual. I think the point that I wish to communicate is that it has to be taken up as a combination of all these different expertises. Now, a clinician cannot actually, talk about the economics of this and explain that how you will get various things, how much it is going to cost, and every month when you come, there will be something. So it has to be a team effort. I think one of the major components which was missing was this genetic counseling, and which I think is a big achievement which has happened. But when we work together, then it's the sensitivity of each other's emotions, each other's sentiments that becomes very important. And India is a country of wonderful opportunities, but we also have a bad history of not being able to work together. So I hope that this meeting will help us. Well, I didn't say this for clap, but I mean, this is really the truth. I have worked for so many years. We cannot work together. At least for this kind of situations, it is important that we lower our ego down and work so that ultimately the common man, the society actually benefits. So thank you very much. I'm really apologetic that I can't say more on this, but it has been my privilege to be here. Thank you very much. And I will urge the younger audience to kindly ask questions. It's not a teaching session. So all those sitting on the back benches don't enjoy, only the back benching, but also ask questions. Thank you very much.
Thank you very much, sir. It was great having you with us. Thank you once again.
I request Dr. Moha to introduce our next speaker. Please stick on to the time.
Hello, it's my privilege to introduce the next speakers. It's Dr. Akshaya SB. I request her to come to the dais. She's a postgraduate in the Department of Pediatrics at JSS Medical College and Hospital here. And she's an MBBS from Amrita Institute of Medical Sciences, Kochi. Her interest lies in neonatology. Her career highlights are being member of Indian Academy of Pediatrics. I welcome Dr. Akshaya. Our next speaker is Dr. Sushma. She's an assistant professor in the Department of Pediatrics at JSS Medical College. She is also a member of Indian Academy of Pediatrics and member of National Neonatology Forum. Her academics achievements are fellowship in neonatology from Rajiv Gandhi University, postgraduate degree in pediatrics from Kempegowda Institute of Medical Sciences, Bangalore, and she has been working as a neonatologist for last 10 years. In the interest of time, I am skipping the later part. I welcome both.
Good morning, everyone. Thank you each and everyone for giving us this opportunity to present in this international platform. Today I'm going to present a case report. This is Mrs. Archana with a child of 12 months now, and she'll be talking soon, hopefully. Today I'm going to talk about baby of terminally aged baby. Baby was delivered on May 13 at 7:30 p.m. by LSCS in our outside hospital. Baby apparently cried immediately after birth and was shifted to mother's side, and breastfeeding was initiated within 1 hour of. A baby was born to a second-degree consanguineously married couple, with the mother being 23 years at the time of pregnancy, and hypothyroidism was detected at third month of pregnancy. Regular antenatal visits were done and was uneventful. Maternal pedigree. Baby was born out of a second-degree consanguineous marriage. On the mother's side, like history was uneventful, no history of any sibling deaths, or no other significant family history. Father was also born out of a second-degree consanguineous marriage, and his elder brother, the sibling died immediately, like child died immediately after birth. The cause of which is not known. It was the baby was a female baby. This baby was shifted to our hospital from outside hospital on day 3 of life in view of lethargy and vomiting. At admission, the heart rate was 150 beats per minute, respiratory rate of 42, saturation was 100% in room air, BP was normal, CBG was 96 milligram per deciliter, and normal heart sounds were heard, bilateral air entry was equal, no organomegaly was noted. Baby was lethargic and was responding only to painful stimuli, that is, limb movements were there during for investigations. After that, baby was, soon after the baby came to the hospital, baby was kept NBM and was started initially on IV fluids, and we have sent for investigations which revealed respiratory alkalosis, no sepsis, and electrolytes were normal. CSF analysis was within normal limits, ultrasound training was normal. Then later on, blood urea nitrogen run was low, 15, and ammonia and lactate we had sent suspecting metabolic disorder, where ammonia was found to be more than 1,400 and lactate within normal limits. So with the possibility of metabolic disorder in mind, we have started the baby on peritoneal dialysis in view of high ammonia levels, and sodium benzoate and arginine was started. Baby was intubated for 2 days in view of poor respiratory effort. As there was a serial decrease in ammonia levels, peritoneal dialysis was stopped after 48 hours.
Good morning, everybody. I'm one of the team members of this neonatology team which handled this child. And when this baby came to us, it was day 3 of life, and a well-born child which had no issues in the initial 48 hours. Baby was fed well according to the mother, and she was on the verge of discharge by day 3 of life. And day 3 in the morning, mother noticed that the baby was totally lethargic, and the baby did not feed well as usual in the last 48 hours. And that's when they panicked, and the child was referred to us with the following history. Since us as a referral unit, we received this child, and when we received this child, although the vitals were normal, we could see that the baby was totally lethargic, not responding to any kind of touch or sound, or was only responding only to the painful stimuli when we started doing investigations. And this baby, when we did the case, initially took up this day 3 of life, baby was totally normal, sudden deterioration, and that was the indication we thought for metabolic, which we were thinking of metabolic. And as a routine thing, we do send for sepsis workup. We did the septic workup, which was totally negative. And when we got the ammonia levels, it was beyond 1,000, which was a bit scary with metabolic, with our respiratory alkalosis, because we were thinking of brain damage here. So PD was initiated immediately, and once the ammonia levels started coming down by within 48 hours, that's when we started initiating feeds to the mother. We sent the metabolic workup completely. Child was counseled by our genetic counselor, clinical genetic counselor, and then the further investigations were sent. Parallelly, we did start off with our feeds. Baby was initiated with feeds. But with the suspicion with respiratory alkalosis, hyperammonemia, blood urea nitrogen was low. With all the suspicion, we did think of urea cycle defect, and we tried to get some supplements, protein-free supplements, since it's not available in Mysore, tried to get from outside to a certain extent. And once ammonia levels were low, gradually this baby was introduced to protein-free supplements also, along with some amount of EBM also, because we wanted the baby to go on mother's milk also, because of the benefits. And gradually, the child was discharged on day 13 of life. Although MRI showed some abnormality, we did keep the baby on monitoring, and on OPD basis, all the ammonia levels started normalizing. And presently, the baby is in front of you, having slight mild developmental delay, which is still okay. She's presently on physiotherapy, and she's doing pretty well on physiotherapy and occupational therapy. That we are to
a newborn screening program. Now, in this case, that's what you have to tell counselors, people sitting here, that why is a newborn screening program essential, and what is your newborn screening program? And in this case, do you need an extended newborn screening?
Yes.
As a neonatologist, I think that's the message you have to convey to us.
As in our hospital, for all inborn babies on day 3 of life, we do send newborn screening, which covers 7 disorders. As of now, we have not started the extended newborn screening program, but this child was referred to us on day 3 of life. So newborn screening was not sent initially. But with these reports, we decided, we counseled the mother and sent for the extended metabolic screening directly. We didn't send for the initial basic metabolic screening, which covers only 7 disorders, but we sent for TMS and urine GCMS, which gave us, I think, and following that, DNA testing, genetic testing also was done, and it was decided it's arthrosuccinic aciduria.
Can I just ask you the question? So when you say the newborn screening, what Dr. Ane asked, and you said 7 disorders. None of it includes the urea cycle disorder. Okay, that is the first thing. So as a neonatologist, what was told, that was first thing, my concern. Even the urine given for the, the non-specific 140 disorder by GCMS would have first thing given you the arginosuccinic acid high or urea cycle defect of whatever 5 disorders. I am wondering why you had to go at the pathogenic variant level for the diagnosis, when the GCMS is the confirmatory diagnosis. And in our country, when it is about, socioeconomic strata, poor people not affording, when they are coming, I think that should be the first thing we should take up for confirmatory. Second thing is, was it because she is the young, I think maybe having the first baby, and how you are monitoring now? Do you monitor biomarkers in this case? Because it's a very simple thing. So biomarkers are not there, the neurodevelopmental outcome will be very good.
This child, madam, initially for all the babies, for this child, TMS and urine GMS was sent initially. Yes, DNA report, I do agree. Urine GCMS showed increased citrulline levels, very increased citrulline levels even in this child. DNA report was sent for the out of curiosity and out of interest with our this one. For our academic interest.
It would be important for future pregnancy and prenatal monitoring, not the curiosity.
No, it is mainly because mother, we had a diagnosis already in hand. But out of academic interest, we wanted to get a DNA test also, even though initially they were a little bit hesitant about it. We convinced them, and to a certain extent, madam, out of academic interest and for her.
It's a young girl who's planning other children. So it is a mandatory thing for you to know. It's sporadic second mutation. It is a carrier thing in the parents. And there is a lot of homozygosity, and you have to counsel her now that what about the second child? So it is not out of curiosity. This is out of academic need. Am I right, Prasanna?
Totally agree with you, madam. In this child, what happened is like mother was a little bit, both the parents were a little bit hesitant because of the financial issues. So out of academic interest and convincing them later, the genetic test was done. And the mother, presently we are following it up with ammonia levels is being done. Initially it was done every 15 days. And since it is normalized and it is in the normal levels for past few months, it's being done every month or bi-monthly once. And since she is not from Mysore, she's coming up from far off places. At least 2 months once she do comes for visit. But here I am happy to also tell you people that once the bridging was done between, once she was in NICU, the bridging was done with our clinical counselor and with the help of our biochemistry department, also with all the tests, everything done, and once diagnosis was done, and she's been regularly following up with the genetic counselor, and in fact, our genetic counselor is her first call for whatever problem she goes to. And that's the rapport she's developed with her, and that is a good sign for us also, because anything we get to know is through our genetic counselor. She's been counseling her regularly, and once the baby for regular workup regarding growth and develop, she does comes to pediatric department.
One sec. I second with Dr. Annie Hassan. See, when a parent comes to you or a patient comes to you, I think as a clinician, your first priority of interest is the patient's immediate goal and the long-term goal to suggest a family what is going to happen and what are the hopes and what journey the parent can take. Then your secondary interest can be academic or your personal is what I
I
feel.
totally agree with you theoretically and ideal situation. I totally agree with you. But we also need to think practically, because many times what happens once we tell the parents there is a genetic issue involved, many times they back up. They just back out of all investigations. Yes, with the genetic counseling in picture, it has been a lot of help for us, because many times with just one session, they do not agree for anything. And once we go for one step ahead and some tests are done and we already know the diagnosis, further step to take for them, it is quite a task. I totally agree with ideal situation. Yes, it has to be done. But I think all of you might be aware, even with our setup, many of them just back out, because it is still, most of the villages, it is still a taboo. And yes, we are trying our best to overcome this. And whenever possible, we are trying to get it done. Even in fact, many times we do, our biochemistry has been helpful even financially also.
Thank you, and very well presented case. I have two queries, I'd say. One is that you said since the child is not from Mysore and has to travel bi-monthly or something you said. So what is her long-term management routine? That is one thing. And second, is there a way to work out with local, clinician there, so that in long term, because this is a lifelong management, I suppose, that could be their journey could be, made a little bit easier maybe. So is any effort taken in that direction? And secondly, just one point to be added, when you said that the patients back up when genetic counseling is advised to them, I think if it is pressed upon them that it is for their benefit, for their future planning and all that, do they still back up? Do the
Yes.
Okay,
Out of 100%, at least 50% back out. Yes, many times we have tried to counsel them. Many times we have even called the family members. And yes, some after so many counseling sessions do agree for it. But still, there are a lot of people who back out of genetic testing.
Okay.
Counseling, they are coming, but testing, they back.
Okay, maybe what is the provision of pre-testing counseling? Because there should be a provision of pre-testing counseling as well, where just to make aware of for the patients, because 90% of the patients would not be aware of the benefits of genetic counseling. And if at that stage the counseling, I don't know how it works here, but most places.
I'll just tell you what is our protocol in our NICU as the 40-bedded NICU, which is a reference center. So whenever we have similar children with where we do have some kind of suspicion of metabolic disorder, the first call goes to the clinical genetist, and she comes in. There, both the pediatrician or the neonatologist who's handling the child and the clinical genetist, both of us sit together, and detailed history is taken again by her. since she takes it according to her, she takes completely again with both mother and father.
Parking
And that's when the bridging
phone
starts
ಮಾಡಿ
between
ನಾನು ಪಾರ್ಕಿಂಗ್
the
ಏರಿಯಾಕ್ಕೆ ಬಂದು
transfer
ಅವ್ರನ್ನ
from
ಪಿಕ್ ಮಾಡ್ತೀನಿ
parent
ಮನೆ
to
ಬರ್ತಾ ಇದ್ದಲ್ಲ
that
ಅಲ್ಲ
person starts. And she keeps coming in and meeting her every now and then so that the rapport is
ಬಂದು
built up.
ಕರ್ಕೊಂಡು ಹೋಗ್ತೀನಿ
And once the second or third setting is built up, and the initial screening normally we do here is an ABG, ammonia levels, and lactate levels as a basic investigation. Once we get his basic investigations and the clinical counselor also is in a good rapport with the mother, then she starts counseling them or whichever further genetic test has to be done. That is the protocol we are following as of now here.
And what about the long-term management?
Long-term, yes. If they are somewhere outside Mysore, normally what do? We do have some local doctors who are in contact with us, and we tell these parents when they go back to any small. These parents normally what happens once you tell them they have developmental delay or some genetic issues, even they are in a panic mode that even a small cough and cold they might start panicking. So what normally the protocol is, they give a call either to the doctor or to the NICU. NICU number is available to them around the clock. So 24/7 NICU landline numbers are available. They do call them. Their junior resident or a senior resident is always available. And they receive the call and then they direct them accordingly. Take the history and direct. If it is something which can be handled locally, they direct them to the local doctor. Or if they feel something serious is there, they ask them to visit here.
Okay.
Just a last comment. India being definitely, economically weaker, and we as an NGO, 99% of the families approaches are from lower background only, because people who have money, who are educated, don't come to us because they find their own way. We have experience. Yes, whatever happens in the clinicals, yes, there is a resistance, but we also have to explore other possibilities, and I think that the teamwork can make a difference in reducing the percentage, and we are very much successful in that, because it is only how well you put it across, how do you convince, and what are the risks, and long term many families do agree in spite of being the local economy segment. Once they convince, believe me, irrespective of the earning pattern, we have families successfully raised funds and taken care of their children, because for every family, children becomes their world and is their only world. So I feel you should not give up thinking that it's economically lower segment family. I think a teamwork can definitely make. And sometimes non-clinical side counseling or meeting also helps a lot, is what I feel. Thank you.
I totally agree, sir. In JSS, yes, 4-5 years back, we didn't have our testing here locally. So it was difficult for us to help them out in a certain way. But yes, our Department of Biochemistry has come up with the genetic testing of late with karyotyping, TMS and GCMS. We have started our own local. So whenever possible, they are also helping us out whenever patients are not affordable or anything. They are trying to help us. They are trying to help us. And even through some funding also, we are trying to get the testing done as much as possible.
Also, another part of it is whether such patients are being connected with similar patient groups, patient advocacy groups or patient support groups, because that usually gives a lot of help, both clinically and also, interacting with parents who have had similar children, and just to know about their growth pattern and everything, that has actually been proven to do a lot of help and moral support to the parents.
So that part we are actually doing with Down syndrome children. In that part we have started. Since our genetic department is also and evolving gradually, and probably we'll take your suggestion and try to link them up with other kids. Yes, with Down syndrome children, since more children are there, we are teamed them up together. We have linked them to each other.
Okay,
and
because
they call them on the same day, so that they also are they meet and they get to know each other also.
Yeah, that would be help. Even the various financial sources also can be arranged in that cases, and moral and many other sort of support could be got. And IEM especially, they do have very active support groups around.
So just to quickly step in the genetic counselor's perspective, all what is discussed here this could be done, that could be done, support group, talking to the patient, psychological perspective. Genetic counselor can support the clinical team in all these aspects. Job very well done. Even now, a good example is that when the patient was a little, I mean, the young boy was a little restless, our own genetic counselor took the baby with her and she was taking care of the family. So assured, genetic counselors can gel well with the families. Given the clinicians' busyness, we can definitely help and that rapport can do wonders. Thank you so much. Thank you, Pooja, for taking care of the patients.
If she wants to, I think we're good. Yeah, the patient can, we can hear the story maybe. If she wants to share. Otherwise, it's fine.
नमस्कार, अभी मैं आप लोगों की बात सबकी सुन रहा था, अभी थैलीसीमिया का भी लेक्चर सुना और अभी जो ये स्टोरी देखी, तो जो आपने स्टोरी बताई है वो पिछले 30 साल से सेम स्टोरी है कि बच्चा इन्फेक्शन से ट्रीट होता है, बच्चे का सही डायग्नोस नहीं होता है, बच्चे को सही काउंसलिंग नहीं मिलती है, बच्चे को सही ट्रीटमेंट नहीं मिलता है। तो इसके लिए जैसा अभी प्रसन्ना जी ने बोला, ये पूरा अभी डॉक्टर एनी ने भी बोला कि हमें टीम वर्क बहुत जरूरी है। हम पेरेंट्स सपोर्ट ग्रुप, हम पेरेंट्स को सपोर्ट कर सकते हैं, क्लिनिकली अपनी लाइन को क्रॉस नहीं कर सकते हैं, हम सब कुछ जानते हुए अपनी लाइन क्रॉस नहीं कर सकते। तो जेनेटिक काउंसलर बहुत इंपॉर्टेंट है इसके अंदर। और जैसा आप ये कह रही हैं कि कई डॉक्टर ये बोलते हैं कि कुछ नहीं हो सकता है, और हमारा क्वेश्चन ये है कि क्या हो सकता है, क्योंकि इस बच्चे को सही ट्रीटमेंट चाहिए और अगला बच्चा बिल्कुल सही आना चाहिए। उसके लिए इसका सही डायग्नोस बहुत इंपॉर्टेंट है, क्योंकि आई एम वेरी सॉरी टू से कि हम लोग इस डायग्नोस पे इतने सारे पैसे खर्च कर देते हैं कि बच्चे का ये भी करा लीजिए, बच्चे का वो भी करा लीजिए। एक न्यूबॉर्न स्क्रीनिंग या एक जो आपने टीएमएस बोला या जीसीएमएस बोला, आई एम नॉट क्लिनिकल पर्सन, उस अगर वो कराने से हमें कुछ इंफॉर्मेशन मिलती है, सही डायग्नोस मिलता है और पेरेंट्स की भी कैरियर स्क्रीनिंग हो जाती है। क्योंकि जितना मैं मालूम रखता हूँ 90 to 95% डिजीज ऑटोसोमल रिसेसिव है। तो we both mother and father are carriers in most cases. तो अगर हमारी कैरियर स्क्रीनिंग हो जाती है, बच्चे का सही डायग्नोस हो जाता है, तो मुझे पूरा विश्वास है कि आने वाली जो संतानें हैं हम बिल्कुल स्वस्थ लाएंगे। कोई भी माँ बाप ये नहीं चाहेगा कि उसका बच्चा इस तरह के डिसऑर्डर से लेकर आए, लेकिन जो बच्चा आ चुका है उसे आप डॉक्टर्स का, पूरी सोसाइटी का, हम एनजीओ का फर्ज बनता है कि उसे करेक्ट डायग्नोस। हमारे सपोर्ट ग्रुप के अंदर 350 मेंबर है। मुझे बड़ी खुशी है बताते हुए कि आज 70 से ज्यादा बच्चे स्कूल जा रहे हैं, कई हमारे बच्चे कॉलेज जा रहे हैं। ये अपने आप में शो करता है कि अगर आप आईएम की बात कर रहे हैं, यूनिसाइकिल डिसऑर्डर की, जितना मैं समझ पा रहा हूँ, अगर हम सही डायग्नोस दें, सही ट्रीटमेंट दें, तो हमारे बच्चे भी बाहर की कंट्रीज जैसे नॉर्मल जा सकते हैं। और मैं इस बच्चे के लिए ब्लेसिंग दूंगा कि ये बच्चा हमारा बिल्कुल नॉर्मल रहेगा। और ऐसे हजारों सैकड़ों बच्चे हैं जो आईएम लेके आते हैं। प्लीज, एक विराट कोहली पूरा गोल नहीं कर सकता है, उसे 10 आदमियों का साथ चाहिए। ओके, मेरा नाम विकास भाटिया है, मैं जयपुर से आया हूँ और मेरा एक पेरेंट सपोर्ट ग्रुप है कॉल मड इंडिया मेटाबॉलिक एरर एंड रेयर डिजीज ऑनेशन। हमारे उसके अंदर 350 मेंबर हैं और मैं पिछले 12 वर्षों से काम कर रहा हूँ। इस तरह की मैंने तकरीबन 150 मीटिंग्स अटेंड करी हैं, खुद मैंने 50 मीटिंग्स ऑर्गेनाइज करी हैं। और मैं इस मंच के द्वारा आपसे अपील करना चाहता हूँ कि 21 नवंबर को हम लोग आईएम डे ऑब्जर्व करते हैं। प्लीज इस 21 नवंबर 2022 को आप इसे मैसूर में सेलिब्रेट करिए, हम उसमें जरूर शामिल होंगे। बहुत बहुत धन्यवाद।
Just I would like to add a note with this case is early diagnosis. Just because, as said, everything is getting diagnosed as sepsis. So in the NICU, the team is so robust now that any case, sepsis, the alternative diagnosis with pedigree, consanguinity would be always taken as a second differential as IEM itself, and immediately we have an SOP which is developed by our NICU team, where immediately we do the screening, so that this is an example where the child had 1400 ammonia level with immediate decision was taken to do a peritoneal dialysis. So that is how we could avoid a lot of damage that is going to happen to the child. So in this way, I'm really thankful to our NICU department, because every child with sepsis with certain history, we have our own protocol that they will be screened for inborn error where we can avoid. And the system up to IEM diet, counseling, support, everything is happening here. So this is from the JSS, which we have developed over a period of this 5 years after establishing this counseling clinic.
Thank you, everyone. And thank you, Dr. Sushma and Dr.
Yeah, just a minute. It's also very important that carriers of any of these disorders, they have to be told to even convince their extended family to get tested, because maybe their brothers or sisters are also carriers and they're not aware of it. So that is also important. And then if somebody is a carrier, their spouse should be tested so that another child in the same family is not affected with that problem. So that is also important.
Excuse me, one question I have. Myself, Dr. Shweta Singh from Jain University, Bangalore. So I'm a basically molecular biology researcher. So from my perspective, when you talk about thalassemia, I know what it's an autosomal recessive disorder. And when you talk about this disease, what I figured out, it's an X-linked disease because the female child was also having it and the male child was also having it. But those families who are in the localized, they don't know about it. So we need to have a parent education system where we can have free camps, where we show the statistics that how genetic counseling has helped us lower this type of diseases. So that will be more helpful. That's what I think.
Probably, yes, your suggestion can be taken. But yes, as I told you, our genetic team is just evolving for the last 4 or 5 years, and we are coming up with new programs, and hopefully we will come up with that also soon. Thank you.
Thank you, Dr. Sushma and Dr. Akshaya. Yes, excuse me.
Policies we want in India. So this can happen. This can happen only, if BGCI can talk to government Ministry of Planning and Family Welfare. Yeah, they have to come up with such policies. See, at the end of the day, we want a better India. As our Prime Minister says, Atmanirbhar Bharat. So we want to see that. This is only possible if government will help all the medical universities all over India to have this type of screening program. Thank you.
Thank you.
I'd like to take this up as a policy researcher that it has been long, debated and worked upon how to bring up such kind of policy. But with a huge population and differential race in India, it is very difficult to identify a panel of disease for which career counseling has to be generalized for the entire country. Maybe it could be region-wise and then there's migration and everything. However, high-risk population, identification of high-risk population, and then career screening and then prenatal screening, prenatal diagnosis is what is more feasible and cost-effective in India. And that is where the role of genetic counselors come, where they have to identify the high-risk patients and the families, and then they can carry on from there, rather than a general career screening. So yeah, with that, we have to end this session in the interest of time.
Yeah, thank you, everyone. Now let's move to the next session on cystinuria. I request the chairperson to introduce Dr. Shashi Kiran and Sivi, and Dr. Sivi.
Now, it would be my pleasure to introduce Dr. Shashikiran KV. I would request him to come on the dais. So he is Assistant Professor in the Department of Nephrology, Institute of Neurourology, Mysore. So he has done his MD Pediatrics from Rajiv Gandhi University of Health Sciences and BM Nephrology from NIMS, Hyderabad. And his interests have been in the pediatric nephrology. He's also a secretary of IAP Mysore and also member of Indian Society of Nephrology. I welcome you, sir. We have a co-presenter, Dr. Siri, who is a postgraduate in the Department of Pediatrics at Mysore Medical College and Research Institute, Mysore. She's also a member of IAP, and her interests are critical care in pediatrics. I welcome you, Dr. Seri. Over to you, presenters.
Good morning to one and all present here. First off, I would thank the organizers for giving me this opportunity to present my case on this platform. So here is a story of a 12-year-old girl child. So a 12-year-old female child born to a second-degree consanguineously married couple came with complaints of not gaining height in comparison with her peers. The only complaint was not gaining height. She was in fact referred from a school to us. There was no other history suggestive of any other complaint. But on eliciting the history, the parents gave us a history of polyuria and polydipsia. There was no other contributory history suggesting any other symptom, any other system involvement. So all she had was polyuria, polydipsia, and short stature. There was no significant past history. She had the history of V's at age of 7 years. Coming to the family history, both parents and the siblings, they are of normal height. There's no history of delayed attainment of puberty in either of her parents. This is the pedigree. It's a second degree consanguineous marriage, and Sandhya is the first. My patient was the first child who was affected. Coming to the birth history, she was delivered at 39 weeks and she had 2 days of NICU stay for her birth weight, which was low and which was 1.8 kg. She is immunized till date. She is developmentally appropriate for age. She goes to class 8. She has a good scholastic performance. She has a good diet. Diet is adequate. Socioeconomic history, they belong to a lower middle class family as per the modified Cooper-Smith scale. So coming to examination, on examining her, we found she was vitally stable. Her head-to-toe examination was normal. All she had was pallor, and her SMR stage was stage 2. And systemic examination was normal. When anthropometry was done, her height and weight were both low. She was underweight. Her weight was less than third centile, and her height was also less than third centile, suggesting she was severely stunted. Her upper segment to lower segment ratio was normal, so which showed that she was a proportionate short stature. When we took the mid-parental height and we got the target height, and then we did the projectile height, we had a difference of about 20 centimeters, suggesting that it was a pathological proportionate short stature. So we had a child with pathological proportionate short stature. Our close differentials for this was either an endocrine cause or was a renal cause. So we went ahead with investigations. And on investigation, she had anemia. Her HB was 7.2 gram per deciliter, and her renal profile was severely deranged. So here, for the parents with a child who was just short, they didn't think she had any other problem other than the short stature, and we found that her creatinine was 3.6 milligram per deciliter. So we had to counsel the parents regarding possible renal etiology for a short stature. Child also had hypokalemia, she had hypocalcemia, hypomagnesemia, and the serum phosphorus levels were low. So we went ahead and did an ABG. ABG showed both NAGMA and HAGMA, that is normal anion gap metabolic acidosis and high anion gap metabolic acidosis. And our EGFR was only 13 ml per minute. We could attribute the high anion gap aspect of the ABG to the CKD which she was having because of her reduced GFR and her elevated creatinine and urea. But the normal anion gap was the one which gave a clue towards the possible proximal RTA because of her urinary and serum electrolyte imbalance. So after getting the urine pH and urine electrolytes done, we came to a diagnosis of a possible proximal RTA, that is type 2 RTA, which could have been the cause for the CKD. Now the task was to explain to the parents as to why she could have this RTA and go about finding the cause for this RTA. One of the, as she was a child, 12-year-old child with the proximal RTA, we thought of cystinosis as a possible cause for the RTA, and we got her genetic analysis, as well as we have also sent for her leukocyte cysteine levels. These are our investigations. Our other endocrine causes like diabetes and thyroid dysfunction was ruled out. Her USG also showed raised echo pattern and blurring of corticomedullary junction of bilateral kidneys, which is suggestive of CKD, and other reports are. So we got a genetic analysis done, and it showed a CTNS gene mutation. This was her genetic analysis, which was both in exon 7 and intron 12. We have also sent for a leukocyte cysteine levels, which are awaited for this child. And we have supplemented her with calcium, magnesium, phosphorus, iron, soda bicarbonate. Basically, whatever she's losing in her urine because of her RTA, we are supplementing her with that. And our next, we have also counseled the parents regarding the possible need for dialysis, and we are awaiting our leukocyte cysteine levels, and we are planning for a cysteamine therapy for the child.
Very good morning to one and all. At the outset, I thank the organizers for giving this opportunity to share with you this case. I am no expert in management of cystinosis, I would like to confess. This is actually just my second case which I have seen here. One was during my residency, and that was a already diagnosed case, but this one came with a suspicion. Child was actually admitted in the Department of Pediatrics for evaluation of short stature. So they did a basic workup and they found out the renal cause as the possible etiology for this child having short stature. And with that as background, when I looked up into the further investigation, this child had all features to suggest a proximal RTA. So in a child with proximal RTA, we usually, without any other forthcoming histories of any drugs or etc., usually think of something genetic, some transporter mutations or some issues, of which cystinosis definitely has its place. So after getting this idea on how to go about, I'm from a government sector where we see only strata belonging to low secretion strata. So I had a lot of deficiencies on how to go about. In fact, I would say I'm illiterate in that aspect. So finally, my first step at that point of time was to treat the child symptomatically. So I addressed the child's issues like hypokalemia, hypocalcemia, phosphorus supplementation, vitamin D supplementations, some anemia correction. These were the basic first things which were going on. But ultimately, we want a diagnosis for this child. So the diagnosis for this child, simple one, was a ophthalmic evaluation. But unfortunately, ophthalmic evaluation slit lamp did not show any cysteine deposition. So the next step definitely is a genetic analysis or cysteine levels. So when I explained to the father that this child needs much higher investigation, and that definitely cost. So I talked with one of my philanthropist friend, and they were kind enough to get a genetic test for this. Can you put up the slide? So this test came out positive, and then after this, now that I have a diagnosis of late onset or juvenile nephropathic cystinosis, how to go about it? What should I do? Seriously, again, I would like to confess again. Definitely at first, at the initial point, I did not know how to procure cysteamine, how to go about all these things. And child has already presented very late. This is not plain proximal RTA. The child has already landed up with advanced chronic kidney disease. So as a nephrologist, I'll be concerned about the kidneys, what I can do next. So all I could offer was only with respect to the nephrological point of view. And with respect to this, then I did some search with my friends and my seniors, and they got told the number of Dr. Aditi Sinha and Arvind Bagga who are doing some research work based on cystinosis in AIIMS, New Delhi. So they told me that send a sample for leukocyte cysteine levels, we'll send you the vials. So based on that, if that turns out something, I'll be helping you out with enzyme replacement. And now we have sent that reports and we are awaiting for that. As of now, what am I doing with the child? Symptomatic therapy. So what have I told the patients? I've just told that your child has a renal dysfunction, which is genetic. In fact, to tell them and explain what is genetic, how it has come itself was difficult for me. Definitely, I feel even with a DMD R&B degree, I severely lack in counseling them regarding that. All I can tell them is that your child someday or the other will require renal replacement therapy, which will be a dialysis to begin with, or if you're forthcoming and we can manage finances, we'll go ahead with a renal transplant. So even with that, that will not be the end of the story there for this child because its basic pathology needs to be addressed. That I hope in future I'll be able to get help and
begin with, I just want to say it's a rare genetic condition which not many of us have come across, to be honest, like yourself. So we wouldn't know. But the good thing about it is that we got the genetic testing done, we could manage that, and we've come to a particular some results out of it, and which has indicated the condition to it. So this highlights the importance of genetic testing that needs to be done at the right time as such, and how we can come to decide as to what test needs to be done. That was one good thing, and I think to throw the light on how to manage this case. I don't know if we have any nephrologists in the audience who can throw some light on that.
nephrology prospect, I take care, madam. I am there.
I'm sorry that I did not.
Sorry. Sorry.
No, it's how to, what was your
My plan is now she is in an advanced stage of chronic kidney disease. She will have the biochemical parameters going haywire that we can address with medications. But ultimately she will end up in a stage where she will get renal replacement therapy. So when I tell them that you have to go for a dialysis, maybe for a small child, I'll have to do a peritoneal dialysis. Or if everything goes on well, I can do a preemptive transplant to this child. But definitely, I told you, just for a genetic test, the finance was sponsored by someone. So when we go ahead with the transplant, yes, government will give CMRF funds are there, but that will not be completely sufficient. Somehow we can work it out. We have done previously also a child transplant of even 7-year-old or 6-year-old with very minimal finance. That can be done. But doing a transplant doesn't end up here to this child because other organ involvement will be there. So what I am really asking for help, in fact, if anybody is aware, is cysteamine therapy. If anybody have come across, that is one thing. Other thing is, how will I go about to tell the parents how this they got this decision, what and other things.
Have to tell them that it is a genetic condition which has been passed down. It is a rare thing, and also it's not missing. It can happen sort of to anybody, and so it has been like tested and found out, and they are planning for future pregnancies and all. Then they need to get the parental testing and prenatal diagnosis done subsequently. But if you are looking for some to something, I'm not really aware of that.
Thank you. I point taken. Yes.
I do not have an answer to this. I'm a complete non-clinical person. Only thing I wanted to add upon this is a common problem with every rare genetic disorder, and especially the ones which are not being worked upon, highly. Every clinician is, encountering the same problem, and that is where the rare disease policy comes up with the Center of Excellence idea, which to explain better, which is a hub and spoke model. All over the country, there will be center of excellence, and any such case which you do not have an answer to, the clinician doesn't have an answer to, can quickly refer to, and as you have already found out in AIMS group is working. And then there's another part where we are working with the WHO Global Collaborative Network for Rare Disease, where the idea is to connect such hubs globally, so that any such case comes up and for which you do not have an answer maybe in India, but you can connect to groups across the globe, whoever is working on such, and work on any intervention that could be taken upon. And I think that will be very helpful for any clinician situated anywhere in the country. And the other part, as you were talking about the one-time transplantation cost and everything, rare disease policy also covers this one-time transplantation cost charge, but it does not cover the follow-up maintenance cost, again, which is, I suppose, it's high for a normal family, right? So, but one time they do have provision for that. So those things you can maybe discuss. We can discuss.
Thank you, ma'am. Thanks a lot for
That is what Suraj was saying, that a genetic counselor will help you in the remaining journey. They can find out where the other international collaborations are. They'll find out if there are clinical trials going out for it. They can tell you what the current rare disease policy offers you, tell you what your government can offer. That also comes in the added responsibility of a genetic counselor. At the same time, they support the clinician and the family. So take their help. You don't have to sit and rack your brain all the time. You do your transplant, you do the management, you do the dialysis. That's your skill and that's your training. So the other things, they are researchers, they are advocacy groups, they are counselors, they will look into it. And in fact, this is a very, very strikingly interesting report for me as a geneticist. But let's two homozygous, two variants.
Madam, again, I will like to tell that if you ask me to read this report, I'll see only the last column one in red. Very true, I accept it, ma'am, but I will have to confess whatever is our limitation.
See, I would like to continue what Annie has said because I'm also a geneticist. It's a very interesting information which is on the screen because two mutations, it may be haplotype also. We do not know because a homozygous condition must be both the parents must be carrying it. So we need to know if they have other family members like children. Is the only child or
one more sibling is there, male child is there.
so those children, they may be some of them may be heterozygotes also. I think taking this information, as Annie said, taking care of the patient, is one thing. The other aspect as geneticist, genetic counseling, it's very, very important. So that's what I can say.
Thank you, ma'am.
Thank you.
Have you checked thyroid levels? Like I might have
Thyroid function test or within
normal, okay. And do you think this is a single gene disorder? There can be, because in this situation it can be a multigenic also. So when a phenotype you see which has got multiple things to note on, I think because you are asking like you don't know what to do. So that point also I think one must consider that other genes which are associated with this particular gene also you have to look for. Of course, we have to look at the Western literature only. So whatever is happening in today's day, we have to see. And third thing, as far as treatment is concerned, grafting and all those things is okay, like you will do that. But there are, of course, you have to watch. There are drugs which always bind to the capsides of the gene. That is where the gene starts transcribing. So you have to look at that also. There must be some drugs which naturally, when you take them, they start functioning differently.
Thank you, ma'am.
Is the head circumference normal? For head circumference?
Yes, head circumference is normal.
Normal.
What dad has to say?
ಬೆಳವಣಿಗೆ ಪ್ರಾಬ್ಲಮ್ ಸಮಸ್ಯೆ ಅಂದ್ಬಿಟ್ಟು ತೋರಿಸ್ತಾ ಡಾಕ್ಟರ್ ಸ್ಕೂಲ್ನಲ್ಲೂ ಕೂಡ ಹೇಳಿದ್ರು ವೈಟ್ ಸ್ವಲ್ಪ ಕಡಿಮೆ ತೋರಿಸಿ ಅಂತ ಹೇಳಿ ಡಾಕ್ಟರ್ ತೋರಿಸಿದಾಗ ಮೊದಲು ಅದು ನಾವು ಸಂಬಂಧದಲ್ಲಿ ಮದುವೆ ಆಗಿದ್ದು ಅಕ್ಕನ ಮಗಳು ಮದುವೆ ಆಗಿದ್ದು ಡಾಕ್ಟರ್ ಸ್ವಲ್ಪ ಚೆಕ್ ಮಾಡಿ ಒಂದ್ 2 ರಿಪೋರ್ಟ್ ಚೆಕ್ ಮಾಡಿದಾಗ ಅದು ಸ್ವಲ್ಪ ಹುಟ್ಟಿನಿಂದಾನೇ ಸ್ವಲ್ಪ ಸಮಸ್ಯೆ ಎರಡು ರಿಪೋರ್ಟ್ ಚೆಕ್ ಮಾಡಿದ್ರು ಡಾಕ್ಟರ್ ಚೆಕ್ ಮಾಡಿದ್ರೆ ಒಂದು 5 ಬಿಟ್ಟಲ್ಲಿ ಹುಟ್ಟೆ ನಮ್ಮ ಸಂಬಂಧ ಮದುವೆ ಆದ್ರಿಂದ ಹುಟ್ಟಿನಿಂದ ಸ್ವಲ್ಪ ಸಮಸ್ಯೆ ಇದೆ ಅಂತ
To translate whatever he said, in the school screening program, the child was suspected to have short stature and was asked to take higher care, medical care, attention. So he brought the child to the Department of Pediatrics. He underwent certain testing done and all the evaluations for the child. And the doctors have told that probably your marriage leads to the family. He is married with the second degree consanguinity. So probably that is one which is leading to the present disease in this child. And specifically, two important tests have been sent. One of the reports of that is available, the other one is awaiting. So he still awaits what next needs to be done.
ನಮಸ್ಕಾರ ಎಲ್ಲರಿಗೂ.
It doesn't feel so. Madam, consanguineous marriage in Karnataka, South India is pretty common and it's very accepted now. I have my own family, I'm multiple people with consanguineous marriage.
While the clinicians are finding out how to deal with this, so I would be more concentrating on the child. Okay, so because of her short stature, we also have to look into the child's mental well-being, psychological well-being. She might be undergoing a lot of bullying. Okay, she might be undergoing a lot of these kind of things. And also, I'm happy that this condition has not done anything to her cognition, as going by the history that she is doing well her in studies. So that in that way, I'm very happy to see that her academics and her other performance have not been compromised with the disease. So I would be better looking out from the child's point of view, how to ensure that her self-esteem is not affected because of her short stature or because of this rare condition. So we would be looking upon how we can support her to ensure that other positives that are there, that she is still able to do and which she still can able to live with it. So that would be my perspective.
Very true, sir. This point, I would like to make my own personal. I was not pathological. I come into the physiological short stature category. So shortest in the class. Only after 12th standard, when I got to MBBS, the narration changed. And then this Kula term was there.
I totally empathize with
Kula
this.
Shashi was always called everywhere. That is there.
That's my life experience too.
In this regard, like this is again a very common problem for all the rare diseases, where the stigma, the social impact in the children who are dealing with it, and parents, of course. And what I see is the Board of Genetic Counselor, they have a wonderful opportunity to work with the schools. Maybe that is something beyond the scope of their work, but still I'm requesting you, if there is a scope for you to work with the schools, and it's just not the government schools, the private schools, every kind of schools, if you could do general awareness campaign just among the students, among the teachers, just to sensitize them of into more broad area of diseases, because it could be one child in entire school suffering from one disease, but in general sensitizing the school and destigmatizing such conditions, that would be a wonderful service to the society. So I'd request this board to take this up and see if there's a way that they could work on it.
ನಮಸ್ಕಾರ, ನನ್ನ ಹೆಸರು ರತ್ನಮ್ಮ ಅಂತ. ನಾನು ICM ಟೀಮ್ ಅಲ್ಲಿ ದೀಪಾ ಮೇಡಮ್ ಅಂಡರ್ ಅಲ್ಲಿ ರಿಸರ್ಚ್ ಅಸಿಸ್ಟೆಂಟ್ ಆಗಿ ಕೆಲಸ ಮಾಡ್ತಾ ಇದ್ದೀನಿ. ನಾವು ಕೆಲಸ ಮಾಡ್ತಾ ಇರೋದು ವರ್ಕ್ ಪ್ಲೇಸ್ ಬಂದು ಟ್ರೈಬಲ್ ಏರಿಯಾ. ಕರ್ನಾಟಕದಲ್ಲಿ 51 ಟ್ರೈಬಲ್ ಗ್ರೂಪ್ಸ್ ಇದೆ. ಅದರಲ್ಲಿ ಒಂದು 13 ಫಾರೆಸ್ಟ್ ಬೇಸ್ಡ್ ಟ್ರೈಬಲ್, 3 ಬಿಳಿಗಿರಿ ರಂಗನ ಬೆಟ್ಟ, ಕೊಪ್ಪಳಸ್ವಾಮಿ ಹಿಲ್ಸ್, ಮಲೆ ಮಹದೇಶ್ವರನ ಬೆಟ್ಟ, ನ್ಯಾಷನಲ್ ಪಾರ್ಕ್ ಬಂಡೀಪುರ, ನ್ಯಾಷನಲ್ ಪಾರ್ಕ್ ನಾಗರಹೊಳೆ, ತಿಕ್ ಫಾರೆಸ್ಟ್ ಅಲ್ಲಿ ವಾಸ ಮಾಡ್ತಕ್ಕಂಥ ಫಾರೆಸ್ಟ್ ಏರಿಯಾದಲ್ಲಿ ನಾವು ಕೆಲಸ ಮಾಡ್ತಾ ಇದೀವಿ. ಸೊ ನಮ್ಗೆ ಗೊತ್ತೇ ಇರ್ಲಿಲ್ಲ, ಈ ಜೆನೆಟಿಕ್ ಡಿಸೀಸ್ ಬಗ್ಗೆ ಗೊತ್ತೇ ಇರ್ಲಿಲ್ಲ. ನಾನು ಓದಿದ್ದು ಆರ್ಟ್ಸ್, ಅದ್ರಲ್ಲಿ ನನಗೆ ಒಂದು ಸೋಷಿಯಲ್ ಸೈನ್ಸ್ ಅಲ್ಲಿ ಒಂದು ಪೇಪರ್ ಇತ್ತು. ಸೊ ಹಾಗಾಗಿ ನನಗೆ JSS ತುಂಬಾ ಪ್ರಾಜೆಕ್ಟ್ ಗಳೆಲ್ಲ ಮಾಡ್ತಾ ಇದೆ. ಸೊ ಹಾಗಾಗಿ ನಮ್ಗೆ ಈ ಜೆನೆಟಿಕ್ ಡಿಸೀಸ್ ಗಳು ಮತ್ತೆ ಕೌನ್ಸಿಲಿಂಗ್ ಇದ್ರ ಬಗ್ಗೆ ಹೆಚ್ಚು ನಮ್ಗೆ ಪರಿಚಯ ಇರ್ಲಿಲ್ಲ. ಸೊ ತದನಂತರದಲ್ಲಿ ನಾವು ಇಲ್ಲಿ PhD ಗೆ ಜಾಯಿನ್ ಆಗಿ ಆ ನಂತರ ನಾವು ಇಲ್ಲಿ ICM ಅಲ್ಲಿ ದೀಪಾ ಮೇಡಮ್ ಅಂಡರ್ ಅಲ್ಲಿ ಕೆಲಸ ಮಾಡುವಾಗ ಜೆನೆಟಿಕ್ ಒಂದು ಕೌನ್ಸಿಲಿಂಗ್ ಮತ್ತು ಜೆನೆಟಿಕ್ ಟೆಸ್ಟ್ ಗಳು ಇದೆ ಅನ್ನೋದು ಈ ಪ್ರೆಸೆಂಟ್ ಅಲ್ಲಿ ಅವ್ರಿಗೆ ಗೊತ್ತಾಗ್ತಾ ಇದೆ. ಈಗ ಗೊತ್ತಾಗ್ತಿದೆ ಟ್ರೈಬಲ್ ಗಳಿಗೆ. ಅಲ್ಲಿ ಎಷ್ಟು ಮಕ್ಕಳುಗಳು ಡೆತ್ ಆಗ್ತಾ ಇದೆ, ಅವ್ರಿಗೆ ಅವೇರ್ನೆಸ್ ಇಲ್ಲ. ಈ ಜೆನೆಟಿಕ್ ಕೌನ್ಸಿಲಿಂಗ್ ಅಂದ್ರೆ ಏನು, ಜೆನೆಟಿಕ್ ಡಿಸೀಸ್ ಅಂದ್ರೆ ಏನು ಅವ್ರಿಗೆ ಗೊತ್ತೇ ಇಲ್ಲ. ಸೋಷಿಯಲ್ ಸ್ಟಿಗ್ಮಾ ತುಂಬಾ ಇದೆ, ಎಕನಾಮಿಕ್ ಕಂಡೀಷನ್, ಪೂರ್ ಕಂಡೀಷನ್ ತುಂಬಾ ಇದೆ, ಹಾಸ್ಪಿಟಾಲಿಟಿ ಬಗ್ಗೆ ಅವ್ರಿಗೆ ಅವೇರ್ನೆಸ್ ಇಲ್ಲ. ಸೊ ನಾವು 3 years ಅಲ್ಲಿ ಏನ್ JSS ಇಂದ ಅಲ್ಲಿ ನಾವು ಕ್ಯಾಂಪ್ ಮಾಡಿದ್ವಿ, ಅವೇರ್ನೆಸ್ ಮಾಡಿದ್ವಿ. ಮೇಡಮ್ ಹೇಳಿದಾಗೆ ನಾವು ಪೇಷಂಟ್ ಸಪೋರ್ಟಿಂಗ್ ಗ್ರೂಪ್ ಗಳನ್ನ ಮಾಡ್ಕೊಂಡ್ವಿ. ಅದರಲ್ಲಿ ಆಶಾ ವರ್ಕರ್ ಗ್ರೂಪ್ ಗಳು ಮಾಡ್ಕೊಂಡ್ವಿ, ಅಂಗನವಾಡಿ ಸ್ಟಾಫ್ ಗ್ರೂಪ್ ಗಳನ್ನ ಮಾಡ್ಕೊಂಡ್ವಿ, ಕಮ್ಯುನಿಟಿ ಲೀಡರ್ಸ್ ತುಂಬಾ ಇಂಪಾರ್ಟೆಂಟ್ ಇವರು, ಆ ಕಮ್ಯುನಿಟಿ ಲೀಡರ್ಸ್ ಗ್ರೂಪ್ ಗಳು ಮಾಡ್ಕೊಂಡ್ವಿ. ಮತ್ತೆ ಟ್ರೆಡಿಷನಲ್ ಹೀಲರ್ಸ್ ಗ್ರೂಪ್ ಇದು ತುಂಬಾ ಇಂಪಾರ್ಟೆಂಟ್. ಯಾಕಂದ್ರೆ ಟ್ರೈಬಲ್ಸ್ ಮತ್ತೆ ಲೋಕಲ್ ಟ್ರೆಡಿಷನಲ್ ಹೀಲರ್ಸ್ ತುಂಬಾ ಅವರು ಟಚ್ ಅಲ್ಲಿ ಇರ್ತಾರೆ. ಆ ಟ್ರೆಡಿಷನಲ್ ಹೀಲರ್ಸ್ ಗ್ರೂಪ್ ಗಳು ಮಾಡ್ಕೊಂಡ್ವಿ. ಮತ್ತೆ ಲೋಕಲ್ PHC ಪ್ರೈಮರಿ ಹೆಲ್ತ್ ಸೆಂಟರ್ ಈ ತರ ಗ್ರೂಪ್ ಗಳನ್ನ ಮಾಡ್ಕೊಂಡು 3 years ಅಲ್ಲಿ ನಾವು ಹೌಸ್ ಟು ಹೌಸ್ ಫಸ್ಟ್ ಇಯರ್ ಸರ್ವೆ ಮಾಡಿ, ಸೆಕೆಂಡ್ ಇಯರ್ ಫುಲ್ ಕೌನ್ಸಿಲಿಂಗ್. ಅವ್ರಿಗೆ ಫಸ್ಟ್ ನಾವು ಹೇಗಿರ್ಬೇಕು ಅಂದ್ರೆ ಫಸ್ಟ್ ನಾವು ಅವರಲ್ಲಿ ಒಬ್ಬರಾಗ್ಬೇಕು. ಅವ್ರು ನಾವು ಫಸ್ಟ್ ಹೋದ ತಕ್ಷಣ ನಾವು ಜೆನೆಟಿಕ್ ಟೆಸ್ಟ್ ಮಾಡ್ತೀವಿ, ನಾವು ಈ ಟೆಸ್ಟ್ ಬಂದಿದೀವಿ ಅಂದ್ರೆ ಅವ್ರು ಯಾವತ್ತೂ ಒಪ್ಪೋದೇ ಇಲ್ಲ, ಯಾವ ಪೀಪಲ್ ಆದ್ರೂ ಸಹ. ಸೊ ನಾವು ಅವ್ರಿಗೆ ಫುಲ್ ಕ್ಲೋಸ್ ಆಗಿ ಅವ್ರ ಫ್ಯಾಮಿಲಿ ತರ, ಅವ್ರ ರಿಲೇಷನ್ಸ್ ತರ, ಅವ್ರಿಗೆ ಫ್ರೆಂಡ್ಸ್ ಆಗಿ ನಾವು ಸರ್ಕಲ್ ಮಾಡ್ಕೊಂಡು 1 by 1 ಅವಾಗ ನಾವು 2 ಸ್ಟಾರ್ಟಿಂಗ್ 4 PSC ತಗೊಂಡಿದ್ವಿ ನಾವು ಹೌಸ್ ಟು ಹೌಸ್ ಸರ್ವೆ ಮಾಡುವಾಗ. ಸೆಕೆಂಡ್ ಇಯರ್ ಅಲ್ಲಿ ನಾವು 2 PSC ಇಂಟರ್ನಲ್ ಸ್ಟಡೀಸ್ ಆಗಿ ಮಾಡುವಾಗ ನಾವು ಆ 2 PSC ಅಲ್ಲಿ ನಮಗೆ ಗೊತ್ತಿರ್ಲಿಲ್ಲ, ನಮ್ಗೆ ಟೋಟಲ್ ಪೇಷಂಟ್ 82 ಪೇಷಂಟ್ ನಮಗೆ ಜೆನೆಟಿಕ್ ಡಿಸೀಸ್ ಪೇಷಂಟ್ ಬಂತು. ಗೊತ್ತೇ ಇರಲಿಲ್ಲ ಟ್ರೈಬಲ್ ಗಳಿಗೆ ಸ್ಟಡಿ ಮಾಡುವಾಗ. ಅಷ್ಟೊಳಗಡೆ ಅವ್ರಿಗೆ ನಾವು ಕೌನ್ಸಿಲಿಂಗ್ ಮಾಡಿದ್ವಿ, PSC ಲೆವೆಲ್ ಅಲ್ಲಿ, ಕಮ್ಯುನಿಟಿ ಲೆವೆಲ್ ಅಲ್ಲಿ, ಅಂಗನವಾಡಿ ಲೆವೆಲ್ ಅಲ್ಲಿ, ಟ್ರೆಡಿಷನಲ್ ಹೀಲರ್ಸ್ ಆ ಲೀಡರ್ಸ್ ಗಳೆಲ್ಲ ಸೇರಿಸ್ಕೊಂಡು ನಾವು ಕೌನ್ಸಿಲಿಂಗ್ ಮಾಡಿ ಆಶಾ ವರ್ಕರ್ಗೆ, ಅಂಗನವಾಡಿ ವರ್ಕರ್ಗೆ ಟ್ರೈನ್ ಅಪ್ ಮಾಡಿದ್ವಿ. ಯಾಕಂದ್ರೆ ಲೋಕಲ್ ಅಲ್ಲಿ ತುಂಬಾ ಇಂಪಾರ್ಟೆಂಟ್, ಅವ್ರಿಗೆ ನಾವು ಟ್ರೈನ್ ಅಪ್ ಮಾಡಿದ್ವಿ. ನಮ್ಮ ಮೇಡಮ್ ಅಲ್ಲಿ PSC ಗಳಲ್ಲೂ ಮತ್ತೆ ಆಡಿಗಳಿಗೆಲ್ಲ ನಾವು ಭೇಟಿ ಮಾಡಿ, ಸೊ ಈ ತರ ನಾವು ಪೇಷಂಟ್ ಮಾಡುವಾಗ ಅವ್ರಿಗೆ ಗೊತ್ತಾಯ್ತು, ಓ ಜೆನೆಟಿಕ್ ಡಿಸೀಸ್, ಸಿಕಲ್ ಸೆಲ್ ಅನಿಮಿಯಾ, ಬೀಟಾ ಥಾಲಸೆಮಿಯಾ, ಈ ತರ ಪೇಷಂಟ್ ಗಳಿದೆ, ಹೀಗಿದೆ. ಇದು ಅವ್ರಿಗೆ ಗೊತ್ತೇ ಇರ್ಲಿಲ್ಲ. ಅವರು ಯಾವ್ದು ನಮ್ಗೇನೋ ಭೂತ ಬಂದಿದೆ ಅಥವಾ ಇನ್ನೇನೋ ಮಾಡಿದ್ದಾರೆ, ಮಾಟ ಮಂತ್ರ ಮಾಡಿದ್ದಾರೆ, ಈ ತರದಲ್ಲಿ ಅವರು ಆ ಭಾವನೆಗಳು ಇತ್ತು. ಸೊ ನಾವು ಇದನ್ನ ನಾವು ಟ್ರೈನ್ ಅಪ್ ಮಾಡಿ ಅವೇರ್ನೆಸ್ ಕೊಟ್ಟಾಗ ಅವ್ರಿಗೆ ಗೊತ್ತಾಯ್ತು, ಓ ಜೆನೆಟಿಕ್ ಡಿಸೀಸ್ ಇದೆ, ನಮ್ಮಲ್ಲಿ ಇದೆ, ಇದು ಫ್ಯಾಮಿಲಿ ತುಂಬಾ ಇಂಪಾರ್ಟೆಂಟ್. ಆವಾಗ ನಾವು ಒಂದು ಮಗು ಒಂದ್ ಫ್ಯಾಮಿಲಿಯಲ್ಲಿ ಒಂದು ಮಗು ನಮ್ಗೆ ಥಾಲಸೆಮಿಯಾ ಮತ್ತು ಸಿಕಲ್ ಸೆಲ್ ಇದ್ದಾಗ ಹೋಲ್ ಫ್ಯಾಮಿಲಿಗೆ ನಾವು ಕೌನ್ಸಿಲಿಂಗ್ ಕೊಡ್ತಾ ಇದ್ವಿ. ಸ್ಲೋಲಿ ನಾವು ಅವ್ರಿಗೆ ಕೌನ್ಸಿಲಿಂಗ್ ಕೊಡ್ತಾ ಇದ್ವಿ, ಅವ್ರಿಗೆ ಸಪೋರ್ಟ್ ಆಗಿ ಅವ್ರಿಗೆ ನಾವು ನಿಂತ್ಕೊಂಡು ಸಹಾಯ ಮಾಡ್ತಾ ಇದ್ವಿ. ಸೊ ಈಗ ಅವ್ರು ನಮ್ಗೆ ತುಂಬಾ ಕ್ಲೋಸ್ ಆಗಿದ್ದಾರೆ. ಫೋನ್ ಮಾಡ್ತಾರೆ, ನಾವು ಒಂದ್ ವೀಕ್ ಹೋಗಿಲ್ಲ ಅಂದ್ರೆ ಅವ್ರಿಗೆ ಫೋನ್ ಅಲ್ಲಿ ಕಮ್ಯುನಿಕೇಶನ್ ಮಾಡ್ತಾರೆ, ಯಾಕೆ ಬಂದಿಲ್ಲ. ಸೊ ಆ ಟ್ರೈಬಲ್ ಪೀಪಲ್ಗೆ ಫಸ್ಟ್ ಅವ್ರಿಗೆ ಫಂಡಮೆಂಟಲ್ ರೈಟ್ಸ್ ಗಳೇ ಕೆಲವು ಇಲ್ಲ, ಮೂಲಭೂತ ಸೌಲಭ್ಯಗಳೇ ಇಲ್ಲ. ಸೊ ಅವ್ರ ಫಂಡಮೆಂಟಲ್ ರೈಟ್ಸ್ ಇಲ್ಲ, ವಾಟರ್ ಫೆಸಿಲಿಟೀಸ್ ಇಲ್ಲ. ಸೊ ಈ ಜೆನೆಟಿಕ್ ಡಿಸೀಸ್ ಇದೆಯಲ್ಲ, ಮೇನ್ ವಾಟರ್ ಫೆಸಿಲಿಟೀಸ್ ಬೇಕು ಅವ್ರಿಗೆ. ಮತ್ತೆ ಎಷ್ಟೋ ಸಮಸ್ಯೆಗಳು ಅವ್ರಿಗೆ ಫುಡ್ ಇಲ್ಲ, ಸರಿಯಾಗಿ ಫುಡ್ ಊಟ ಮಾಡಕ್ಕೆ ಅವ್ರಿಗೆ ಫುಡ್ ಸಿಗ್ತಾ ಇಲ್ಲ ಅವ್ರಿಗೆ. ಮತ್ತೆ ಬೇರೆ ಬೇರೆ ಹಾಸ್ಪಿಟಾಲಿಟಿ ಬಗ್ಗೆ ಅವ್ರಿಗೆ PSC ಗಳಿಗೆ ಹೋಗ್ಲಿಕ್ಕೆ ತುಂಬಾ ಮೂಲಭೂತ ಸೌಲಭ್ಯಗಳೇ ಇಲ್ಲ. ಸೊ ಇದೆಲ್ಲ ಇರುವಾಗ ಅವ್ರಿಗೆ ತುಂಬಾ ಪ್ರಾಬ್ಲಮ್ ಆಗ್ತದೆ. ಮತ್ತೆ ಹೈಡ್ರಾಕ್ಸಿಯೂರಿಯಾ ನಾವು ಅದಕ್ಕೆ HB ಎಲೆಕ್ಟ್ರೋಫೋರೆಸಿಸ್ ಟೆಸ್ಟ್ ಮಾಡಿಸ್ತೀವಿ, ಮತ್ತೆ ಸ್ಯಾಲಿಬ್ರಿಟಿ ಟೆಸ್ಟ್ ಗಳೆಲ್ಲ ನಾವು ಮಾಡಿಸ್ತೀವಿ, ಮತ್ತೆ ಕೌನ್ಸಿಲಿಂಗ್ ಮಾಡಿಸ್ತೀವಿ. ಅದಾದ ನಂತರದಲ್ಲಿ ಅವ್ರಿಗೆ ಪೇಷಂಟ್ ಐಡೆಂಟಿಫೈ ಮಾಡಾದ್ಮೇಲೆ ವಾಟ್ ಈಸ್ ನೆಕ್ಸ್ಟ್ ಮೇಡಮ್ ಅಂತ ಕೇಳ್ತಾರೆ ಅವರು. ಮತ್ತೆ ನಾವ್ ಏನ್ ಮಾಡ್ಬೇಕು, ಎಲ್ಲಿ ಔಷಧಿ ತಗೋಬೇಕು, ಎಲ್ಲಿ ಟ್ರೀಟ್ಮೆಂಟ್ ತಗೋಬೇಕು, ಈ ತರದೆಲ್ಲ. ಮತ್ತೆ ನಮ್ಗೆ ಏನ್ ಮಾಡ್ತೀರಾ ಈ ತರ ಪೇಷಂಟ್ ಗಳಿದ್ದಾರೆ ಅಂದಾಗ ನಾವು 1-2-3 ಪೇಷಂಟ್ ಗಳನ್ನ ರೆಫರೆನ್ಸ್ ಕೊಡ್ತೀನಿ. ಅಲ್ಲಿ ಕಾಳಪ್ಪ ಒಂದು ಪೇಷಂಟ್ ಇದೆ, ಮತ್ತೆ ತಾಯಮ್ಮ ಅಂತ ಒಂದು ಪೇಷಂಟ್, ಚಿನ್ನಮ್ಮ ಅಂತ ಒಂದು ಪೇಷಂಟ್ ಇದೆ. ಅವ್ರಿಗೆ ಫುಲ್ ಜಾಯಿಂಟ್ ಪೈನ್. ಆ ಜಾಯಿಂಟ್ ಪೈನ್ ಬಂದಾಗ ವಿಂಟರ್ ಸೀಸನ್ ಮತ್ತು ರೈನಿ ಸೀಸನ್ ಅಲ್ಲಿ ಜಾಸ್ತಿ ಆಗೋಗುತ್ತೆ, ಫುಲ್ ಜಾಯಿಂಟ್ ಪೈನ್ ಆಗೋಗುತ್ತೆ. ಮತ್ತೆ ಇನ್ನೊಂದು ವೆಂಕಟರಾಮು ಅಂತ ಒಂದು ಪೇಷಂಟ್ ಇದೆ, ಸಿಕಲ್ ಸೆಲ್ ಅನಿಮಿಯಾ. ಅವ್ರು ಫುಲ್ ಹೊಟ್ಟೆ ಎಲ್ಲ ಫುಲ್ ಊದ್ಕೊಬಿಡುತ್ತೆ, ಫುಲ್ ಸಿವಿಯರ್ ಅನಿಮಿಯಾ. ಅವ್ರಿಗೆ ಅವಾಗ ಬ್ಲಡ್ ಕೊಡ್ಸ್ತಾನೆ ಇರ್ಬೇಕು, ಬ್ಲಡ್ ಹಾಕ್ಸ್ತಾನೆ ಇರ್ಬೇಕು. ಸೊ ಇದೆಲ್ಲ ಆ ಟ್ರೈಬಲ್ ಏರಿಯಾವ್ರಿಗೆ ತುಂಬಾ ಪ್ರಾಬ್ಲಮ್, ಬರ್ಲಿಕ್ಕೆ ಆಗಲ್ಲ. ಎಲ್ಲಿ ಹಾಕ್ಸ್ತಾರೆ, ಎಲ್ಲಿ ಮಾಡ್ತಾರೆ, ಇದು ಈ ತರ ಸಮಸ್ಯೆಗಳಲ್ಲಿ. ಸೊ ಹಾಗಾಗಿ ನಮ್ಮ ದೀಪಾ ಮೇಡಮ್ ಅವರು ನಾವೇನು 3 years ಇಂದ ನಾವು ಈ ಪ್ರಾಜೆಕ್ಟ್ ICMR ಮಾಡುವಾಗ ಅವ್ರು ತುಂಬಾ ಉಪಯೋಗ ಆಗಿದೆ. ಸೊ ನಾವು ಒಂದೇ ಅಲ್ಲ, ಈಗ ಹೈಡ್ರಾಕ್ಸಿಯೂರಿಯಾ ಟ್ಯಾಬ್ಲೆಟ್ಸ್ ತುಂಬಾ ಪ್ರಾಬ್ಲಮ್ ಇದೆ. ಮೇಡಮ್ ಅದನ್ನ ಬೇರೆ ಬೇರೆ ಕಡೆಯಿಂದ ಎಲ್ಲ ಪಾಪ ಅವರು ಹೈಡ್ರಾಕ್ಸಿಯೂರಿಯಾ ಟ್ಯಾಬ್ಲೆಟ್ಸ್ ನ PSC ಗಳಿಗೆ ಸಪ್ಲೈ ಮಾಡಿ ನಮ್ಮ ಮೂಲಕ ನಾವು ಡೈರೆಕ್ಟ್ ಆಗಿ ಅಲ್ಲಿ ತಗೊಂಡೋಗಿ ಕೊಡ್ತಾ ಇದೀವಿ, ಪೇಷಂಟ್ ಗೆ ಸಪ್ಲೈ ಮಾಡ್ತಾ ಇದ್ವಿ. ಮತ್ತೆ ಫೋಲಿಕ್ ಆಸಿಡ್, ಐರನ್ ಟ್ಯಾಬ್ಲೆಟ್ಸ್ ಈ ತರದನ್ನೆಲ್ಲ ಸಪ್ಲೈ ಮಾಡಿ PSC ಗಳಿಗೆ ಅಲ್ಲಿ ಕೊಡ್ತಾ ಇದೀವಿ. ಅದ್ರ ಜೊತೆಗೆ ಕೌನ್ಸಿಲಿಂಗು, ಫುಡ್ ಬಗ್ಗೆ, ಹೈಜಿನಿಕ್ ಬಗ್ಗೆ, ಇದ್ರ ಬಗ್ಗೆ ಎಲ್ಲ ನಾವು ಕೌನ್ಸಿಲಿಂಗ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಸೊ ಹಾಗಾಗಿ ಹೈಡ್ರಾಕ್ಸಿಯೂರಿಯಾ ತುಂಬಾ ಪ್ರಾಬ್ಲಮ್ ನಮ್ಮ ಏರಿಯಾಗಳಲ್ಲಿ ಇದೆ. ಸೊ ಈ ತರದ ಸಮಸ್ಯೆಗಳು ಮುಖ್ಯವಾಗಿ ಟ್ರೈಬಲ್ ಅಲ್ಲಿ ಪಾಪ್ಯುಲೇಷನ್ ತುಂಬಾ ಡಿಕ್ರೀಸ್ ಆಗ್ತಾ ಇದೆ ಇವಾಗ. ಅವ್ರಿಗೆ ಗೊತ್ತಿಲ್ಲ ನಾವ್ ಯಾಕೆ ಚೈಲ್ಡ್ ಡೆತ್ ಆಗ್ತಾ ಇದೆ ಅನ್ನೋದು ಅವ್ರಿಗೆ ಗೊತ್ತಿಲ್ಲ. ಆ ಚೈಲ್ಡ್ ತುಂಬಾ ಡಿಕ್ರೀಸ್ ಆಗಿ ಚೈಲ್ಡ್ ಡೆತ್ ಆಗ್ತಾ ಇರೋದ್ರಿಂದ ಪಾಪ್ಯುಲೇಷನ್ ತುಂಬಾ ಕಡಿಮೆ ಆಗ್ತಾ ಇದೆ. ಸೊ ಇದನ್ನೆಲ್ಲ ಗಮನಿಸಿ ಈ ಜೆನೆಟಿಕ್ ಏನು ಕೌನ್ಸಿಲಿಂಗ್ ಮತ್ತೆ ಇಂಟರ್ನ್ಯಾಷನಲ್ ಸೆಮಿನಾರ್ ಆಗ್ತಾ ಇದೆ. ಐ ಆಮ್ ಆಲ್ಸೋ ಟ್ರೈಬಲ್ ಇನ್ ಸೋಲಿಗಾ ಕಮ್ಯುನಿಟಿ. ಸೊ ಹಾಗಾಗಿ ನಾನು ಮೇಡಮ್ ಅಂಡರ್ ಅಲ್ಲಿ ಕೆಲಸ ಮಾಡ್ತಾ ಇರೋದ್ರಿಂದ ಫಸ್ಟ್ ಗ್ರಾಜುಯೇಟ್ ಅಂಡ್ ಫಸ್ಟ್ PhD ಇನ್ ಕರ್ನಾಟಕದಲ್ಲಿ ತಗೊಂಡಿದ್ದೀನಿ ನಾನು ಸೋಲಿಗಾ ಕಮ್ಯುನಿಟಿಯಲ್ಲಿ. ಬಟ್ ಏನಪ್ಪಾ ಅಂದ್ರೆ ನಾನು ಓದಿದ್ದೆಲ್ಲ ಕನ್ನಡ ಮೀಡಿಯಂ. ನಮ್ ಕನ್ನಡ ಮೀಡಿಯಂ ಅಲ್ಲಿ ನಮ್ ತಂದೆ ತಾಯಿ ಓದಿಸಿದ್ದೆ, ಇದು ಮಹಾ ಸಾಧನೆ. ಸೊ ಹಾಗಾಗಿ ತುಂಬಾ ಫ್ಲೂಯೆನ್ಸಿ ಆಗಿ ನಂಗೆ ಇಂಗ್ಲಿಷ್ ಮಾತಾಡಕ್ಕೆ ಕಷ್ಟ. ನನ್ನ ಮಗಳು ಡಾಕ್ಟ್ರು ನೀಟ್ ಅಲ್ಲಿ ಇವಾಗ ಬೆಂಗಳೂರು ಮೆಡಿಕಲ್ ಕಾಲೇಜಲ್ಲಿ ಈಗ ಫಸ್ಟ್ ಇಯರ್ MBBS ಸ್ಟಡಿ ಮಾಡ್ತಾ ಇದ್ದಾಳೆ. ಫಸ್ಟ್ ಮಗಳು ಇಂಜಿನಿಯರಿಂಗ್ ಮುಗಿಸಿ ಇದೇ JSS ಕಾಲೇಜಲ್ಲಿ UPSC ರೆಡಿ ಆಗ್ತಾ ಇದ್ದಾಳೆ. ಸೊ ಇದೆಲ್ಲ ಕಾರಣ ಎಜುಕೇಶನ್. ಮೇಡಮ್ ಯಾರು ಹೇಳಿದ್ರು ಎಜುಕೇಶನ್ ತುಂಬಾ ಮುಖ್ಯ, ಎಜುಕೇಶನ್ ಬೇಕು, ಅವೇರ್ನೆಸ್ ಬರ್ಲಿಕ್ಕೆ. ಎಸ್ ಕರೆಕ್ಟ್. ಯಾಕಂದ್ರೆ ಈ ತರದೆಲ್ಲ ಜೆನೆಟಿಕ್ ಡಿಸೀಸ್, ಸೋಷಿಯಲ್ ಎಕನಾಮಿಕ್ ಪೂರ್ ಕಂಡೀಷನ್ಸ್ ಮತ್ತೆ ಎಜುಕೇಶನ್ ಯಾರಿಗೆ ಇಲ್ಲ ಅವ್ರಿಗೆ ಅವೇರ್ನೆಸ್ ಬರ್ಬೇಕಾದ್ರೆ ಎಜುಕೇಶನ್ ಬೇಕೇ ಬೇಕು. ಸೊ ಹಾಗಾಗಿ ಎಜುಕೇಶನ್ ಮತ್ತು ಸೋಷಿಯಲ್ ಎಕನಾಮಿಕ್ ಥಾಟ್ಸ್ ಮತ್ತೆ ಅವೇರ್ನೆಸ್ ಎಲ್ಲಿ ಇರುತ್ತೆ, ಇದನ್ನ ನೀವೆಲ್ಲ ದೊಡ್ಡ ದೊಡ್ಡ ಸಾಧನೆ ಮಾಡಿರೋರು ನಿಮ್ ಜೊತೆಗೆ ನಾನು ಚಿಕ್ಕವಳು ಕೂತ್ಕೊಂಡು ಮಾತು ಹೇಳ್ತಾ ಇದ್ದೀನಿ. ಸೊ ಅದ್ರ ಜೊತೆಗೆ ಎಜುಕೇಶನ್ ಇದ್ರ ಕಡೆ ಅವೇರ್ನೆಸ್ ಇರುತ್ತೆ. ಮತ್ತೆ ಸೋಷಿಯಲ್ ಸ್ಟಿಗ್ಮಾ ಅಂತ ನಾವ್ ಏನಿರ್ತೀವಿ ಅದನ್ನ ನಾವು ಸ್ವಲ್ಪ ಇದ್ ಮಾಡ್ಕೊಂಡು ಮುಂದೆ ಹೋಗಿ ನಮ್ಮ ಸ್ಟೇಟಸ್ ಆಫ್ ಹೆಲ್ತ್ ನಮ್ನ ಹೇಗೆ ತಗೊಂಡು ಹೋಗ್ಬೋದು ಅನ್ನೋದನ್ನ ನೀವೆಲ್ಲ ಕಾಪಾಡ್ಲಿಕ್ಕೆ ಸಾಧ್ಯ ಆಗುತ್ತೆ. ಅದ್ರ ಜೊತೆಗೆ ನಾವು ಕೈಗೂಡಿಸ್ತೀವಿ ಅಂತ ಈ ಸಂದರ್ಭದಲ್ಲಿ ಹೇಳ್ತಾ ಇದ್ದೀನಿ. ಸರ್ ಹೇಳ್ತಾ ಇದ್ರು ತುಂಬಾ ಇಂಪಾರ್ಟೆಂಟ್ ಎಜುಕೇಶನ್ ಮತ್ತೆ ಸೋಷಿಯಲ್. ಪೇರೆಂಟ್ಸ್ ಗಳಿಗೆ ಎಜುಕೇಶನ್ ಇಲ್ಲ ಇಂಥ ಏರಿಯಾದಲ್ಲಿ, ನನ್ನ ಏರಿಯಾದಲ್ಲಿ ಎಸ್ಪೆಷಲಿ ಪೇರೆಂಟ್ಸ್ ಗಳಿಗೆ ಜೆನೆಟಿಕ್ ಅಂದ್ರೆ ಏನು ಗೊತ್ತಿಲ್ಲ, ಕೌನ್ಸಿಲಿಂಗ್ ಅಂದ್ರೆ ಏನು ಗೊತ್ತಿಲ್ಲ, ಟೆಸ್ಟಿಂಗ್ ಅಂದ್ರೆ ಏನು ಗೊತ್ತಿಲ್ಲ, ಸ್ಯಾಲಬಿಲಿಟಿ ಟೆಸ್ಟ್ ಅಂದ್ರೆ ಗೊತ್ತಿಲ್ಲ, ಸೊ HB ಎಲೆಕ್ಟ್ರೋಫೋರೆಸಿಸ್ ಟೆಸ್ಟ್ ಅಂದ್ರೆ ಗೊತ್ತಿಲ್ಲ. ನಾವು ಬ್ಲಡ್ ತಗೊಳ್ಳೋಕೆ ಹೋಗುವಾಗ ನೀವು ಬ್ಲಡ್ ತಗೊಂಡು ಯಾರಿಗೂ ಮಾರಾಟ ಮಾಡಕ್ ಹೋಗ್ತಾ ಇದ್ದೀರಾ? ನೀವು ಬ್ಲಡ್ ತಗೊಂಡು ನಮ್ಮ ಮಕ್ಳು ಬ್ಲಡ್ ತಗೊಂಡು ಯಾರಿಗೂ ಬಿಸ್ನೆಸ್ಗೆ ವ್ಯಾಪಾರ ಮಾಡಕ್ ಹೋಗ್ತಾ ಇದ್ದೀರಾ? ಮತ್ತೆ ನಮ್ಮನ್ನೇ ಕೇಳಿ ಎಷ್ಟೋ ಜನ ಮಚ್ ತಗೊಂಡ್ ಬಂದ್ ನೋಡಕ್ ಬಂದಿದ್ದಾರೆ. ಆದ್ರೆ ಅವನ್ನೆಲ್ಲ ನಾವು ಗಲಾಟೆ ಒಂದು ಕೌನ್ಸಿಲಿಂಗ್ ಮಾಡಿ ಅವೇರ್ನೆಸ್ ಕೊಟ್ಟಿದ್ವಿ. ಸೊ ಹಾಗಾಗಿ ಇದು ತುಂಬಾ ದೊಡ್ಡ ಒಂದು ಸಾಧನೆ. ಎಲ್ಲ ಇಲ್ಲಿದ್ದೀರಾ. ಸೊ ಹಾಗಾಗಿ ನಾನು ಈ ಸಂದರ್ಭದಲ್ಲಿ JSS ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಮತ್ತು ನಮ್ಮ ದೀಪಾ ಮೇಡಮ್ ಟೀಮ್ ಅಲ್ಲಿ ನಾವು ನಿಜವಾಗ್ಲೂ ಕೆಲಸ ಮಾಡ್ತಾ ಇದ್ವಿ. ಯಾಕಂದ್ರೆ ಎಷ್ಟು ಜನಗಳಿಗೆ ಅವೇರ್ನೆಸ್ ಕೊಡ್ತಾ ಇದ್ವಿ. ಥ್ಯಾಂಕ್ಸ್ ಟು ದೀಪಾ ಮೇಡಮ್ ಮತ್ತೆ JSS ಅನ್ನೋದಕ್ಕೆ ನಾನು ತುಂಬಾ ಇಷ್ಟ ಪಡ್ತಾ ಇದ್ದೀನಿ. ಥ್ಯಾಂಕ್ ಯು.
I'm just going to quickly translate. So, sorry. Yes, yes. So, the person who spoke just now, Ms. Ratnamma, okay, so she has a PhD from JSS as a part of an ICMR project. So, initially she was from an arts background, but then she belongs to a Soliga community, right? So, after looking at her community, she wanted to do something for them. So, she got into life science. So, as she was studying, so she saw that there were a lot of these genetic disorders that were actually prevalent among these tribals, but there was no awareness about it and people did not even know that they had some disorders. It's just that there are multiple affected individuals and they had to go door to door, patient to patient, and even then they had to connect with each patient as a family member before they could even suggest genetic testing to them. So she has taken a lot of efforts over the years. She's taken help from ASHA workers, Anganwadi workers, and a lot of other doctors. Dr. Deepa has helped out, JS's team has helped out. So everybody has helped them reach out to them, even to get medications. So these tribal community, they do not have access to proper hygiene itself. They are not aware of what are the healthy practices that they need to do on a routine basis. But now they have reached a level where they come and ask, say, I have this history, I want the medication, I want to know what is the disorder. So they have identified thalassemia, sickle cell anemia, many such disorders in those communities. And the thing is, the population of these tribals have come down drastically because number of these children have died due to these disorders. So now, ultimately, what she is really strongly wanting to share with us is that because of education and awareness, she was able to do all this. And she wants us all to join hands with her to reach out to more people. Right? And she's really grateful to Dr. Deepa Bhatt and the ICMR and the JSS team for actually helping her reach so many patients. And she wishes that all of us here go work hand in hand and do the same. Thank you, Ratna.
Pooja, what's her name?
Ratnamma.
Ratnamma. I would want to add on. In Tamil Nadu, we are doing this work in all the complete tribal area is covered. All the villages, all the PHCs. And the way we work is, we train the complete health system. The VHN, the SHN, the CHN. Everybody is taught what the disorder is. Quick identification. Then they bring them to the PHC doctors. They do a differential diagnosis. We still bring them to the neurologist because we are working on neuromuscular before we take the sample. So this particular project in Tamil Nadu for Dushi, we have covered the entire state. All our VHNs, they know. We show them the video. We do that. So it's just not we doing and getting out. We want to really capacity build there. And in Tamil Nadu, we have 3 tribal areas, mainly in the Ooty region and in the Salem region. And Ashas are wonderful. I would say, really to all the counselors, I want to say, the whole project as such, this just March 2022, we have covered the entire state of Tamil Nadu for Duchenne muscular dystrophy with a vision by 2020. Of course, it was a 2020 vision. It became 2022 because of the pandemic. By year 2022, Tamil Nadu will be a state where there is no kid with Duchenne who will go unidentified. We need to identify. The main thing is, again and again for counselors, we have a big role. We identify to prevent it in the next generation. That is the most important. We know there is no cure. What is the point in having more and more children? They are not aware. The village people, you say, otherwise they just put the child inside the house. You don't even know there is a kid like that. I have seen a mother in Madurai with 6 Duchenne kids. You won't believe, 6 boys, 3 no more, 3, and she was taking the last one in. What is the public health system doing? We have a big growth. When I went to the government, they said, no, we don't need counselors. We will manage with the SHNs. SHNs are all 10 standard or 12 standard. Nothing to demean them. But counseling is an art by itself. It needs a background. It needs a skill. We need to teach them. And of course, now I'm so contented in the work. The entire state we have identified, we have established the carrier status, and we have ensured all the familial cases. There is no more kid with Duchenne in the family. There is no cure. And there is a responsibility in all of us. So I'm so happy she brought it out. And Amma in Tamil Nadu, every VHN, SHN, and CHN has a knowledge of Duchenne. And any time later, because you know it's a huge gene, you might get new mutation, they will immediately pick up and they know where to come.
and we move to prevent it. We have a huge role, and today only the national policy has come for rare disorders. We have been working for the last 10 years, and this is the 10th year. We have been redefining Duchenne, and we have been working with the 2022 vision. We have covered. There is nothing, oh, we don't know the numbers, we don't know the numbers. We have a big group. We know the clinicians are busy, there are lots of other things, but we have a role and we have to establish ourselves. And what we do and again, it doesn't come once, taking a carrier sample or thing. You need to build a rapport with the patient and the family. Today you won't build it from the villages itself, because we don't take samples before they are 18 for the carrier girls. So we tell the patient when she's 18, please call us up. We need to take the carrier sample. We need to check. And again, she's 50% chance of getting a normal kit. Otherwise, you check it out, we can handhold her to get a normal kit. There is no issue. So now, after 10 years, we are getting phone calls saying, Madam, 18 years when we have to bring the girl for carriers. That is what we have achieved. And I'm saying again, we have the numbers. The policy says, oh, you don't know. Unless you have numbers, how can you make a policy? How can you know what you need to do next? So I'm so thankful and so happy you have done it. Congratulations. Thank you.
Thank you, Ratnama, for sharing your experience. Ratnama ಅವರೇ ಧನ್ಯವಾದಗಳು ನಿಮ್ಮ ಅನುಭವವನ್ನು ಹಂಚಿಕೊಂಡಿದ್ದಕ್ಕೆ. I thank the presenters for bringing up the rare condition to our knowledge. Thank you. Moderators, please.
I once again thank the organizers for giving me the wonderful opportunity to answer this chairperson. Thanks a lot, and I extend my gratitude to Department of Pediatrics, Mysore Medical College. Thank you.
Good morning, everyone. I'm Dr. Chaitra. I'm a faculty at Genetics and Genomics, University of Mysore. Today here we are talking about the genetic disorders and all those stuff. And Ratnama to relate, and Madam also said there should be some policy regarding this. And Madam also said we should sensitize the kids at the school level for all these genetic disorders. I worked on recurrent pregnancy loss for my thesis, and even today, even recently, what we see is everybody are blaming the females. Okay, there is no, even today there is no knowledge that even male is contributing for the girl child. Okay, so recently we had a case. The guy, he's a very he's a high paid job in Bangalore in a very high firm, and 2-3 recurrent pregnancy losses, and we had done all A to Z test on the female. She is normal. But when we did the semen analysis, severe teratospermia. But he is not ready to take up the blame and accept the fact that it is because of him. So where do we stand? Ratnama said in tribal areas, they are not educated. Even here, contrarily, he is highly educated, but he is not ready to accept the fact. I think now we have ads and other informative ads going on in TV or in the hospitals, where they have stuck like female feticides, and also the sex determination is to be avoided. I think we also should educate each and every person that about this, regarding that the males actually play a role for a female kid, not the female to be blamed. And recently also we had a case where the female has come and she has come for the scanning, and the in-laws, they have got all her belongings, and only if she is pregnant they will take her back. If she is not pregnant, they will send her to the MICA and to see that the male is azoospermia. So what do we do? So I think we should do this. Okay, thank you.
Thank you, one and all. Thank you. It was a great session and discussion. Now we'll move to the next session on cystic fibrosis. I request the chairperson to introduce Dr. Sushmita and Dr. May.
Before I introduce Dr. Sushmita, as a parent of a suffering from a rare disease child, a doctor is one who takes care of my child, who works for the betterment of my child. Having said, everybody is a doctor to me, and today, July 1st, is a Doctor Day. And on behalf of ORDI, I wish all the doctors in this room and outside this room, I wish you happy Doctors Day. I request Dr. Sushmita to be on the dais. She is going to present a case on cystic fibrosis. She is a third year junior resident in MD Pediatrics from Mysore Medical College and Research Institute. She has completed her MBBS from Father Muller Medical College, Mangalore. Career highlights: ICMR short-term studentship project in 2014 on efficacy of PAP stain in detection of Mycobacterium tuberculosis in sputum sample and its comparison with ZN stain and rhodamine stain. Welcome, Doctor. Dr. Megha, who is a senior resident in Mysore Medical College and Research Institute. She has completed her MBBS MD Pediatrics from Bangalore Medical College. Her interests are in research, genetics, metabolic disorder, and neurology. She has completed MBBS and with a gold medalist in otorhinolaryngology and pediatrics and MD Pediatrics, and she's a college topper and she has multiple publications. Welcome, doctor. You can start.
Good afternoon, Manindra. Myself, Dr. Sushmita. Firstly, happy Doctor's Day to all the doctors out there. And I want to thank Dr. Deepa ma'am for providing me this wonderful opportunity. To start with my case, this is a tale of a consistent that is cystic fibrosis. As a clinician, often we come across with challenging cases. This is one among those challenging cases which we recently came across in our hospital. And this case also enlightened me how genetic analysis can make or break a situation and the importance of genetic analysis in patient management. This is a story of 5 months. Next slide, please. This is a story of 5 months old child who presented with vomiting, loose stools since 3 days and fever with hurried breathing since 1 day. No significant past history or family history. I apologize for not having a pedigree chart. And mother conceived spontaneously at age of 24 years. Bookcase with no comorbidities. Baby was born full term with birth weight of 3 kg and exclusively breastfed and well-thriving child and developmentally appropriate for age. On receiving, we found signs of shock with respiratory failure, for which child was intubated and resuscitated accordingly with fluid boluses and inotropes and antibiotics. So at the end of the history and examination, we thought it's a simple case of gastroenteritis with dehydration or a septicemia with septic shock, and which was treated accordingly, and few relevant investigations were done. And investigation showed us that there was a mixed metabolic acidosis with DIC picture, and along with that, this electrolyte. So initially, we started with antibiotics, inotropes, and this electrolytemia was treated with the corrections. On one side, my patient started improving with the treatment. But on the other side, as soon as we stopped our electrolytes correction, child again continued to have persistent dyselectrolytemia. Somehow on the other side, like the respiratory component and the cardiovascular component improved with the therapy. We tapered ventilator setted and inotropes, and child was extubated on day 12. But child was O2 dependent for a prolonged time, which we treated with regular nebulizations and chest X-ray, and CT was also done to see in underlying condition, and 2-day echo was also done because hypoxia was not improving. And CT showed that basal segmental collapse with patchy consolidation. But child hemodynamically stabilized, but dyselectrolytemia continued to persist. And one more incidental finding what we noticed was patient started with persistent hypertension and metabolic alkalosis. So with hyponatremia, hypokalemia, metabolic alkalosis and hypertension, we thought, are we dealing with something hyperaldosteronism state? And is there is an underlying cause why my patient is having persistent dyselectrolytemia? For which we took endocrinologist opinion and certain investigations were advised, and those investigations revealed us that aldosterone was low normal and plasma renin activity was low and serum cortisol was high, and calcium and creatine ratio and sodium bicarbonate, vitamin D as about old. But at the end of the investigation, what we realized was we have a patient with persistent dyselectrolytemia, along with the low plasma renin activity and low plasma aldosterone and elevated cortisol level with hypercalciuria. This helped us to narrow down our diagnosis to apparent mineralocorticosteroid excess, Liddle syndrome, and a variant of congenital adrenal hyperglycemia. So if we see the list of investigation, what we have got, it is really a expensive test which we advise for our patient, and still with all those investigations we ended up with 3 diagnoses and we couldn't conclude. So this point, Deepa ma'am helped us, saying that genetic analysis could give a definitive diagnosis, and it can reduce the time and help us to final diagnosis for the rapid diagnosis, and multiple hormonal level and metabolic assay to rule out the other conditions was time consuming, and it was not readily available in our hospital, for which we got genetic analysis done, and we had Kahani Mein twist. It turned out to be cystic fibrosis, which was not at all in our differential diagnosis. So does this mean that we were wrong from our part? Because there was a clear-cut hyponatremia, hypokalemia, hypertension, hypocalcemia, hypocalciuria, and also child responded to spironolactone therapy, which these are the points which favored us towards apparent mineralocorticosteroid excess. But considering this genetic analysis report, which is saying that likely pathogenic in 2 mutations, so on retrospective analysis, we analyzed whether my child is having cystic fibrosis, atypical presentation. On that, the GI symptoms and respiratory failure which my patient presented, and the prolonged oxygen therapy and metabolic alkalosis with hypovitaminosis and vitamin D, and we thought renal vein thrombosis due to the central line insertion was an incidental finding. But there are case reports which is saying that cystic fibrosis can also present with this presentation. So we couldn't conclude whether like apparent mineralocorticosteroid excess has been ruled out, or my patient is a case of cystic fibrosis, for which we took Deepa ma'am's help, and she advised that there can be an overlap of both, and this can be an atypical manifestation of cystic fibrosis or a evolving case of cystic fibrosis. Now presently, child is on regular follow, additional vaccination and precautions to reduce the morbidity and prolong the life expectancy has been considered, and re-evaluation of genetic analysis has been planned for the future. And again, when as a clinician, we are only at doubt what to counsel the patient. So this is where like genetic counselor has helped us a lot. So now I request Dr. Megha ma'am to continue.
Good afternoon, everyone. Happy Doctors Day, everyone. And I'd really like to thank the organizers for providing us this opportunity. And we are actually not so experienced in this genetic analysis. And I think there are much more experienced people here sitting. So who would guide to us in this challenging case, where initially there was a acute presentation of like an acute GE with dehydration, dyselectrolytemia, which we thought over the acute crisis settles it is resolved. But then we had this challenge of persisting dyselectrolytemia. And on discussions with endocrinologists, we thought of a diagnosis of apparent mineralocorticoid excess and a variant of CAH, Liddle syndrome. But we were not able to narrow down the diagnosis, and which required further multiple hormonal panel level analysis. And those tests were very expensive, and the availability was an issue. In Mysore, we couldn't get, and even in situation, even in Bangalore, it was not available for multiple confirmatory tests. We had to send the samples to Bombay and Delhi. So affordability, availability, timing, all these were issues. So with the guidance from Dr. Deepa ma'am and our endocrinologist, we went for a genetic analysis. But then, till now, we had counseled the patients regarding endocrine abnormality. But then, after the genetic report, we again had a challenge that the whole diagnosis changed. So now we are in this dilemma of whether to completely accept this, or is there any, should we rule out the apparent mineralocorticoid excess completely, or is there some when we discussed with the endocrinologist after the report, she said there are like case reports which have association of cystic fibrosis with apparent mineralocorticoid excess. So now we are like whether we have to further go with whole exome sequencing, and I would like to ask about whether there is what is the role of initial clinical exome sequencing, or should we prefer for a whole exome sequencing? So I think this will be a good platform to discuss such doubts from as clinicians. It would be helpful for us.
I see that you have already done these results that you've got are showing likely pathogenic results. They are not clearly pathogenic. So we have to take these results with caution. And so this was done using clinical exome, or did you directly get
Clinical exome.
Clinical exome. Yes. Generally, what people do is that most popular test like for the present and the past, people would go for clinical exome analysis for various reasons. Like the companies are also are offering these tests, the labs, and for them also it is easier to perform this test. It's a targeted sequencing test, it's a limited gene, but the regions of the genes which are all of clinical significance. So they are looking at all the genes, the target genes with the clinical significance. So when you expect something, when you're sure of something that you're really expecting a particular condition, you want to confirm it, then you go for clinical exome. But since this has shown likely pathogenic and you are still not sure, you want to get other tests done, maybe whole exome could be done, but you have to still remember that whole exome is also like expensive test. It's not it's like very cost effective or something, and you have to read it when you get the report for after analysis. You have to read in between the lines what they are saying about the limitations of the test and what are the points that you should really consider and whether the results are reliable or not as such. When one is not very sure, then they are going in for the. And now more and more people are going for the. Sometimes doing clinical exome, whole exome, you do not get any results, or even if you get are variants of uncertain significance. So you may not get results in there and such. That's the present scenario with the high-end genetic tests. Keeping that in mind.
Because we had response to the treatment.
Really very important, and also there's response to therapy. So I would request the lab to do a reanalysis and also ask them to look at the pathway genes, not just the gene. And like Jaya said, many times you say clinical exome, but it is the whole exome that the company does. So if you ask them to reanalyze, and they will come up with an answer, a better answer. And in that, mostly genetic counselors help. So we also ask them to do manual reanalysis.
Thank you.
Just that can ask them to do. And that wouldn't be an expensive thing. That probably on medical charges.
Can I comment one? Just to sum up, a very nice case where we have important policy decision people here also. And our population, Indian, is so multi-genetically diverse. Just remember, and for all the youngsters over here also, whatever you get, and if you get the negative report, don't get disappointed. There could be something else associated with it. Even likely pathogenic is important. Even if you get VUS, you have to go in a depth and find out. That could be important in our population. That could be a rare case to publish from Indian population, remember. And cystic fibrosis is coming again and for the newborn screening. The simply on third day, when you had, but that time you had no clue. It came out later on, right? But likely pathogenic are important variants established as mutants. But VOS, even if you get sometimes and associated with other, because there could be two something different points and the variation on two different genes, and combinedly they will be having some effect. So one has to go for such a case at the research level down, academic, and that will be your new publication. And as a research policy, those who can afford cystic fibrosis, a very simple 200 rupees test can be introduced in healthcare as a newborn screening test. Thank you.
Our patient would like to share her experiences in the whole course.
ಎಲ್ರಿಗೂ ಶುಭ ಮುಂಜಾನೆ ಶುಭ ಮಧ್ಯಾಹ್ನ. ಏನಪ್ಪಾ ಅಂತಂದ್ರೆ ನಾನು ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ಫಸ್ಟ್ ಅಡ್ಮಿಟ್ ಆದಾಗ ಈ ತರ ಪ್ರಾಬ್ಲಮ್ ಇರುತ್ತೆ ಅಂತಾನೆ ಗೊತ್ತಿಲ್ಲ. ಆಮೇಲೆ ಒಂದು 20 ದಿನ ಆದ್ಮೇಲೆ ಹೇಳಿದ್ರು ನಿಮ್ಮ ಮಗುಗೆ ಬ್ಲಡ್ ಅಲ್ಲಿ ಉಪ್ಪಿನಂಶ ಜಾಸ್ತಿ ಇದೆ, ಅದಕ್ಕೆ ಮೋಷನ್ ಆಗಿರೋದು ಅಂತ ಹೇಳಿದ್ರು. ಅವಾಗ ನಮ್ಗೆ ತುಂಬಾ ಬೇಜಾರಾಯ್ತು, ನಮಗ್ ಗೊತ್ತೇ ಇಲ್ಲ ಈ ತರ ಪ್ರಾಬ್ಲಮ್ ಇರುತ್ತೆ ಅಂತ. ಸುಷ್ಮಿತಾ ಮ್ಯಾಮು ನೀರು ಡಾಕ್ಟರ್ ಹತ್ರ ಕೇಳ್ಕೊಂಡು ಟ್ಯಾಬ್ಲೆಟ್ ನ ಸಜೆಸ್ಟ್ ಮಾಡಿದ್ರು, ಸ್ಪೈರಲ್ ಆಕ್ಟನ್ ಅಂತ. ಅದನ್ನ ಹಾಕಿದಾಗ ಒಂದು ಕಮ್ಮಿ ಆಯ್ತು. ಆಮೇಲೆ ಬ್ಲಡ್ ಅಂಶ ಕಮ್ಮಿ ಆಗ್ತಾ ಬಂತು. ಆಮೇಲೆ ಹೇಳಿದ್ರು ಇದು ತುಂಬಾ ಕಾಸ್ಟ್ಲಿ ಆಗುತ್ತೆ, ಒಂದು ಬ್ಲಡ್ ಟೆಸ್ಟ್ ಮಾಡಿಸ್ತೀರಾ ಅಂತ. ನಮ್ಗೆ ಅವನಿಗಿಂತ ಹೆಚ್ಚು ಇನ್ನೇನು ಬೇರೆದಿಲ್ಲ ಅಂತ ಅನಿಸ್ತಾ ಸಮಯದಲ್ಲಿ ಆವಾಗ ನಾವು ಮಾಡಿಸ್ತೀವಿ, ನಮ್ಗೆ ಕಷ್ಟ ಆದ್ರೂ ಮಾಡಿಸ್ತೀವಿ ಅಂತ ಹೇಳಿದಾಗ ದೀಪಾ ಮ್ಯಾಮ್ ನಮ್ಗೆ ತುಂಬಾ ಹೆಲ್ಪ್ ಆಯ್ತು. ಅದು ಸಮಸ್ಯೆ ಇದೆ ಅಂತ ಮೊದಲು ಟ್ಯಾಬ್ಲೆಟ್ ಕೊಟ್ಟಿದ್ರು. ಅದು ಉಪ್ಪಿನಂಶ ಕಮ್ಮಿ ಆಯ್ತು, ಮತ್ತೆ ಬಿಪಿನೂ ಕಂಟ್ರೋಲ್ ಆಗ್ತಾ ಬಂತು. ಆಮೇಲೆ ತೃಪ್ತಿ ಮ್ಯಾಮ್ ಮೀಟ್ ಮಾಡಕ್ ಹೇಳಿದ್ರು, ಅವ್ರನ್ನು ಮೀಟ್ ಮಾಡಿದ್ವಿ. ದೀಪಾ ಮ್ಯಾಮ್ ಸಹ ನಮ್ಗೆ ಜೆನೆಟಿಕ್ ಟೆಸ್ಟ್ ಮಾಡ್ಸಕ್ಕೆ ತುಂಬಾ ಹೆಲ್ಪ್ ಮಾಡಿದ್ದಾರೆ. ನಮ್ಗೆ JSS ಆಸ್ಪತ್ರೆಯಿಂದ ತುಂಬಾ ಹೆಲ್ಪ್ ಆಗಿದೆ. ಥ್ಯಾಂಕ್ ಯು ದೀಪಾ ಮ್ಯಾಮ್. ಇಷ್ಟನ್ನ ಹೇಳಕ್ ಇಷ್ಟಪಡ್ತೀನಿ ಮ್ಯಾಮ್.
The mutation most common even in India and the outside countries is F508 mutation, the deletion of F508.
Then it might not make sense to be to call them pathogenic or likely pathogenic, because then they're very common in Indian context.
When we check the literature, sir, they say there are like 1,900 mutations which can happen in the gene. And because our country being very heterogeneous races, heterogeneous population, there is not like a very fixed set of mutations. Even for testing of cystic fibrosis, we usually test for the 30 to 90 genes, usually which are most common in our country. And this will identify around 90% of the patients. So this is what the literature, from the literature we could get, sir.
Although I'm not a doctor, but usually they talk about a sweat test when it comes to cystic fibrosis. About that.
Again, availability was an issue for us, sir, and cost also. So the diagnosis says that we can diagnose either by a high sweat chloride test or by identifying two genetic mutations suggesting for cystic fibrosis.
Again, I need to reiterate that one, patients supposed to play an important role in this. And we as an ORDI, we have a separate chapter for cystic fibrosis itself, with more than doctors from 12 states have come together, patients are there. And on ORDI, we also support the patient with low-cost medicines and other things for long term. Another important point which came out is when the mother said, although she's not economically well placed, but she said, for my children, I can do anything. Morning also we discussed this. So once again, I would like to request doctors, while you play a parental role for the patients, but please don't judge the patient, because for mother or a parent, everything. Give them a chance. Thank you.
Excuse me. I would like to add a point. Myself, Dr. Sangeeta. I'm coming from Trivandrum. I am a scientific officer to a genomics company. So the basic part of my work is usually analyzing those variants that had been shown on screen most of the time. So what we get to know, like, although now we talk about genetics and now the scale of understanding genome has gone into genomics, which is extensive, huge amount of data coming in, and we on a day-to-day basis, we really find it difficult to get the right information onto the table of a clinician as from the clinician to the patient itself. Because there are, as she was saying, like we get likely pathogenic variants. These informations are basically based on what American College of Medical Genetics has given us, or what they call as pathogenic or non-pathogenic. There is huge gap between Indian data as well as international data. What might be importance in a American condition may not be the same for us. So we are still waiting for the Indian genome work to come up actually to support all these things to be analyzed in a proper way. So meanwhile, when it comes to interpreting those data, we are far, behind because we are not collaborating with the right team of groups who are actually internationally working on, consolidating all these information. Because we need to actually tie up with those groups who are working on these variants on a day-to-day basis. If we really come across and work together, these information, how these variants are managed or how they have been clinically interpreted, how they have been counseled, all this has to be done on a single platform. So which would actually help the clinician to make the appropriate treatment decision based on these findings. And literally on a personal level, there has been instances when you literally have to. Actually, I worked not just on diseases. We also work on wellness. So when it comes to a genetic counseling, when we say we wish to schedule counseling for a person who is normal and taken for wellness test, they say I don't have a psychological problem. So counseling, taking that up as genetic counseling is also a word. I come from Kerala, which is 100% literate state, but still there is a huge group of people who don't know about genetics or genetic counseling as of now, and we are talking about genomics or genomic testing to them. So, and if my homework is good, I'm sure that there are no genetic counseling courses also in Kerala. So that's one reason for which I have come here as well. There is a
Thank you, Dr.
potential.
Sangeeta. No, I will actually definitely address that in our next session.
Yes.
No, it's really, we are really happy that we're all here for the same reason.
Right.
But in the interest of time, I'm going to have to stop you, but thank you so much
Yeah.
for sharing.
Thank you.
So, we all had a lot of questions during the sessions, and I know we have more questions. We will definitely address them later, but at this point, we just have one quick question to the panel. I would request Purnima to ask a question to the panel.
Thank you, Pooja. Dr. Moha, ma'am, can you address this one? Like how policy interventions can help these sort of cases? Thank you for bringing this up. So we have been discussing a lot of challenges that we are facing in terms of handling the genetic diseases, and more so in terms of rare conditions. In terms of policy interventions, there could be a way out to bring together all the actors who are involved in various phases of treatment, diagnosis, counseling, just hand holding of the patients and the patients themselves in terms of specific need for each of the diseases, and a policy that takes care of all the stakeholder needs is something that can take forward. Having said that, we all expect that, especially in case of rare disease, we look forward to one particular policy which has come up, and we expect that it will solve most of the problems. However, it has to be a more comprehensive approach with multiple policies having a perspective for rare diseases, like the national health policy, the public health policy, like National Health Mission, Rashtriya Bal Suraksha Karyakram, from very base root level where maybe the public health workers, including the ASHA workers, the Anganwadi workers, they are made aware of the rare conditions. not specific conditions, which is not possible, but in general, just identifying the patients, referring them to the tertiary health center as soon as possible. From there, taking on to the tertiary healthcare centers who can connect to the easy transition to the genetic counselors, because for rare disease patients, diagnosis odyssey is already so difficult that genetic counselors should not come up as another, just point of contact where they have to, come another day to the hospital to meet yet another doctor. Rather, it should be a smooth transition, just, people coming together to help the patient rather the patient running from door to door. And then, as we had a brilliant example of Dr. Sorry, I didn't get the name, but someone who is working at the tribal health level and who can actually coordinate with a center like JSS, she has been doing so, and then holding the hands and working together. And so then orphan drug policy. We have had examples of Duchenne muscular dystrophy in India, where the patient advocacy group based in Bangalore, many of you must be knowing about that, who have worked together to come up with a therapy and to go to the clinical trial. They have worked with the government to bring an expedited orphan drug approval system, which was just 5 years back not there. 2019, New Drug and Clinical Trials had a special provision for orphan drugs. And now in India, for import of the drugs, approval of rare disease drugs, we have special provisions. So that is where policies can play a role in bringing doctors and genetic counselors together. Policy can play a role in mandating newborn screening. But in all of that, all of us, the stakeholders, have to work together, have to generate awareness, which many of the patient advocacy groups are doing. And it's my humble request to the genetic counselors, as doctors have to work with you, then the next step would be you working with the patient advocacy group. So if all of this can come together, I think there's a long way ahead which we could move to make things possible, which might not be looking for. With that,
Prasanna sir, your thoughts, please. Dr. Jay.
This person, as well as a genetic counselor, and but I would say good policies are definitely needed, and what are being worked on would definitely streamline the whole process. It will harmonize the whole system and process, which would be finally be helpful in the all achieving all our common goal of identifying the genetic conditions and treating them at the right time, diagnosing them at the right time, and sort of helping the patients and their families in alleviating their economical, social, psychological, and emotional, and of course preventing them in future. That's the best.
The policy will not come with you. When the diseases are treatable, okay, then the ecosystem works with the government to bring the policy because there is a business interest. We are talking about the condition where 95% of the country. So obviously you do not have that third force to influence the policy. It's only all of us have to make an effort. If doctors and genetic counselors make an important piece here to convince the parents, new parents coming in, that please join the movement either with the patient groups or wherever it's possible. Only then the policy can come. Only sitting in the four walls saying that we need a policy is not going to happen. We took 10 years even to bring that the national policy for rare disease, where at least government has recognized it. Okay, it may not help all of us. That is one point. Second one is health is a state subject. Every state we have to make and replicate this effort. It's just by getting a national policy for rare disease in India today what we have. If you look at it, the group 2 diseases are left to the state government without any direction. Unless and until we make effort in every state with every patient group, every disease condition, it's not going to happen. So that is where it's everybody's work. And if you have to make a healthy nation for such condition, all of us have to work together. One. Second, when it comes to genetic counselor, I always call them Jor ka Jatka Dheere se lage, who helps transition the parents to get understand the situation and slowly get. And the word a patient group plays a role of a traffic cop, which you can go here and I think we need to work together.
Thank you, sir. We thank all the chairpersons, speakers, and the patient families. Now, Dr. Deepa will take over.
We have come to end of session. I think was a great beginning for the 7th BGCI annual conference. In the interest of the time, we are compelled to close the session so that the next session will not get affected. So we have come to the end of the first session, that is pre-conference workshop on patient interactive session. So I request Professor AJS Banwar sir, who is a senior geneticist from Punjab, to honor our chairpersons, moderators, and speakers. I request our chairpersons, Prasanna Shirol sir, Ritvik Kashyap sir, Dr. Jaya Vyas, Dr. Mohua Chakravarti, Dr. Pallavi and Dr. Namrata, Dr. Sushma, Dr. Akshaya, Dr. Shashikiran, Dr. Siri, Dr. Sushmita, Dr. Megha, and also our wonderful moderators who have carried the session so nicely. Dr. Angel, Dr. Subhadra, and Subhashini. Thank you, sir. So we come to the end of forenoon session, and we will break for lunch, and let's all gather back at the same place sharp 2 p.m. so that we will be on time and have a lot of interactive sessions. So we will have a very interesting session
which is a need of our, that is on the genetic and genomic education in India and across the globe. Thank you.
all the delegates to please be seated. I'm going to invite the host for the session shortly. Two, three. So may I invite the host for the session?
Good afternoon, everyone. Myself, Dr. Vinita SP, Assistant Professor, Department of Anatomy, JSS Medical College. Welcome you all for the afternoon session on genetic and genomic education or training. As we all know, genetic and genomic education is in the forefront in the current era. So considering the current status of genomic education in India, we would like to understand how is this particular genomic education across the globe through several esteemed speakers ranging from America to Australia. So based on that, we would like to analyze how is the current context of Indian genomic education. So let us begin the session, and I hand over the podium to moderator, Dr. Lakshmi BR. He is the founder, trustee, and managing director of Molecular Diagnostics Counseling Care and Research Center, Coimbatore. And Madam is the founder member and current vice president of Board of Genetic Counseling India. I welcome Dr. Lakshmi BR to take this event forward.
Good afternoon, all. Thank you, Vinita. I'm sure we are going to have a great session because all of us are really waiting. And genetics and genomics, as somebody just said during when I got into the hall, the next 50, 100 years is going to be dominated by genetics and genomics. Yes, it is. We all of us know. So now, where are we in India in terms of genetics and genomics? And mainly here today, genetic counseling as such. So the way it is organized is, we have speakers all over the world, as Vinita rightly said, and we have special guests. So the real aim of this session is going to be, I'm going to ask from you, what is it you really want in terms of curriculum? Our curriculum or the way genetic counseling goes should be recognized by UGC. Yes, it should happen. So we should work towards it. We already have a long homework done. And the next one is the profession should be recognized in this country. The Health and Family Welfare Department should say, yes, genetic counseling is one of the key professions which is needed. So I have taken up these two goals. And when these two goals are coming in, we need esteemed guests, people in India who have worked with the government, with the policy makers. And so we have three very special guests. And one, we have Dr. Rao, Dr. T.S. Rao. So most of you know him. So he's a former senior advisor, Department of Biotechnology, Ministry of Science and Technology, Government of India, New Delhi. At present, he's an advisor in developing health technology campus in IIT. Currently part of Make in India and Atmanirbhar Bharat initiative of Honorable Prime Minister of India. Interest, yes, we know, medical biotechnology, vaccine research and development, and mainly policies. And again, in terms of his career, all of us know him, the significant role in polio eradication program, Government of India, and coordination on development and commercialization of first indigenously developed rotovac, more on vaccines. And again, during this COVID, he had such contributions made to the government. And again, establishment of all these centers. If you sit with him, we'll understand how much of effort has gone, because somebody who was really interested and keen and who has shown that such initiatives at the level of policy making makes a vast difference. And he has proven and shown during his entire tenure and even now. Co-author of a comprehensive book, An Introduction to Biotechnology, Principles, Techniques, Applications, and Industrial Opportunities. Recipient of prestigious Distinguished Service Award of USIBS at Atlanta, USA. And Pratibha Pushkar from Government of Andhra Pradesh. And of course, introduction of rota vaccine in all 26 states. Currently doing an international cancer genomic consortium project with 16 countries collaboration, ICGC, at NIBMG Kalyani and ACTREC Mumbai, India, on specifically with oral cancer. There is lots more, but I'm so happy that Rao is here. I invite him over to the dais. And I thank him for really making it, because unless we have policymakers sitting here or who can take us to the policymakers, whatever we dream of, it'll become far-fetched. Thank you so much, sir, for making it. And of course, Dr. Katoch, Director General of ICMR, was supposed to come, but since there's been some issue with Jaipur and connectivity, he couldn't join. Maybe he promised to join online, but his blessings and whatever needs to be done, he said we can always talk out to him. And we have one more special guest, Dr. M.A. Shekhar. He's an academician and a clinician. He will be joining us around 3:30, 3:40. So this is a goal we'll work. We are going to hear from various countries their experience of genetics education and training. And here I would call upon Suraj to introduce the two chairpersons, and they would in turn be introducing the speakers. And after that, we'll have a panel discussion with all of them and the two special guests. And I'm sure we are going to achieve the goal. At least put up the white paper to the government to establish this profession in the government, and also to set the curriculum in India to take it to the next level. Thank you. Thank you for the opportunity. Yes, Suraj. Suraj is level 2 senior genetic counselor, one of the passionate genetic counselors of BGCI.
Thank you so much for that wonderful introduction, Dr. Lakshmi. Dr. Shekhar would join us shortly. So now I take the honor and privilege of introducing our chairpersons for this session. So the first chair of this session, a true academician, I would like to introduce to you Dr. Preeta Shetty. She is an associate professor, human genetics, cytogenetics, and molecular medicine. She's also the program director of BBMS program, which is Biomedical Sciences in College of Medicine, Gulf Medical University, UAE. She's also an associate member of the very own Board of Genetic Counseling India. She's also a member of Asia Pacific Society of Human Genetics. She's also a fellow, Institute of Biomedical Science. And you can see her credentials. She has 15 years of graduate and undergraduate teaching experience with numerous awards that you can see on screen. And she is also a recipient of awards for research, publication achievement, and excellence in teaching. Who better we call as a chair for this session? Please welcome Dr. Preeta Shetty. May I now introduce to you the second chairperson, who's also a pioneer in the field of education, Dr. Akhila Prashant, who's from the very own JSS Medical College. All of you would know. She's a professor, Department of Biochemistry, and convener, Department of Medical Genetics here at the JSS Academy of Higher Education and Research. She's currently working on multi-centric project on National Registry for Rare and Other Inherited Disorders. She's not only a clinician, but also a researcher. She has a PhD and also a postgraduate diploma in genomic medicine and healthcare. And she has established the Department of Medical Genetics here at JSS. She's also initiated BSc and MSc courses in Medical Genetics and Genomics program. It's an honor to have you here, ma'am. Please welcome on stage. May I now request a special guest, Dr. Rao, to start this session off with his comments. Please welcome, sir. Thank you. Over to you.
Thank you very much. Good afternoon to everybody. Thanks, Dr. Lakshmi. Nice introduction. And also, your goals are very clear. And if you target like that, probably will be successful. Doing that in a timeline bound. So nice to meet all of you again. It's a great meeting after 5-6 years back, I think. No? Then earlier I started 93, then probably now meeting and seeing that how much enthusiasm still continuing and sustaining in all of you into that. But it's a great cause. All of you have joined over here. And first of all, thank you very much, Dr. Lakshmi, for inviting me for this session and meeting also. Otherwise, I would have missed a lot of fun. So that meeting all of you and also learning more things, what's happening in this area. So still it's a passion for me. For 30 years back, still I continue till we accomplish our goals so that this clinical genetic uh, aspect need to be consolidated and also to be put in a government approval. That's very important to that. Subject, if you don't put water in the shell, that will not become a sacred water. So you have to put into the shell, then make that shell water to be distributed to everybody and make a robust internationally create a genetic counselors in the country because we need two aspects of it. One is recognition of the UGC, what she rightly said. Second is that approval of the government of India with high authority in the health area is the Ministry of Health and Family Welfare, associated with the DHR and ICMR. These are our, and I'm telling such another thing also, Niti Aayog also need to be apprised what all are doing it with different pockets, different parts of the country. All of you are trying to collate things to happen, and they will need to be consolidated. And I saw the one book of comprehensive and DHR, this Dr. Lakshmi is bringing out Duchenne muscular dystrophy, and Dr. Dave's book just now I saw the counseling, how guidelines which we have to have. So what I really, we can end of the day panel discussion, we can discuss what the next course of action. But otherwise, I'm overwhelmingly happy to see you all of you are aware DBT has started recently. Me and also
BGCI.
so probably those who meet
Yeah, sir is presenting. After at 2:20, sir.
BGCA. That's not that big.
Yeah. How did he end up in my? Okay.
So someone I got so
okay. Yeah, those Umeed and Nidan Kendras is a phase one in 2019, September 2019, we got inaugurated through our minister. And now because of COVID problems, which we could not extend to other centers, it will happen very soon into that. So some of these initiatives of Government of India, especially Department of Biotechnology, with the involvement of Health Ministry as well as the ICMR along with us. So make these kendras to robust to provide genetic counseling and also clinical diagnosis of that. What morning I saw some of things still they're all dicey. So one should really make a clear-cut policy level discussions we need to make move forward on them. So one policy, like internationally they have one policy. Similarly, in India should also have one policy adopted by all of us, not making halfway jumping into the well. There is no meaning at this stage. After 30 years of our introduction of human genetics program, genomics program in the country. So we are doing a lot of genome core grants and all that, as well as 1,000 genomes. So they're all fine. They're all intellectually, we all add up to that. Ultimately, what patient get the benefit out of this your exercise is more important than do the all publications into the American journals, Human Genetics Journal. That's fine. There's no issue at all. You should do continue that. But first and foremost, your customer is our patient. How this particular genetic counseling and genetic diagnosis helping our families, affected families, and reduce the consanguinity. Those are issues we need to tackle over this. And genetic education. Genomics and genetic education is very important, which we going to talk in a panel discussions later on. But with these few words, I thought thank you very much once again for all of you and inviting me again here to we'll see how we move forward and also make sure it has to be adopted by Government of India policy so that all of you to get facilitated this guidance. Thank you very much, Sandra.
Good afternoon, one and all. The first talk of this session is by Professor Alison McEwan. She is coming live from Australia. The title of her talk is Designing and Delivering Online Genetic Counselor Education. We have a brief CV of Professor Allison. She is Associate Professor, Graduate School of Health, University of Technology, Australia. She's done her graduation from Victoria University of Wellington, New Zealand. Graduate Diploma in Genetic Counselling, Charles Stewart University, Australia. PhD from University of Otago, New Zealand. Postgraduate Certificate in Professional Supervision, the University of Auckland, New Zealand. She's the Fellow of Human Genetic Society of Australasia. And she has 16 plus years of experience as a genetic counselor in Wellington, New Zealand. She, Human Genetic Society of Australasia Certified Genetic Counselor. She's also the President of Human Genetic Society of Australasia and is only the second genetic counselor to take on this role. We welcome you, Professor Allison. Over to you.
Thank you. I'm just going to share my screen. I need you to let me share the screen. Thank you. Okay. Tēnā koutou katoa, Bujari Gamurua. I begin today by acknowledging the people of Ngāti Toa in Aotearoa, whose land I'm speaking from today, and the Gadigal people in Sydney, whose land UTS is located on. Thank you for the invitation to speak today. The genetic counselling profession is facing many exciting and challenging opportunities as our understanding of the potential of genomics to improve health outcomes increases. It's a privilege to have the opportunity to share my experience with designing and delivering online genetic counsellor education. During 2016, I worked with the University of Technology, Sydney, as they began to plan a new Master of Genetic Counselling program. At that time, there were 2 Master of Genetic Counselling programs in Australia, one in Melbourne and the other in Sydney. In discussion with the University of Technology, Sydney, we agreed to offer a program that was predominantly online. We hoped that this would increase access to training for students who were unable to move to Sydney or to Melbourne. In 2017, I moved to Sydney and began work to design and develop and deliver the UTS Master of Genetic Counselling. This is a 2-year coursework master's degree that is delivered online with block weeks on campus each year. Students complete coursework subjects in genetics and genomics, counselling and communication, genetic counselling, and research methods. They do a small research project and about 74 days of clinical placement activity during the 2 years. Over the next few minutes, I'm going to outline the tools and techniques we used to design interactive online genetic counselling education. We wanted the education to specifically facilitate class engagement and connection. I'm going to describe ways that we facilitate counselling skill development and simulate clinical placement activities online. And I'm going to finish with a suggestion for the use of online genetic counsellor education to help the profession expand in India and elsewhere. I hope that there will be time for discussion this afternoon or in the future. And I've tried to keep the technical language to a minimum, but please make a note of any words that are unfamiliar, and perhaps I can use the online chat to explain any of those later this afternoon. So the program at UTS uses online learning and weekly timetabled, what we call live and online classes, supported with on-campus blocks. I'm going to break down the different components of our approach now. So we use a learning management system called Canvas, where we create content for the students. This is where the students develop their knowledge. They work their way through several Canvas pages of activities, readings, discussion boards, and videos each week. And what we find is that Canvas is a really great tool that allows us to design in activities to help students think about the knowledge content. There's a lot of text on this screenshot from a Canvas page in one of our subjects. I just wanted to give you an example of what online content can look like. So here we're asking our Year 1 students to watch one of these 2 videos and to make notes about how the content of that video applies to a genetic counselling client who they've met. At the end of each week during the term, our students come to what we call live and online classes on Zoom to apply their learning. During the live and online classes, students practice role plays, they have small group discussions, they respond to polls, they can do presentations, they interact with guests, and they ask questions in exactly the same way that learning occurs in a physical classroom. This is our Year 1 class at the start of 2022. The online learning is supported by an on-campus block week in Sydney. The blocks happen at the start of Year 1 and then once each semester. During the pandemic, we've delivered the block weeks online as well, and we've graduated competent genetic counsellors who have completed almost all of their learning online. While we know that the students really enjoy getting together on campus, being forced to move the block online in 2020 and again in 2021 has given us the opportunity to prove that wholly online genetic counsellor education is possible. This is a photo of our graduating class of 2020 taken a few weeks ago. They were meeting up for only the second time in the course of their degree. So how do we design good quality online genetic counsellor education? I believe that the key to online learning is creating an interactive learning community. For me, this means prioritising learning activities that facilitate connection between students and also setting clear expectations about participation both in class and in the pre-class activities. Students who have the opportunity to get to know each other are much more likely to participate in class and to support each other during the program. Our experience has shown us that it's possible to design online learning environments where students form friendships and a collective class identity that extends beyond their time in the program. So we specifically set out to use the Zoom breakout room function during every class so that the students interact with each other in the same way that they do in a physical classroom. This is a screenshot from an end of semester class where themed backgrounds were encouraged, and you can see that the students are laughing together and having fun with their Pokemon backgrounds. And there's a lecturer in that class as well. So how have we created this online community? We use the Zoom chat function to increase participation in class discussions. This gives students who prefer to respond in writing a way that they can participate in class. And we find that the students often use the chat to encourage and support one another. Early in the program, we establish clear expectations about participation on discussion boards, voting on polls, and contributing their thoughts and ideas. We do this by interacting with the students in Canvas as well as in class, so that they know that we're reading their contributions and discussing those with them. We encourage traditions that are about community and that create moments of class connection and shared laughter. So when we were designing the program, we spent quite a bit of time working out how the students would develop their counselling and communication skills in an online environment. And I think we know that the key to developing our counselling skills is to practice them often. And so the list in this slide shows one of the ways that our students participate in regular role plays in an online environment. We designed into the program these regular assessment activities that are worth just a few marks each. And each week, the students work in groups of 2 or 3 to record their counselling skills practice. They watch the recordings to identify the specific skills that they're using, and then they upload those into Canvas for assessment. As academic staff, we watch the videos and we provide them with feedback, and then we encourage them to use that in the next small skills task. We find that the students quickly develop their counselling skills, and these small assessment tasks also help them to get to know each other. Students have told us that they often will stay online chatting with each other once they've finished their recorded task. So now I'm going to talk a little about clinical placement activities. We know that clinical placements provide students with workplace experience during their training. Our students have a short observation placement during their first semester, and then they have a longer clinical placement in the other 3 semesters. And we wanted to add some additional placement activities that would give students the opportunity to plan their own workload and work with simulated clients more independently than they can at a clinical placement site. We were already using simulation in the program, so we used our experience with simulation and our own clinical knowledge and experience to develop a series of what we call virtual clinical placements. These are another example of how online genetic counselor education. So simulation is a technique, I guess, that involves students working with standardized clients who are actors, who are trained to simulate the psychological, emotional, historical, and physical manifestations of a client. We've written about our use of simulation, and I've put the reference on this slide. So during our virtual clinical placement weeks, the actors are students from the other year group. And what we find is that by asking the students to take on the role of a genetic counselling client, they get some idea of what it feels like to be a genetic counselling client. And we then have reflective conversations in class with them. And these have really indicated for us that significant learning opportunities occur when they take the role of the client. So how did we develop this virtual clinical placement? We started off by making a list of all the different activities that a genetic counsellor does during a working week. And we set about developing ways to recreate those in a simulated environment for our students. So the students spend a week working in a small team of students along with a clinical placement supervisor, and they plan their week, they make intake calls, they attend continuing professional development activities. They have a turn being the on-call genetic counsellor and respond to phone messages. They attend and participate in clinics. They draft the post-clinic letters. They attend supervision. And then at the end of the week in their team, they prepare and give a case presentation. We evaluated the student satisfaction with the virtual clinical placement. and we found that all the students who completed the evaluation reported that this virtual clinical placement helped them to develop and deliver their clinical communication skills. As you can see from these two quotes on the slide, they were able to give more things a go and push themselves to try things that they would normally ask for help with when they were on a placement. So I think simulated clinical placement experiences offer ways for students to develop their skills so that we can more rapidly expand our genetic counselling workforce. There's scope to broaden the range of virtual placement activities beyond clinical skills to help students prepare for roles, for example, as a laboratory genetic counsellor. Simulated placement experiences like these also have the potential to reduce the pressure on clinical services while still ensuring that students are really well prepared to enter the workforce.
Professor, you have 2 more minutes to conclude.
Thank you. So I guess what I just wanted to finish with was to say that as I've been thinking about and preparing this talk, I've been reflecting on the way that genetic counselling education evolved in Australia and New Zealand, and wondering if our experiences could be used as a model as genetic counselling expands in India and elsewhere. So just to put this into context, when genetic counsellor education started in the early 1990s in Australia, we used resources that we had access to, and I've listed some of these on the slide. And we called this approach the checklist approach. These are some papers that summarise the experience of developing genetic counsellor education in Australia and New Zealand. And you can see that it really has taken us from the early 1990s with the checklist approach through to 2009 when the first Master of Genetic Counselling program began. And then in 2019, we became a self-regulated health profession. And we're continuing to work towards title protection for genetic counsellors in Australia and New Zealand. So it's really been quite a long trajectory of time to get to where we are today. In preparing the talk, I had a look at the resources on the Board of Genetic Counselling India website, and I could see that you've got several training programs and certificate courses. And I wondered if there was the potential to develop a modified checklist approach where you use the resources that you already have and then add, for example, some online activity, for example, some virtual clinical placement activity in an advanced genetic counselling subject online that would help to create a shared professional identity and practice across your country. And once you've got that workforce, then you've got people who can really continue the work towards regulation and the government processes that take so much time and energy. So in closing, I'd like to thank you for the opportunity to talk about my experience with designing and developing online genetic counsellor education. We've proved that it is possible to create interactive, engaged online learning communities, to simulate clinical placement activities online and graduate competent genetic counsellors. Building on the concepts I've outlined today, offers us as a global profession the opportunity to more rapidly establish a genetic counselling workforce in countries where this profession is developing. And I'm happy to take questions later on this afternoon. Thank you.
Thank you, Professor, for a wonderful talk. You have enlightened us on delivering online genetic course education in Sydney, Australia. Thank you for that. I just wanted to know, you have mentioned about 2-year master's program. Is it a credit-bearing program? If yes, how many credits does it?
Is it an accredited program? So So the program, it's a 96 credit point, 2-year full-time master's program. And it's got what we call external accreditation through the Human Genetics Society of Australasia. So it's the required entry for practice as a genetic counsellor in Australia and New Zealand, to have that HGSA accreditation.
Thank you so much.
I hope that answered the question.
Floor is open. Anybody can ask. If anybody has any questions, you may go ahead and ask. In the end, okay, we'll have a panel discussion, Professor, at the end. You please be connected with us. We will have a next speaker now. Dr. Akila will introduce our next speaker.
It's my proud privilege to introduce Dr. Girish Katta. He is a professor and head of the Department of Medical Genetics, Kasturba Medical College, Manipal, and the founder and director of Suma Genomics Private Limited, Manipal. He's an undergraduate from the Mysore Medical College and Research Center, and he's done his MD Pediatrics from St. GS Medical College, Mumbai, BM Medical Genetics from STPGI, Lucknow, and his interests are mainly in the area of skeletal dysplasia, prenatal and postnatal dysmorphology. Over to you, sir.
Thank you, Dr. Akila. Can you hear me? Can you see my slides?
Yes, sir.
Can you hear me?
Yes, sir. Yes.
Can you see me my slides as
Slides
well?
are also visible, sir.
Yeah. Thank you, Dr. Akila, for this introduction, and I thank all the organizers at Mysore and all over the country who called me to give this presentation. Unfortunately, I could not be there in Mysore with all of you. Mysore is one of my favorite places. I graduated from Mysore Medical College. So, hello, Akila, can I proceed? Hello, am
Just
I
sorry
audible?
for interruption. It's not on a slideshow mode. It's on a presenter view. So there is just 3 dot. Click on it, and it will be on a presenter view. Exit and reshare.
Okay. Now, should I? Where should I go?
Yes, click again.
Slideshow.
Yes, click on slideshow.
Yeah.
There is a 3 dot.
Okay. Yeah.
Click on it. Hide presenter view.
Okay. Can you?
It's loading.
One second.
Or you can do continue like this only.
Oh, just a second. Okay.
You have a dual monitor system.
I have dual monitor.
But that's why the issue is coming, because the full screen is on a second. You can continue with this slide itself. You just need to
Okay. Okay.
press down itself.
Okay. Fine. I'll do that. Okay. Good afternoon. Thanks for the help. Because I have dual monitor, I think this is the issue. I will now be able to present. Can you see? Okay. Now I will, over the next 8 or 9 minutes, I will discuss the Master of Science program in Manipal. It is not, it is silly actually to tell what is a genetic counselor to this august audience. We have a lot of trainers, lot of trainees, lot of professionals who perform genetic counseling every day. I really enjoyed the talk by Alison just before, how they deliver virtual genetic counseling training in Australia and New Zealand. Just for the benefit of the audience and some of the students, genetic counselors are masters trained healthcare professionals. Across the world now it is accepted. Several universities have come out with genetic counseling programs. Usually it is 2 to 3 year master's program, where knowledge is imparted or acquired in basic science, medical genetics, epidemiological principles, and counseling theories. And the counselors have skills in genetic risk assessment, education, interpersonal communication, and counseling, and they serve their clients and their families for a diverse set of genomic indications. When we began genetic counseling program in India, we just looked into the scenario. Today, we have 1.4 billion people in our country, and we have one physician per 1700 people. It is not still optimal. We are far away from being optimal doctor-patient ratio. And even today, for such a large populous country, we have about 60 to 70 medical geneticists in here, which makes this highly insufficient number of trained clinical geneticists or medical geneticists or even genetic counselors, as I will be discussing today. Very small number of genetics health professionals. If we see the last decade or two, the advances in human genome project and our capability to sequence the human genome interpretation have developed so rapidly. We are still getting it. We are still scarce, or we still do not have sufficient human resources to deliver these advances to the people. Our program is of 2 years. I am aware there are some 3-year university programs as well, but it is 2 years full-time program in the campus. We select people with a bachelor's degree in nursing, human genetics, human biology, medical biotechnology, or molecular biology. An element of human genetics is necessary in their bachelor's degree for entry into our program. So we do not take people from other backgrounds. A science background with at least some training in genetics and human health is necessary to enter into our program. The course is also open for medical and dental graduates. We have an university conducted entrance examination, which is written, followed by an interview and aptitude test by the Department of Medical Genetics. We consider genetic counseling profession requires an aptitude, and only those who can talk, communicate well, and have a passion for the profession will do better. So we have an aptitude test to select students shortlisted in the written test. Our program has component of clinical training, laboratory training, and we have teaching programs, which includes 2 semesters of 5 months each in a year and 2 months of vacation. So we have 4 semesters. These are UGC prescribed programs, so we cannot change these things, but it is 2 years with 4 semesters, 1 month vacation, around 5 months of teaching or learning in the campus. Every week we have a seminar on basic science, seminar on clinical science or counseling issue, journal presentation, and 2 discussions. And every day for 5 days in a week, we have a basic course for the every hour for 1 hour of 1 hour duration for the students. We try to impart several clinical skills, which include collection of medical and family history, pedigree construction and analysis, participate in ordering genetic tests, counseling for common conditions, prenatal testing, Down syndrome, muscular dystrophy, microarray, and exome sequencing. Basic presumption is common genetic condition. The top 10 conditions account for nearly 70 to 80% of our practice. So we try to cover these conditions very well so that rarer condition can be addressed at a later stage, but common conditions are our main aims, so they can do these things regularly. And we ask them to involve with us in consenting for procedures and as well as consenting for research. We expect each student to write 50 case summaries in 2 years duration, which should include several cases of Down syndrome, Duchenne muscular dystrophy, spinal muscular atrophy, thalassemia, amniocentesis, coroniculus sampling, familial cancers, recurrent pregnancy loss, neural tube defects, fetal anomalies detected by ultrasound. This constitute the mainstay of their training, but we also have exposure to counseling for teratogenic exposure, fetal autopsy, clinical testing, pre-test and post-test counseling for several indications and several conditions, research testing, counseling for consanguineous couple, preconception counseling, newborn screening, and pre-symptomatic screening as well. Our syllabus is spread over 2 years. In the first semester, we have foundation course of about 3 months duration, where we teach physiology, biochemistry, and anatomy, and human genetics, clinical genetics, and we introduce them to clinical case preparation. These are the subjects which we deal in the first semester. You can see on the right hand side the credits. Each credit is about 15 hours of teaching, minimum of 15 hours of teaching or academic activities. If it is practicals, 2 hours is considered as 1 point. So we should have 15 points. So in the second semester, we teach principles of genetic counseling, common genetic disorders, clinical case management, and they get to do some electives in genetic and genomic tests. In the second year, we have training in reproductive genetics, cancer genetics, and applications of genetic counseling. And we have an elective in next generation sequencing. They can choose electives outside the department as well. It may be research methodology, it may be ethical issues. And in the fourth semester, we teach them recent advances, research in genetics, ethical, legal, and social issues in genetic counseling, and research and education. They need to do a small research project. And we have an internal assessment and sessional exam at the end of each and every semester, and we have one external examiner for their exam at the end of each semester. These are the textbooks we recommend them to read, which includes Emery Elements of Medical Genetics, Medical Genetics by Jorde, Kerry, Bumshad, and White, Chromosomal Abnormalities and Genetic Counseling. We have a book by Beverly Asher and colleagues on Guide to Genetic Counseling, Strachan and Reed, Thompson and Practical Genetic Counseling. As far as I know, there are 3 Master of Science programs dedicated to genetic counseling at Manipal. We began the program in 2014, followed by Nizam's Institute of Medical Sciences, Hyderabad. This year, Sanjay Gandhi Postgraduate Institute of Medical Sciences will start the program in Masters in Genetic Counseling. I am aware there is a Biomedical Genetics and Genetic Counseling program in Vellore Institute of Technology as well. We have trained 17 counselors as of today, starting from 2014, and now they are spread all over the country. Some of them are doing PhD or doctoral training. Some of them are working with the industry. Some of them are working with the clinicians. And currently we have 12 trainees being trained at our center. It is not only genetic counseling in the hospital, they get also have different opportunities after their training. They can work in research, education, industry, marketing, and many other roles across the healthcare and genetic field. Currently, we have huge demand for genetic counselors in our country. I am aware several countries even today do not have genetic counseling training programs. Some countries borrow people trained from other countries, and in India, as of today, there is huge demand and very limited supply. We have very few people who can be trainers, who can be teaching genetic counselors, because India till recently did not have genetic counseling programs. Very few full-time training programs in the country, and we now get a lot of applications. This year, I think for 6 seats, we have more than 50 applications. Everyone wants to be a genetic counselor, and that too quickly. We have several short-term certificate programs, programs which do not select people with a science background. So we need to slowly develop a program for our country at par with any international training program and develop best genetic counseling professionals. The National Society of Genetic Counselors says that while genetic counselors are not medical doctors, they are part of the healthcare team and work with patients and doctors. I urge all to undergo a proper training program and work with the clinical team before and after ordering the test, so that we can serve the patients in need in a better way. These are members of our beautiful team. Actually, they do a lot of hard work to develop these programs, participate in these programs, and make it very successful. And I get the opportunity to inform on their behalf of our academic activities. Thank you.
Thank you very much, sir, for taking us through how the program is run in an Indian institute and what is the requirement of the Indian population. Based on that, the curriculum has been designed. So I think since the discussion is later, we can move on to the next speaker.
Our next speaker is Dr. Takeshi Iwata, live from Japan. The title of his talk is Establishing Framework to Identify Disease-Causing Mutations for Patients with Inherited Eye Disease. Dr. Takeshi is the Director of Molecular and Cellular Biology Division, National Institute of Sensory Organs, National Hospital Organization, Tokyo Medical Center, Tokyo, Japan. He's the head of Japan Eye Genetics Consortium, president of Global Eye Genetics Consortium, meeting liaison of International Society for Eye Research. Professor Takeshi has PhD from Meijo University in Nagoya, Japan, postdoctoral fellowship from National Eye Institute, NIH, USA, postdoctoral fellowship Bascom Palmer Eye Institute, University of Miami, USA. Some of the career highlights: he has identified 5 novel genes for inherited retinal diseases, glaucoma and optic neuropathy, identification of molecular mechanism of AMD and glaucoma. He's involved in establishment of Japan and global genetic consortiums. On behalf of BGCI and JSS College, I welcome you, sir. Over to you.
Well, thank you very much for this invitation to BGCI. I'd like to first thank Dr. Ratna and Dr. Lakshmi for this invitations. My talk will be mainly ophthalmology that I work on. And the I'm not a genetic counselor. I'm the basic researcher, actually trying to find as many novel mutations within the Japanese population for these inherited eye diseases. So I like to share the slides. Can you see my slides?
Yes, we do.
Okay. So I like to start with this slides. It shows that the eye diseases in some way is affected by genetic factor and environmental factors. And because genetic factor are more easily detected, for many decades, people have been looking into this genetic factors. If the genetic factor is extremely strong, we will call them inherited eye diseases because it will have some inheritance among the generations within the disease pedigrees. And some of these disease will be retinitis pigmentosa, if you know. Only the people who are ophthalmologists will probably know this name, but retinitis pigmentosa is one of the major disease of inherited eye diseases. Macular dystrophy, Stargardt disease, retinoschisis is among. There are other 30 different diseases in this list. We call these genetic variants a mutation or single nucleotide difference can cause a disease in the eye. Usually it's one gene or in a heterozygous form or just one allele, and the frequency will be low. On the other hand, there are very common diseases like age-related macular degeneration, like glaucoma and cataract and myopia, where there will be less genetic associations meaning that these variants within the genome it's not strongly influencing, and probably environmental factor has a major role in these common eye diseases. But these variants has been heavily studied in the past 20 years or so using the technique called the whole genome wide association studies. And these are called risk variants, usually not one. It's like age-related macular degeneration. You will have 30 different locus that are associated with the diseases. And the frequency is extremely high, which means that even if you have these risk variants, some of the people will not develop the disease. So here's the brief history of the human diseases that was published in Nature 2 years ago. And on to the left, there is a rare monogenic diseases, and to the right, the common diseases. So ophthalmology field has been pioneering a forefront in this genetic studies, like the lab that I went, gyrate atrophy. This is a common, rare, but common retinal pigment epithelial diseases. Also retinitis pigmentosa caused by rhodopsin mutations. These both were identified in the 1980s and 1990s, early 1990s. And if you look at the common diseases, one of the first genome-wide association studies to find where in the chromosome the genetic factors are associated with these common diseases was actually done for age-related macular degeneration. So one of the first genetic studies of these diseases were actually done in ocular diseases. So I will be talking mainly about this inherited retinal diseases. As you can see, this is the eye and the light. I'm sorry. The eye comes in, the light comes in to the, and then it focus onto the retina. Retina is mainly 3 layers of neurons and plus the retinal pigment epithelial cells on the bottoms. And you can see this retinitis pigmentosa, Stargardt, these choroideremia, there are 36 different type of these inherited retinal diseases. And most of these diseases are caused by genes that are expressed in this photoreceptor where the light is detected, or somewhere in the retinal pigment epithelial cells proteins mutations. And also bipolar cells and ganglion cells are also associated with optic neuropathy and inherited type of glaucomas. And these genes has been identified in the 1988 when I started my postdocs, and now it has gone up to over 300 genes. So in 2011, the Japanese government has decided to put a sum of money to start a large consortiums in Japan to detect all the mutations in this inherited retinal diseases. So this is the ophthalmology panel that was assembled, all of them from the Japanese Society of Clinical Electrophysiology of Visions, who are expert in these inherited diseases, plus they are all electrophysiologists. And we have started this studies. The first thing that we had to do is how to collect all this information into one place. So on the left side is the diseases that we're dealing with. And this is that we decided to make the server, data server, the phenotype genotype database, and to collect all this information. So there are fundus photo, the visual field, the autofluorescence, fluorescent angiograms. This is the OCT, the dissection of the retina, and also electroretinogram. All these visual image information will be uploaded into our systems. And because the clinicians are very busy, we try to minimize the tasks of like typing. I think we will put some scroll bars or buttons to minimize typing within this database. So this is the structure, that framework that we developed, is that University A and B and C will be uploading each of the diseases into the systems. And each of the data that is inputted is actually monitored by this panel of ophthalmologists. And they will say that maybe this fundus photo, maybe not image quality is not enough, or sometimes this disease is what you think is not, this is wrong. It should be this disease. And that kind of filtration is being done by these ophthalmologists of the panelists. And go through this filtrations. Finally, we go to the whole genome or whole exome sequences for sequencing. And if we find a novel, known mutations, the result will immediately go back to the patients. If it's a novel mutation, then it will be discussed further. And if it's a completely novel genes, then we have to do a functional analysis to evaluate if this is really the gene to cause the diseases. So in Japan, we have collected about 1,200 pedigrees so far, and majority of it is the retinitis pigmentosa, and also the macular dystrophy and Leber congenital amaurosis and Stargardt diseases in this order. And probably this may be different among each countries. And we will do the sequencing. Mainly, we're doing a short read, meaning that you will chop up the genome into small pieces, and we will just isolate the exon where the protein coding. Or you can just sequence the whole genome if you wish. But if you can pick just the exon part, at the end, the data will be 1/10 of the size of the whole genome, which is much faster to do the analysis. This is the programs that we use to flow and then identify the mutations. And if you find the known mutations, we will just return it. But if it's unknown, we will go to further analysis to find if this is really the mutations. So in Japanese population, here you can see the retinitis pigmentosa showing a gene called EYS. A majority of the population is caused by EYS. This is only in Japan. And if you go to other countries, probably you will find totally different genes with a much higher ratios. But on the other hand, if you look at Stargardt disease, you see a majority of this population will have this gene mutation in ABCA4. This will be exactly the same in the UK as well. So depending on the diseases, you will have one particular genes that will, most of the mutation will be hit, a hotspot, or there'll be a number of genes that the ratio will be different among the ethnic groups. So if you look into this genes, after this analysis of whole exome sequence, how much did they actually solve? And if you look at retinitis pigmentosa, at the end, we were only able to identify 37% of the pedigree. That means if 10 people came to your clinic with retinitis pigmentosa, only 4 patients can be detected, and rest of the 6, no result. On the other hand, if there is somebody with a retinitis retinoschisis comes into their clinic, then you're probably doing this analysis, you will detect and tell the patients what kind of mutation you had. So this will change among the ethnic groups, but this 37% is talking with our friends in US, UK, and Netherlands and Switzerland. This ratio is pretty much the same, which means that just doing the genetic analysis at this current level is not enough to detect all the mutations for the patients. And the whole world is actually working very hard to fill in this gap. If you find a new mutations, you do need to do a functional analysis. And that will be some of the protein simulations. You will get the patient iPS cell differentiating retinal cells and try to find out what's the cause. And you will make knock-in and knockout mice to find the same phenotype with the humans in the mice. And these kind of information will eventually say that this is the gene that is causing the mutation. And then usually this process will take years, and the cost will be significant, and the collaboration is very important. So I'd like to summarize that the 10 years of work of our Japanese Eye Consortium is that we do the diagnostic, receive the phenotype information, collect phenotype information, store it in the database, collect blood and saliva samples, do the DNA extraction, do the gene sequences, identify the mutation. If you can find it, return to the patients. But if you don't find it, then you will have to do a significant functional analysis. But if you do this functional analysis, eventually you will find how this mutation is actually causing the disease. And this seed information can be used to develop therapy. It can be a gene therapy, or it can be a chemical inhibitor or something. But we usually can suggest a drug or some kind of a therapy from this seed information. And some of them can go into clinical trials, and that's what we are currently doing. So in summary, I'd like to say that the genetic research of rare and common eye disease has always been in the forefront of human genetics. The JEGC has established to collect patient phenotype information and blood or saliva sample for DNA extractions. Panel of ophthalmologists were positioned to maintain quality of diagnostic and phenotype data. TMC is responsible to obtain research grant for JEGC project and develop phenotype genotype database and perform whole exome genome analysis of all collected DNA samples. Approximately 1,500 Japanese pedigree, father, mother, and child has been collected, and approximately 1,200 has been sequenced, and we are currently more as we speak. A whole exome analysis of Japanese RD resulted with significant number of pedigrees still unsolved. Currently we are doing a short and long read whole genome analysis for these pedigrees. We have identified many new genes, and probably because we are in the Far East, we are finding new genes. But if you go to India, we will definitely find more genes. So I'd look forward to the lab and the people who would work on these genetics, who would find new genes in this Indian regions. Also, this information that we do with the functional analysis, with the patient IPS, knock-in, knock-eye mice, and protein modeling, all this information can be used to develop novel therapeutics for inherited eye diseases. So I'd like to thank first the patient, the pedigree, who has participated for this study, and all our collaborators and the funding agency. Thank you very much for your attention.
Thank you so much, Dr. Takeshi. You have nicely touched upon all aspects of inherited eye disorders. You started it with distinguishing between Mendelian disorder from that of multifactorial disorder. And then you spoke about molecular mechanisms and then diagnosis. Very nice. Thank you. Thank you for such a wonderful talk.
So now we move on to our next speaker, Miss Juliana. Her affiliations are as follows: Genetic Counseling Asia, Kuala Lumpur, Malaysia; National University of Malaysia; Genetic Counseling Society, Malaysia, a Professional Society of Genetic Counselors in Asia, Singapore, and Asia Pacific Society of Human Genetics, Singapore. She has done her BSc Honors in Genetics from the National University of Malaysia in 2002, Graduate Diploma in Genetic Counseling from the University of Melbourne in 2003, and Masters of Counseling from University of Malay in 2009. Her interests are mainly on reproductive genetics and cancer genetics. Some of her career highlights: she's the first genetic counselor from Malaysia to be certified by the Human Genetic Society of Australasia, the founding member of the Malaysian Rare Disorders Society, the president of Professional Society of Genetic Counselors in Asia, secretary of the Genetic Counseling Society Malaysia, and visiting lecturer, Master of Medical Science program from the University of National University of Malaysia. So this over to you.
Sorry, I'm trying to share my screen. Can you see my screen?
Yeah, it's you.
Okay. Okay. First of all, I'd like to thank the organizers of BGCI 2022 for inviting me to present this talk. In this 15 minutes, I will try to cover the overview of genetic counseling, education, and training in Asia Pacific region. And I'll start with the sub-regions first. So the genetic counseling profession has begun nearly 50 years ago in the United States, and it's only grown internationally in the past 30 years. So I'd like to share this paper, The Global State of Genetic Counseling Profession, which is unique because in the past, there are many papers that describe the profession of genetic counseling in individual countries or regions, but the data still remains incomplete. But with this paper, which was resulted after 2016 Transnational Alliance of Genetic Counseling Conference, and also in 2017, the World Congress of Genetic Counseling in the UK. The authors in this paper describe fully as much as possible the global state of genetic counseling as a profession. So it is estimated that in 2018, there are nearly 7,000 genetic counselors with the profession established or developing in no less than 28 countries. And in Asia, it was reported that there are about 350 genetic counselors and also 300 genetic counselors in Australasia. So based on the recommendations made by the Royal College of Physicians in the UK to have 6 to 12 genetic counselors per million population, there are only a handful of countries that came close to achieving this workforce recommendation. So in our Asia Pacific region, we have a population of 4.69 billion, which is almost 60% of the world's population. But however, we only have about 1,000 genetic counselors practicing in the Asia Pacific. So the status of training in clinical genetics and genetic counseling is one of the key factors of the development of genetic counseling. And it has been developing in different stages and maturity in the last 30 years. So in the Asia Pacific region, Australia is the first country to have genetic counselors in practice and genetic counseling education program since 1995. So that's almost like 30 years ago. So a lot of the pioneer clinical geneticists and genetic counselors in Asia were trained on overseas, especially in Australia, in the UK, in the US, and also Canada. And it's only when they return back to their home country that they start to develop the genetic services and also advocate for the need of genetic counselors. So since early 2000, there were more genetic counseling programs that were developed, especially in East Asia, Japan, Taiwan, and China, followed by India, Saudi Arabia, and 10 years later in Southeast Asian countries. However, at present, there are still many developing countries that still do not have the genetic counseling education well established. So I'll start with Australia. So genetic counseling education and training in Australia actually began in 1995 to 1996. And throughout the last few decades, of course, it has also evolved. So they started to introduce the graduate diploma in genetic counseling, which is a one-year program from different universities like University of Newcastle, University of Melbourne, Griffith University, and so Charles Sturt University that was conducting distance learning. So there are about 300 genetic counselors currently practicing in Australia and New Zealand for a population of 25.69 million people. So as we all know now, genetic counseling program is usually a 2 years master's program. And in 2008 to 2009, the training program in Australia has expanded to a 2-year master's program. And because in the mid 2000s, there were no training program in the Asian countries, especially in Southeast Asia. So many of us pioneer genetic counselors actually were trained in the Australian program. So currently, the HGSA accredited Masters of Genetic Counseling is actually available in University of Melbourne and also in UTS, University of Technology, Sydney. So the training in Australia for genetic counselors is actually very developed and matured. And many of us in the Asian countries actually look at it as a model system for us to develop our own genetic counseling program. So they have the certification for genetic counseling as early as in the 1990s. And recently they have also the professional registration, whereby the genetic counselors are self-regulated under the HGSA, which is the Human Genetic Society of Australasia. So following that, the countries in East Asia were the first to also develop their own genetic counseling education almost in the same year, which is about 2003. So in countries like Japan, there are currently 289 genetic counselors that are board certified, and they have the most genetic counseling program, which is about 23. And they've developed this since 2003. They also have a certification pathway, which is overseen by the professional societies. As for China, they do have a pilot program that started in 2003 by the University of Fudan, but I do not have accurate information of current numbers of genetic counselors and whether this program is still active. But from the literature, I know that there are certification pathway in place overseen by the Chinese Board of Genetic Counseling. In Taiwan, they currently have 14 postgraduate courses that also started in 2003 and are currently 14 genetic counselors that are board certified. And their certification pathway is currently combined between the Taiwan Association of Genetic Counseling and also the Taiwan Human Genetic Society. So in South Korea, they also have 2 postgraduate programs, which was developed in 2006. And they have 12 genetic counselors. And their certification is by the Korean Society of Medical Genetics and Genomics. And in Hong Kong, we have 6 trained genetic counselors. Most of us are trained overseas in Australia. And there are 2 postgraduate programs that has been developed since 2020. And last year, in 2020, there was also the Hong Kong Genetic Counseling Society that was set up. Next is genetic counseling education and training in India. I'm sure the audience is very much more familiar than me. So they currently have 213 certified genetic counselors as of 2021. And as I know, there are currently 4 postgraduate programs that has been developed in India beginning 2007. For the Middle East, I've only managed to get information on Saudi Arabia. So in Saudi Arabia, there are 20 genetic counselors since 2019, and they have 3 postgraduate programs, 1 postgraduate diploma since 2003, and 2 masters in genetic counseling since 2015. They also have a professional registration for genetic counselors established. So there are limited information that I could get for the other countries in the Middle East. So this is the final sub-region, which is Southeast Asia, which is the most familiar to me. So we start with Malaysia. We currently have 10 genetic counselors. Most of us, half of us are actually trained overseas. 4 of us trained in Australia and 1 in the UK. We have developed one postgraduate course in 2015, which is a master's program. And we also have just set up the Genetic Counseling Society in 2018. So next is Indonesia. So Indonesia, we have information that they have less than 10 genetic counselors, only because most of the genetic counseling are actually done by the clinical geneticists or medical doctors. So their first genetic counseling program was actually developed in 2006, and they have 2 professional societies, and the recent one is the Indonesia Society of Genetic Counselors that was set up last year. As for Philippines, they currently have 16 genetic counselors that were locally trained, and 1 postgraduate program, which was developed in 2011. And last year as well, they have set up the Philippine Society of Genetic Counselors. So I will go a little bit in depth in the next few minutes for these 3 countries, because we do share common professional issues and also the challenges to develop this profession in our region. In Singapore, there are 12 there are 12 genetic counselors that were trained, and they currently do not have a local postgraduate course because most of them are sent overseas for training. As for countries like Thailand, Vietnam, and Myanmar, they do have professional societies for genetics and genomic and genetic counseling. However, they don't have genetic counselors that were trained formally. So they run local workshops to train doctors and nurses in genetic counseling. So the trend in Southeast Asia is a lot of the clinical genetics services were established by clinical geneticists that were trained overseas from the mid-1990s. And for other countries like Cambodia, Laos, and Brunei, there are limited information on the genetic counseling education and services. So as I mentioned, I'm originally from Malaysia, so I'm most familiar with the education and training of genetic counseling in Malaysia. So the genetic services was actually started in 1994 by clinical geneticist Professor Dr. M.K. Tong, which was trained in Australia in clinical genetics and also HGSA board certified. So myself, in 2003, I was trained in the University of Melbourne as well under the graduate diploma program, and I returned back to Malaysia to work with Prof. Tong in UMMC. So currently we have a total of 10 genetic counselors, whereby 5 of us are trained overseas and 5 was trained by the local program. So 3 of us are actually working in public hospitals, 1 in a cancer research center, 2 in private hospitals, and another 4 in private health services. So between 2014 to 2015, 2 of us are HGSA certified. And in 2015, we have set up the Masters of Medical Science in Genetic Counseling. As mentioned earlier, we have also set up the Genetic Counseling Society of Malaysia in 2018 because we finally have enough genetic counselors to form a society. And we're currently working on local credentialing pathway to be created to certify more genetic counselors in practice. So because the first 4 of us genetic counselors in Malaysia were actually trained in Australia. So at that time, in 2004, the genetic counseling profession is still very new and we didn't have a local certification pathway in place. So 2 of us, after completing the graduate diploma in genetic counseling from Australia, we decided to request the HGSA to consider us as overseas applicants to go through the certification. And at that time, the HGSA required us to have a certified clinical geneticist as a supervisor, and we were lucky to have Professor Tong to help supervise us in this certification. So in 2014 to 16, myself and Miss Yun, we finally completed the HGSA certification. And currently we have 2 more candidates that are going through certification. But this year, HGSA has limited their certification to only GCs practicing in Australia and New Zealand, but they are very supportive to help other countries to develop their own certification pathway. So this is a snapshot of the Masters of Medical Science in Genetic Counseling. So it's also a 2-year full-time course with lectures, seminar, role plays, and clinical placement. So we try to emulate the genetic counseling program overseas as well, for example, like in Cardiff University and also overseas program. It is accredited by the Malaysian Qualifications Agency, which is the formal recognition of Ministry of Higher Education Malaysia. So I'd just like to share a little bit about the genetic counseling education and training in Indonesia. So it was developed by Prof. Sultana in the Diponegoro University, and she herself was also trained in Australia in clinical genetics. So she has contributed a lot in the development of genetic counseling in Indonesia. They have a master's program in genetic counseling in 2006, and most of the genetic counseling students are medical doctors, and a small number are actually non-physicians, nurses, dentists, biologists, and also other allied health professionals. So they currently have 2 professional societies, Indonesian Society of Human Genetics and also Indonesian Society of Genetic Counselor, which was set up last year. Next is the Genetic Counseling Education of Philippines. So the development of genetic counseling was led by Prof. Carmencita Padilla, which is a pioneer clinical geneticist and Chancellor of University of Philippines. She was also initially trained in Australia. And with the newborn screening being mandatory in 2004, it has really helped the development of genetic counseling programs in Philippines. And they have the Masters of Genetic Counseling set up in 2011. And also recently, Philippine Society of Genetic Counselors. So the goal of the professional societies, similar to Malaysia and Indonesia, is really to integrate genetic counseling services and also help create official job positions in the public service and the healthcare services. And lastly, to also create a pathway for certification, which is locally overseen. So these are the common professional issues that we share. Basically, shortage of genetic counselors, no formal post. We are still working on the certification, licensing, and registration to regulate the practice locally. So the future directions is Thank you. So the future directions is basically to get the genetic counseling profession more recognized within the healthcare professional and services. Hopefully in the next few years, we will get more job positions specifically for genetic counselors and certification pathway and more training programs. So lastly, I would like to acknowledge the support of clinical geneticists in Asia, especially from the Asia Pacific Society of Human Genetics. So in the past, since 2004, there were not many genetic counselors training and practicing in Southeast Asia. And it was over the years that through conferences and networking that we've discovered more genetic counselors that were practicing in the region. And we realized that through the workshops, and that's how we found out about the genetic services from our neighboring countries and the need to train more local genetic counselors. So because of this, we have the opportunity after we've got to know more genetic counselors in the region to set up the Professional Society of Genetic Counselors. So the Professional Society of Genetic Counselors in Asia was actually set up in 2015, which is a special interest group from the Asia Pacific Society of Human Genetics. So throughout the years, during the Asia Pacific Congress of Human Genetics, we have organized 3 pre-conference workshops for genetic counseling. And we've managed to find out more about the genetic services in different countries in Asia. So through this collaboration, we managed to also contribute to the current resources and literature and also publication. So these are just some of the activities of our society. And in December 2021, because of the similar professional issues that we have, we are being challenged with, we have organized a forum between the professional societies in Southeast Asia and also in India and Taiwan to share on the training certification pathways and basically to see how we can collaborate to further develop this genetic counseling profession in our region. So in summary, I feel that the genetic counseling education and training has developed in different stages in Asia Pacific, and there is still much need to develop this profession in developing countries. There is still a shortage of genetic counselors in different countries, even in Japan, where they have the most genetic counselors. And we need to train more genetic counselors to meet the demand of genetic counseling in our region. So one of the ways is to request for funding and support from our local government so that we can train more counselors which are trained in respecting the local culture and culturally sensitive and also being able to speak local languages. So local certification pathway is needed in our region, especially in developing countries, to regulate the profession and maintain the standards of competency and practice. Thank you for your attention.
Thank you, Ms. Juliana, for taking us through all the different programs being offered in different parts of Southeast Asia. And you have brought, you have put forward the numbers of how deficient the counselors are in the healthcare sector. But happy to know that we have a lot of, the numbers are much more, and thanks to all the renowned people sitting here. So that, but still we have to increase these numbers, and rightly said that education is one of the ways in which we can increase it. Thank you so much. We move on to the next speaker now.
Challenges in training genetic counselors in cancer genetic counseling is the title of the talk. And we have Ms. Yu Soo Ki from Malaysia. She is come here. I invite her on stage. And Ms. Yu Soo Ki, she's a consultant genetic counselor, head of genetic counseling unit, Cancer Research Malaysia, visiting genetic counselor, University Malaya Medical Center, Beacon Hospital, Pantai Hospital, Kuala Lumpur. She finished her graduation and master's from United Kingdom, graduate diploma in genetic counseling from Australia, and she is fellow of Human Genetics Society Australasia. She has over 15 years of experience in genetic counseling in cancer research program. She is one of the 2 certified genetic counselors in Malaysia, which is accredited by Human Genetics Society Australasia. She was the head of Familial Cancer and Genetic Counseling Program in Cancer Research Malaysia and the principal investigator for a national-wide study on mainstreaming of genetic counseling and genetic testing for ovarian cancer patients in Malaysia. Member of Genetic Counseling Society Malaysia, she has lots of memberships in various genetic counseling societies all across the world. We welcome you.
Thank you very much. Thank you very much for the warm welcome. Just a little correction. I was the head of the genetic counseling unit in Cancer Research Malaysia, and the team is led by my colleague Tiara Hassan now. So once again, thank you to the organizers, particularly Dr. Annie. Thank you so much for all your efforts in bringing me here today. It's so lovely to actually be in the physical presence of fellow genetic counselors and clinicians working in the genetics field. It's such a rush. So the title that I was asked to speak today is about the training of GCs in using oncology as an example. Now, all of the talks that we have had previously was a very good platform to start the discussions going in terms of the training component of someone to become a genetic counselor and what needs to happen after that in terms of certification. But as genetic counselors and all of you here today, it's also important to think about how we continuously upskill, continuously learn new ways of delivering genetic counseling, because the field is evolving. And I think we all know that with the advancements in genetic technologies, it is continuously giving us new challenges in terms of interpretation of results, but also because of the decreasing cost of sequencing, and that's across the board for all sorts of tests. We see that more and more people will start wanting to do genetic testing. So today, what I'm going to do is just using cancer as an example, but it's not only relevant to the disease of cancer, but all across the board of all genetic diseases. What we should be looking out for, and at the end, to actually really leap forward and think, how are we going to keep up and be ahead of the utility of genetics game, so that we are able to be of good support, which is the primary basis of us being genetic counselors. So I bring your attention to a very nice publication by Anna Middleton a couple of years ago that very nicely describes the role that we play as genetic counselors in 4 very key different areas. So if we say the clinical work is the basis of all our work, so the patient care, working on the service itself. But more and more so, if you move to the top right quadrant, we do need to be in multidisciplinary teams. And as demonstrated this morning by all of the case studies, we never work in isolation. It will always be with other clinicians, other expertise, and more so with the technology fraction as well, learning how to deal with the mess of information and interpretation. On the bottom right, research and policy. So we all hear about the challenges that we have for the profession itself. I urge everyone here to be involved in everything that goes on in terms of the research side in order to get the data that will be important for policy making, because we can't just talk about it and depend on, say, okay, Dr. Annie will do it for us, right? She is wonderful. She has been doing it all, but she needs everyone to put in your inputs as well. And that's really important. So it is on each one of us, it is our responsibility to really come up and particularly to get the data that is necessary for any kind of policy changes. And on the left bottom quadrant, so you have the professional training, which is for us to get all of the skills that we get as genetic counselors. But this doesn't end with just a certification. The constant development professionally, it's now more necessary than ever for genetic counselors. So using cancer management as an example, why is it becoming more and more important for us to really upskill as genetic counselors? So if we just break down on what is the utility of using genetic profiling in cancer management. So what used to be a lot more on diagnosis of a patient with cancer, so that we are able to provide risk management for the individual and for the family members. So that's where the cascade testing comes in. It's now moved on to more treatment-based genetic testing. So you have requests for genetic tests to pair with treatment without having to look at a priori risk or an inherited genetic risk. And also, more and more so, it's being used for prognosis as well. So let's look at what's changing in the first part, which is looking at, say, germline for diagnostic purposes and for risk management purposes. What are the new challenges that we are feeling now? That what is traditionally a bit straightforward in the sense that we have guidelines, who we're going to test, we know what it should be. So referral to testing. So you have that for the HBOC syndrome, you have that for Lynch syndrome and so on. But because of changes in technology, we don't do single gene tests anymore. We don't even do small panel tests anymore, because the cost of doing large panel testing has come down. So driven by market in a sense, and also some of you maybe from the laboratories will say that, it costs the same. We just want to run the same panels for any combination of the cancer profiles that you have. So we still have guidelines. We still have guidelines that say, okay, only these individuals need to be tested. But specifically what genes need to be tested, there are very good publications that defines which are the actionable ones. So for example, for breast, you only have these 7 genes that you really can use clinically. But if for the patient or for say certain labs, they'll say, your 7 genes are going to be embedded in my large panel. So why don't you just run it? Right? It's the same cost because it's all done by NGS and it's the same panel. It actually costs them less to run one panel than to try, report on different groups of genes for you. So because that is available, the option is available to the patient, and some patients may say, I want the best bang for my buck. I want to test all of it. So then what becomes initially for us to use in terms of the result for risk management, then we have to deal with all of the other genes. So what happens if you have an incidental finding in a gene that is not so well established in terms of evidence for risk? Your primary goal has always been on the breast case, like in this case, as an example. But then now you have to deal with all of some other secondary finding for a gene that may not be related. So these are some of the things that we really need to upskill as ourselves. Firstly, we need to know these panels well. We need to know why they are even there in the first place. Were they because of some other reasons that we want to set up these panels? But in particular, how do we manage patients that have got secondary findings? Because that's going to be more and more common as the panels grow larger and larger. So these are things that we need to upskill. And while we are see these changes in our clinic, it is really so important to be able to gather some of these data as well. So working in the clinic doesn't mean that you can't collect data, and psychosocial data is immensely important for us to understand how patient views these things, right? So I urge everyone to just have a little think that in your practice, even though it's a clinical practice, think of what kind of data you can collect. So short little interviews, questionnaires with your patients, you will know better than how do they feel about this. They may feel that as an they might feel that it's okay, secondary finding, it's fine, but some people may say, actually, maybe I didn't want to do this in the first place. Maybe I didn't want to know, it's causing me more stress. But we don't have that sort of data, so it's very hard for us to determine and to say, look, tell our providers, I only want these 7 Gs, just give me these 7 Gs. So these are some of the things that we should think about as practicing genetic counselors. Next, we know that in the cancer field in particular, there is a big push of using genetic profiles for precision medicine. So you are having a lot more testing done, be it in the somatic field or be it in the germline arena. So I want to give an example. This is another area that we all need to upskill. Again, because this space changes so quickly, right? How do we use this information? So what oncologists need is a large profile, as many genes as possible, huge genes, because they just want to know whether a patient is suitable for certain types of drugs. So it is precision medicine, it is about drug pairing. But at the same time, when it comes to guidelines, these are also being changed. If a patient with no a priori risk has to do a genetic test for treatment purposes, there is no criterion. So it doesn't matter whether they have a family history, it doesn't matter their age of onset. So you do not have this sense of being able to calculate a priori risk, right? And because of that, and because of the range of test results that are necessary to pair with a certain drug. And I'm using PARP inhibitors as an example because that's the one that keeps changing depending on the cancer and so on. And you can see some just require somatic, some requires germline. And even though this is just for BRCA1 and BRCA2, I know that a lot of it is just done from a full somatic panel, which we're talking about hundreds of genes. And more so, the same labs that do the somatic test require a paired blood sample for germline in order to rule out germline so that they're able to calculate the somatic upticks better. So it will report on germline incidental findings. So if we delve to all of these genes, how many of them actually are actionable, right? So you can see you have a lot that may have some guidelines for risk management, and that is what I mean by actionable, meaning you find it, there's something you can do about it. So there are some which are written in red here, which has publications that report some of the actionable findings, but they are not in the guidelines yet. So when you have something that you find inside here, you have a guideline, you know what to do with it. But if it's not in this guideline, you will be left with pathogenic variants in genes that supposedly have an association with risk, but you don't know how high, so you don't know what to do with it. So with an increasing number of genes that are being tested, we constantly will need to upskill. We need to know how these are done. We need to know how to interpret it. And as all of you know, the higher the chances of incidental findings, the higher the chances of finding a variant of uncertain significance. So all of these need to be taken account, and we need to know how to deal with it. This is not the future. This is already currently happening, and we all need to learn how to manage this. So I give you a case study on what sometimes is very difficult in terms of particularly managing families with an unexpected finding. So if we have a family pedigree like that with breast ovarian cancer, and the breast cancer samples are sent for somatic testing for treatment purposes, and you get a result like that, and there is an supposedly incidental finding, it finds a germline mutation. But the thing is, with that pedigree, this is not really unexpected, right? You don't not expect the BRCA mutation. So this one you'll be able to manage, even though the main reason to do the test initially was just to do a somatic test to find the treatment pairing for PIK3CK.
The last 3 minutes.
Okay, thank you. If the same result was for this individual here that has no family history, and yet you have to tell her that she has a BRCA1 mutation. Firstly, you have to manage her because she wasn't expecting that. Secondly, you have to manage your family because they will then need to do cascade testing. They have no prior idea that there might be an inherited risk. How are they going to deal with it? What's also more important is for a phenotype like that, how do we actually really explain the risk? We have to delve down and look at the actual variant and see whether there are reports on the range of risk for this particular variant, because the range is also very, very different. So this is just an example of some of the complications that you can get when the test is chosen for treatment purposes, but you find an incidental finding. So in the last 2 minutes, I would just like everyone to think about the future then. Where do we see our role, and using cancer again as an example, in genetic counseling when we leapfrog into the future? So we know that genetic testing is going to reduce, and it might become such that public policy would want to screen population. Because the goal ultimately is to try and reduce risk, is to try and use genetic information to help us with risk management for all sorts of diseases. So I would like to bring your attention, just one example. Ken Offit from Memorial Sloan Kettering published this, and he said that if they had tested cascade testing and offered it, they would find within 10 years, all of the BRCA carriers in the US. So if you find hypothetically all of the BRCA carriers, then you will be managing them and you will save a lot of cost for treatment and so on and so forth. Imagine if this is actually a policy. So we're talking about mass population screening, but still targeted because this is cascade at the moment, but we're talking about huge numbers. So what sort of role would we as genetic counselors need to play, and how would we prepare for a future which might happen soon? Because in terms of policy, this is cost saving in terms of healthcare. You find high risk individuals, right? But how do you actually roll out something like that? Genetic counselors need to embed themselves while these policies are being thought of and so on. So it is very good that you have policymakers here today, because genetic counselors need to be upfront when discussing about this. Another area, so that was targeted high-risk individuals. But this was reported in ESCO recently and it took everyone by surprise. So they have a trial in the UK now in London where WGS is being rolled out in GP clinics, right? And the goal is to look for high-risk individuals, mainly in cancer and in cardiac cases. They have a list of actionable genes, but it is being rolled out by GPs. And that's because WGS cost is now reducing. If I'm not wrong, someone told me eventually it's only $100 to do your whole genome. So again, policy, it might make sense to start doing this. But what are we going to do in this sort of scenario? Okay, so think about it. We need to be involved if these things start to appear, and it might very soon. It's already being trialed. So in summary, the utility of genetic profiling is growing, it is changing, which means we have to evolve as a profession. We have to upskill, we have to learn all of the new technologies, we have to learn how to look at new ways of explaining this sort of data to our patients. And finally, we do have to be involved in a lot of the policy making. So thank you everyone for your attention today.
Thank you so much for a wonderful talk, Ms. Yusuki. It's definitely not easy with increasing number of genes that are offered for testing, but definitely it's not easy to be a good genetic counselor. This conference is all about giving that extra edge step, one leap ahead for the genetic counselors. Give a big hand for all the genetic counselor and the speaker here. Thank you so much.
So next we have Miss Laurie William. Miss Laurie is an assistant professor from the College of Health Professions, University of Arkansas, USA. Her academic qualifications are as follows. She's a Bachelor of Arts Biology, University of Missouri, Columbia. Master of Science, Human Genetics and Genetic Counseling from University of Michigan. Clinical Pastoral Care Program from University of Oklahoma Medical Center. And her career highlights include, she's a member of National Society of Genetic Counselors, developed the Genetic Counseling Graduate Program. She has received several awards as well, and she's authored a book which has come in different editions also. Over to you, ma'am.
Good afternoon. Thank you for that introduction and for the invitation to present. My name is Laurie Williamson, and I am on the faculty at the University of Arkansas for Medical Sciences Genetic Counseling Program in the United States.
Little difference between technology and human minds. So no technology can replace human mind and physical presence. This is a good example. The team is fixing up the problem.
Good afternoon. Thank you for that introduction.
Adversities give rise to opportunities. COVID has taught us this. We've all been online for a couple of years. Now there is no more COVID. See? So it is not obeying.
Good afternoon. Thank you for that introduction and for the invitation to present. My name is Lori Williamson, and I am on the faculty at the University of
I think we have, Mr. Suraj, we can have the next talk and then.
Just a second, ma'am.
Okay, okay.
Hello, Laurie, can you hear me? Hello? Hello?
Yes.
Laurie, are
Yes.
you here? Can you able to give the live presentation now? You have the presentation? Can you give the live? We are facing some problem for running your pre-recording talk. So can you give the live presentation right now? Possible for you? If it's possible?
Oh, to do a live presentation.
Yeah, live presentation. Will it be possible?
Let me see. Just 1 second here.
Okay.
I want to pull it up.
Ma'am, there is some technical error. So we will get it fixed up. We will have the next speaker now and we will shortly connect back. We will get this fixed up.
It's my privilege to introduce Mr. Abhijit Gur. He is marketing head at Lilac Insights. Has done Bachelor of Pharmacy from Nirma University, India, and completed MBA in Pharma Marketing, National Institute of Pharmaceutical Education and Training, India. His area of interest is pharma marketing and worked as a Senior Marketing Excellence in Cipla, India. So the title of his talk is Academic Partner Lilac Insights, Bridging the Gap Between Academic
introduction and
Genetic
for the
Counselors.
invitation to present.
I
My
welcome
name is Lori
Mr.
Williamson, and I
You have 15 minutes, sir. We have to stick on time.
Yes, yes, sure. Audible? Yes. Thank you for the warm welcome. I would like to welcome the dignitaries, respected dignitaries and audience here. It's my privilege to give a talk in front of such a knowledgeable audience, and I'm slightly terrified with the fact that I may be the least knowledgeable person when it comes to genetic counseling or genetic disorder management in the room. But no problem. I'm still the part of the ecosystem that wants to take the whole concept of genetic counseling, inculcating genetic counseling as a part of the mainstream medical practice. So I am Abhijit Gun. My pronouns are he and him. This is the culture that we follow at Lilac Insights, where we introduce with our pronouns. I head the consultations business for Lilac Insights, which entails two businesses: mental health consultations and genetic consultations. Before I start, I would just like to play a small video in terms of what genetic counselors actually do and what we feel about genetic counselors. Krishnan, can you have the video? I think, I believe, ma'am, the technology is still in not our control. Yeah. So basically, what we want to understand and what we want to talk about is how can all the training that you get educationally through the different courses across different colleges in India, how can we make you more ready for the industry, the fast-paced demand of the industry? How can what sort of training can be additionally provided by the industry in collaboration so that the genetic counselors are pretty much available as soon as they pass out or pretty soon after they pass out to start practice and be part of the whole medical system. The video has slight sound, but I think yeah. So I think this is a very important point where I would like to draw your attention. Should it be the last resort, as we are seeing in majority of the cases today, right? People come to genetic counselors or doctors approach genetic counselors as one of the last resort, right? Is it true? Or is it an apt time that genetic counseling be a part of the regular practice and not be seen as the last resort, rather be involved right from the start when we are suspecting to diagnose, and it will help people, it will help the ecosystem to save a lot of time, a lot of money, a lot of effort, and give the right direction, give the right diagnosis to the people at the right time. Some boring stats, but very important and large data. 4.8 crore pregnancies in a year in India, slightly 2 to 3 years old data, out of which only 45 to 60% pregnancies end with a birth. 22% pregnancies result in stillbirth, out of which around 30 to 60% are due to genetic causes. 12 to 15% spontaneous abortions in India. 13 to 19% couples in India suffer through infertility, and a majority of that is due to genetic causes. Almost 30 million estimated thalassemia patients in India, or rather carriers, and 6% of the total births that the live births have birth defects, out of which around 50% is due to genetic causes. Now, this is only the prenatal or the reproductive medicine care segment. If we add the onco segment, if we add the neuro and other segments, adult onset disorders, the burden is going to be huge, which means the genetic disease burden in India is very, very huge. One of the key stakeholders in managing these conditions, genetic counselors, their availability is very scarce. We saw not only in India, but globally, I think the last speakers talking about other countries also facing a similar issue. So what can be done? What can be done to resolve this, right? And this equation is an alarming equation that all of us, not only you as genetic counselors, but we as representatives of the industry need to take care of and deal with. So the need of the hour is trained genetic counselors who are psychosocially aware. What do I mean by that? Being compassionate, empathetic, treating with care, treating with hope, right? So psychologically aware, socially aware about different dynamics, people coming to us. I was hearing a talk in the first session where somebody was saying that they saw two cases where the cause was due to a male infertility or azoospermia, but still the female was being blamed, right? So you need to understand the social fabric of the country, social fabric of whom you are treating, whom you are counseling. So psychosocially more aware counselors, updated about latest technologies, right? So the genetic diagnostic field, the industry is going through a huge flux and there are continuous innovations, right? One day you hear about PGT, then you have PGS, then you have PGTM, and so on and so forth. So there are so many. There is NIPT, there is tax-based NIPT, there is MPSS-based NIPT. So there are so many newer advances that keep on happening over a continuous period of time. You need to be collaborative, right? And I think that's one of the major flavor that I could see through the sessions. We need to be collaborative, not only with the patient, but with the industry, the diagnostic industry, the doctors, the caregivers. So a very collaborative approach, and also eager to create awareness, because if we are 300 to 350 people group who are dealing with such huge patient burden, you need to be creating a lot more awareness, right? And you need to get the right platform to create that awareness. And awareness not only through camps, but all the latest mediums that are available to create awareness about genetic disorders, about the role of genetic counselors, about the role of genetic counselors in treating key disorders and reducing the burden in the country, in the society. Right? So what do we do as a industry representative? What is that we can do? Obviously we can give you platforms, but how can we make you all more ready for the demand, for the future needs, for what the future entails or asks from us, right? So we deliberated, and we have a team of genetic counselors, around 5 people. We take a lot of interns also, time and again. So we deliberated, we discussed with them, and something common that came out was, can we launch a industrial training program for genetic counselors, right? And various, this can be availed by a lot of different segment of genetic counselors, right from freshers to experience. What is the main objective? The larger objective is to bridge the gap between the academia and what the industry demands, right? So academically sound, but what are the other aspects that you need to take care of while you practice, right? While you practice with patients and deal with them continuously. In our head, there are 3 pillars through which whoever attends the program or joins the program can benefit from, right? And I'll talk about those 3 pillars. The first pillar is learn, right? So what are we asking you to learn, or what will we teaching you? Teaching you about latest diagnostic test, not only theoretically, but through real life experiences or real life cases. Learn from leading genetic counselors and clinical geneticists across the country, not limiting to a particular geography, but across the country. Because we have clinics, we have those tie-ups across the country, there is an opportunity for anybody from anywhere in India to collaborate on this. Learn the psychosocial aspects. So as we discussed, right, psychosocially more aware counselors. So one of the business that I had along with genetic counseling is mental health counseling called ATIS, and it's India's first perinatal mental health platform too. So we have a lot of experts, psychologists, clinical psychologists, and psychiatrists who will be a part of this program to make you psychologically more aware, give you those nuances of when you are dealing with different people from different backgrounds, different societies, what should you be taking care of. Different subdomains, right? Not only prenatal, but perinatal, preconceptional, oncology, premarital. So we are seeing a lot of people, because the mean age, marriage age has gone up, people are becoming more aware. So they want to be very sure of. And we heard a famous celebrity, Twinkle Khanna, talking about testing Akshay Khanna's family before getting married. So these are nuances these are experiences that people will start sharing, and maybe premarital counseling, premarital testing will go up, right? If you have to reduce the genetic disorder burden, that's a very key factor. Then personalized genomics. In India, personalized genomics is still not a huge thing. It is catching up really fast in the West, but in West it is recreational, right? So we are at the cusp of launching some very innovative personalized genomic tests. So an experience about personalized genomic testing, which is which is going to be very unique and first time in India. Also, different opportunities in the industry. There are, whenever I interact with genetic counselor, I feel there are very limited opportunities that they're thinking about when they're looking for job or when they're looking for collaboration. So we will give them different aspects of job or opportunities that they can look at. Once they learn, what do? They apply this theoretical knowledge into practice, right? And how do they do it? Not just by observership, but by doing supervised, graded, and independent counselings, right? So we'll allow them to do independent counseling so that they learn firsthand, not just do observerships. Interaction with clinicians and patients on a day-to-day basis, and this pool is from the Lilac Insights pool. And an experience to create awareness, right? Awareness about genetic disorders, awareness about genetic counseling, and the importance of genetic counseling. And we firmly believe that if this applied and if this done properly, this is going to help them or empower them to excel in their career. There's also a chance to be absorbed in Lilac Insights in different roles and different responsibilities and opportunities. There's also a possibility to be part of our aggregator network. So we are realizing that, okay, as an organization, we might not be able to hire 50 genetic counselors, but does that prevent me from networking and creating a network of 50 to 100 genetic counselors who can counsel patients, our patients, Lilac Insights patient? We might not be able to hire everybody, but we can surely give them an opportunity to help the ecosystem, help manage genetic disorders in India, right? And thereby networking with professional build. That's a soft skill, but it's very important. This is one conference, and I think it's happening after 2 years of pandemic. So networking becomes very important in today's day and age. So as a part of this initiative, networking skills are also going to be improved.
Last 2 minutes.
Yeah. So what will the participants get? The participants get a certificate of completion and a letter of experience. They also get assistance in BGCI certification from fresh level 1 to level 2, and placement opportunities at Lilac Insight. These are to just name few. As clinical GCs based anywhere across India. As lab GCs, again, we have different labs operating in the country, lab GCs in different departments. Be an MSL, one area where I feel genetic counselors are not very keen to embark on, but very important to create awareness. So MSL has an opportunity, and lastly, be a part of our aggregator network. What will happen this way? This is making our next generation, our population future ready in terms of industry, clinical care, service delivery, innovation, be a part of research, be a part of training, right? So that as a community, we can grow together. So as a community, let's grow together, right? And move the needle of genetic counseling and the awareness about genetic counseling in India. So for more information about the course, about the industry training program, you can visit our stall in the dining area, stall number 9. We have more information for you, and we can discuss, and whatever suits you, we can take this up from there on. Thank you.
Thank you so much, Mr. Abhijit. We also agree with you, learning together for working together. That should happen in India. How can it happen? It can by encouraging interprofessional education in healthcare system. All of us should respect each other, should know how difficult other profession is. And we look forward, I think, in the next meeting, we will all be open to accept each other. And, there is no high-headedness. Nobody is superior in healthcare system. So thank you. Thank you so much, Mr. Abhijit. Can we have the recorded talk?
Yes, sorry about the technical glitch. We have the recording ready. And also to thank Ms. Lori Dean to have accepted to save us at the last moment technical glitch. But I guess the video is ready now to be played. Audience, spectators live online, your questions are taken, noted, and it will be posted to the panelists during the panel discussion. Thanks for your patience.
Good afternoon. Thank you for that introduction and for the invitation to present. My name is Lori Williamson, and I am on the faculty at the University of Arkansas for Medical Sciences Genetic Counseling Program in the United States. And so I've been asked today to speak about those essential aspects of the global genetic counselor. And so I've broken my talk up into 3 parts. First, I want to provide just an overview of genetic counseling training in North America, and then talk a little bit about aspects of the international applicants and that process for them when they're applying to North American programs. And then I'll come back to wrap up with what I think those essential aspects for training a global genetic counselor are, and provide some of our personal experience. So first, just let me give you the skeleton of the genetic counseling training structure in the United States or in North America. Right now, there are 53 genetic counseling programs in the US and 4 in Canada. Of the 53 in the US, 16 are new accredited programs. That means that in the last 5 to 6 years, we have experienced rapid growth in adding genetic counseling programs in the US. Also, there are 2 more that have been approved for candidacy and are in the process of development. They are not yet accredited as a new program, but they are in that process. Then there are 2 organizations that oversee the programs and then the certification process. So the Accreditation Council for Genetic Counseling, or ACGC, this is the body that accredits the genetic counseling programs. And so they are in place, and that organization is in place rather, to make sure that the programs are teaching what they're supposed to teach. This organization sets the standards for the programs and protects the students. They also set the standards for the minimum competency level that an entry-level genetic counselor should have. And then the American Board of Genetic Counseling, or ABGC, they create the certification exam, administer that exam, and certify genetic counselors. You'll notice 2 aspects of our structure are not on this slide, and that is our National Society of Genetic Counselors. It really does not have anything to do with the training process. It is our professional organization. And then also licensure of genetic counselors. Again, that has nothing to do with the training process. That is a state-based process for assuring that the individual who says they're a genetic counselor and they're practicing genetic counseling is in fact a qualified individual. So let's look at the application process just very generally. So I mentioned these programs in the US and Canada. Each program has its own application. There is not a uniform application process, and there is discussion about that, but right now that does not exist. So each program has its own application, its own fee structure for those applications, and its own process. Also, each program sets its academic prerequisites. Now, the prerequisites are pretty standard across programs. Applicants need to have a strong background in the basic sciences, biology, chemistry, molecular genetics, etc. And they also need to have some exposure in psychology as well as to biostatistics. Now, programs also, at least in North America, have non-academic prerequisites. Now, these are in place to demonstrate that the applicant understands the profession. They understand what they would be getting themselves into and understand the work. So these prerequisites might be shadowing a genetic counselor, being a genetic counseling assistant, working with individuals with developmental disabilities, teaching, etc. Now, and those vary, and the weight of those vary. I need to say that also another academic prerequisite that I forgot to mention is the grade point average, or GPA. Okay, and those are generally very high for genetic counseling applicants. Now we'll jump down to personal statement. So in North America programs, they require a personal statement which gives the admissions committee some insight into that individual before they may be selected to be interviewed. Standardized testing. So pre-pandemic, standardized testing, namely the GRE, the Graduate Record Examination, was required for most genetic counseling programs in North America. During the pandemic, that requirement was set aside. Currently, programs are making decisions about whether or not to reinstate that requirement or let it be. Right now, most programs have just remained silent on that. Well, they haven't remained silent, they're just not picking it back up as a requirement. So we'll see what happens in the next couple of years. Also, pre-pandemic, most programs, in fact, I think all programs, invited applicants to campus to interview. So the interview was in person. During the pandemic, obviously this was also set aside and interviews became virtual. Most programs, at least in the discussion I saw last spring, are maintaining virtual interviews. It's worthwhile to note that there is currently another round of evaluation and push for more diversity in the genetic counseling profession in North America. And we know there's data evidence to tell us that standardized testing is often puts individuals with perhaps not, who are underserved or come from lower socioeconomic backgrounds or different cultures, it puts them at a disadvantage. You can also imagine if you are traveling to interviews around the country or even around the world, how expensive that would be. And so someone from a lower socioeconomic standpoint would not be able to do that. And so removing the GRE and making interviews virtual has really done a lot to increase the diversity of applicants being interviewed. And so I hope that it will stay that way going forward. In 2018, the genetic counseling programs in North America instituted a match process. And so what this is where once the interview has happened, programs will rank their applicants from the top, down to even individuals they decide not to rank. And then the applicant also ranks the programs where they interviewed. And then it's all put into a computer system that has algorithms built in to establish a match. And on a day late in April is our match day. And so programs and applicants are notified where they matched. Now, I want to just make a note for the international applicants. They have 2 additional requirements, at least. One is an English proficiency assessment, and then the other is transcript evaluation, which also adds cost for the international applicant. So we're beginning to see more literature looking into the global genetic counseling, the globalization of genetic counseling, and now into the applicants themselves and the process for international applicants. And so this study in 2016 looked at motivators for an individual to apply to a program outside of their home country. Now, this study had mostly Canadian participants, and these Canadian participants were mostly applying to programs in the United States. So it's perhaps not very generalizable, but I do think it says something, and it's a first step in assessing this. And so the Canadians, their top motivation was that there are only 4 programs in Canada, so it's extremely competitive to enter one of those programs. And then Canadians, as well as individuals from other countries, commented on the limited number of programs in their home country, and then some even had no appropriate training program in their home country. Two other studies, 2016 and 2013, began to explore what are those factors that were important to an international applicant when selecting a program. Now, most of the Canadians in these studies cited geographical location, but not all. And so in order of importance, you can see here on the list, it started with geographical location, but then also included program reputation and cost of attendance. Some of the challenges cited by international applicants in these studies was this application process, the cost of attendance, and visa sponsorships. Now, a recent study conducted by the International Special Interest Group of the NSGC, the National Society of Genetic Counselors, this was presented at the NSGC meeting last year. They interviewed program directors. So they sent out a survey. They had 24 responses from North American program directors. Most were, of course, from the US and some from Canada. 60% of their respondents indicated receiving approximately 10% of international applications. So 10% of their applicant pool were international applications. Most, like 93%, were from India, and then Canada, and then China. The challenges cited by these program directors were how to evaluate a foreign transcript, and they had little knowledge of the visa process for students and then the work visas upon graduation. So what do the applicants look like most recently? From the national match data, in 2021, there were 2,069 applicants overall, and about a little over 50% of those individuals matched to a program. Of those applicants, we don't know actually how many total international applicants there were. That data is not known. However, we do know how many international applicants matched. And we know that 88 received interviews and submitted rankings, and of those, 16 matched, which is a pretty small number. So now the international applicant has become a student. And so what are some of the challenges for them as a student? And again, going back to these two sentinel pieces, these two studies that have really looked at this, they cite just interactions with their peers, writing papers, the cultural adjustment, language, and not learning the US healthcare system and learning about medical insurance. So going back to that survey of the genetic counseling program directors, they were also asked, so when you have an international student in your program, what are some of the challenges? And look, 3 challenges that they cited were listed also for the students: the cultural differences, language barriers, and lack of knowledge about the US healthcare system. So now the applicant became student and the student has graduated and they are now in the workforce. Now this data is a little old. I know there are more programs in India than existed at the time of this study, but you can see here the workforce is, there is no doubt that genetic counseling is globalized and the workforce is definitely growing. Okay. This data has not yet been published. This is fresh data that Dr. Smita Rao was willing to share with me. She's the co-chair of the International SIG for NSGC. And so they have looked at some of their membership. So 8 of their members, that's 10% of their membership, are currently non-US based and they're not NSGC members, interestingly. These individuals cited that they moved out of the US predominantly due to a spouse's job abroad. Half are working for US-based companies. Only 1 of the 8 reports working with the title of genetic counselor, and they all predominantly work in non-direct patient care settings. So what do we do with all of this information? Well, there remain many questions actually. And so I want to advocate for continued research. Currently, one of my students and a former student of Dr. Hassan, Chelna Galada, she is exploring some of this further for her research project, for her thesis requirement, but we need more. And also, most of the research is coming out of North America. And so as more and more genetic counseling programs become are started across the world, and as more genetic counselors are practicing across the world, I think we need to look at all perspectives, not just the North American perspective. Also, the studies that have been done have identified some barriers. And so if we know what those barriers are, we need to begin addressing them. And this ranges from everything with the application process all the way through to assisting with visas for job placement. I also encourage individuals, if you're in a university setting, to engage with your global health programs. That's what I did when I was at UAMS. I sat on the advisory board for our new global health program. And it was incredibly enlightening, and there are tremendous resources through the network of university programs that teach about global health. Also, begin reaching out and collaborate with international partners. Again, I have experience with programs in India, with our program. Just the collaboration is incredibly enriching. In fact, with one of the collaborators we've discussed, we need a funding mechanism for student exchange. The UAMS program where I work, we have sent 5 students abroad for exchange programs and clinical rotations. But we haven't had anyone be able to come to our program. And that is not how it should be. We should be able to do exchange programs equally. This is really key. The international students who are in our programs, I've seen this for myself, we see it in the literature, they struggle. They do not want to be identified as experiencing these struggles with culture or understanding the healthcare system or writing or whatever it may be. But they do struggle, and it is vitally important for program leadership and faculty to check in with those students. It may make the student initially feel uncomfortable, but if they understand that it's coming from a place of care and that this is an approach used to nurture students in the US, I think that the international student would come around to accept that help. Related to this, some of the recommendations out of one of the papers, I think it was the Sabadini paper, also suggested just mentoring, creating international support network for international students in the US. And I think that's coming. Also, it's just important to continue inoculating cultural humility among faculty and students. At least I'm speaking for the US. I think we're making strides, but we have a long way to go still. And finally, well, not finally, but an important one is reciprocity. So the American Board of Genetic Counseling has made some initial steps toward that, being able to certify a graduate, assuming they passed the exam, but allowing them to sit for the certification exam if they have graduated from a program whose accreditation is recognized by BGCI. So that's a convoluted process, but we know that there have been at least 2 genetic counseling programs outside of the US who have applied for that recognition. And then finally, some of the additional struggles just to be aware of, cited in some of the literature I reported on, is that an international student in a US program is very likely going to have some questions about the healthcare team model, the health system, the autonomy of genetic counselors in practicing in the US, and some of the psychosocial skills or techniques that we use in our practice. I want to acknowledge Smita Rao. She was integral in providing support to me as I put together this presentation. She's a dear friend and colleague and is co-chair of the International Special Interest Group of NSGC. She also owns her own company, Genecture, and just an esteemed colleague. And then one of my current students who actually worked as a genetic counselor in India and a graduate of the BIT University, Chalna Galada. She, as I mentioned, is doing her research around perspectives of genetic counseling program directors and students with this shift in some aspects of the application process. And so Chalna was also a resource to me. These are my references. And I want to thank you all very much for the opportunity to present.
We are done with all the talks. Now we have a discussion. We will take your questions. And those of you who had any questions with any of our speakers, you can post it. We will coordinate and give the answers to you.
Thank you so much, chairpersons and special guests of honor, and our moderator, Dr. Lakshmi, for this wonderful session. Without much ado, we are moving on to the much awaited panel discussion. I would request the chairpersons and the special guests of honor to please be seated on stage. And I would also request all the speakers online to be available on video. Shortly, we'll go on the multi-window mode so that all of us can see the panel discussion. May I request Ms. Yoon Suk Hee to join us, please, for the panel. Thank you so much. Can we have a big round of applause for all the speakers, chairpersons, and panelists? One important person is missing in this panel. How can we have a panel without Dr. Annie with us? This is our moderator's request to call you onto the panel. May we please have Dr. Annie on stage. We do not have an introductory slide. She needs no big introduction. The President of Board of Genetic Counseling India, welcome onto the stage. In the meantime, I take pleasure in inviting again the Vice President of Board of Genetic Counseling, Dr. Lakshmi. She also needs no introduction now. She has led the state level project in Tamil Nadu, and all of us know how successful the model is. May I invite ma'am to please conduct this panel discussion. Over to you.
Hi, good evening all. Can I request all the counselors to come in front? This is our session. We are going to make it wonderful for all of us and the country. Come in front. Let's get more energy. It's for us, yeah. Who else will talk? We need to come in front. Don't go at the back. All the counselors who feel, because somebody who does it first always takes lots of effort and energy. You need that. So your participation, your involvement is what is going to take this profession forward. If you mean it, if you think you're there in it, participate. Okay? Okay. I'm so happy. I have already introduced Dr. Rao to you, and we have one other wonderful person, Dr. M.A. Shekhar, who is with us, and he's an academician and a clinician. So I felt it's a wonderful combination, and Dr. Shekhar is the Vice Chancellor of Adi Chunchanagiri University, Belur, Mandya. He's a member of the Governing Council, Mysore Medical College and Research Institute, Governing Council member and Adjunct Professor, JSS Academy of Higher Education and Research, Mysore, Adjunct Faculty, Department of Medicine, Inipoya Medical College, Mangalore, member Multidisciplinary Task Force to draft operational guidelines for NPCDCS, Ayush, implementation at ABHWC. He has his MBBS, MD, and FRCP. His area of interest is diabetes. He's a founder director and diabetologist, Apurva Diabetes Foundation, Mysore, India. Former director, Karnataka Institute of Endocrinology and Research, Bangalore. Former member, National Assessment and Accreditation Council, that is NAC India. Former Inspector, Medical Council of India. Editor and author of 4 books on diabetes. And he has 15 publications of national and international standing. I welcome you, sir, for this. And this is, I really hope this is going to be a great discussion where all of us need to participate. So as I told you earlier, the goal is, there are 2 things we are looking forward. We started the board in 2014, right? So 14, 15, 16, 17, 18, 19, 20, 21. Already we are. So what I was just saying is, it's already close to 9 years. We have the Board of Genetic Counseling India, and it's high time. And we all know gene genetics or gene technology is surging. Things, so much is happening around, and with lots of passion, Dr. Annie and many of us here put in, and now BGCI is there. Now we look forward to establishing the genetic education and training in the genetic counseling area as such. So we heard lots of speakers speak how they sort of went through in their country. And of course, the Japanese talk was more on the registry, which is again very crucial, where genetic counselors have a big role. So I think with all these 9 years of work and the challenges today, we are going to address the challenges of genetic counselors and genetic counseling profession, mainly in our country. And what is that we need to do as a team to take it forward. Next year, the 8th conference when we are sitting, I think our course should be accredited by the UGC, and wherever the recognition needs to come for us, both the state and the central, and the profession of genetic counseling should be recognized by the Indian government. Yes, do we want it? Yes. So we need to do whatever is needed and put across the points, and we have very special guests and senior members who are going to guide us. So I like this quote: a genetic counselor is like air conditioning. When you do not have it, you do not realize it. You do not realize you are missing it, but when you have it, you cannot be without it. So our profession is something like that. So once you know it is there, then it becomes very crucial. I think the medical faculty again needs to know the importance and see the advantage of having the genetic counselors, which is very crucial. It's going to happen. So this again, I think already it was there. So it just says the number. So you see the maximum is in the US, where we started off in 1960, we know. And then Europe, not everywhere in Europe they have the system to say Sweden doesn't have, Norway, Finland doesn't have, Germany doesn't have. No, but still, there is that the genetic counseling profession slowly growing. And of course, Africa, we didn't have specific people speak from there. And of course, Southeast Asia, it's again growing in a big way. So now you're seeing the graph, the levels, and you can see India, last but one. You know the population of our country. So we have the recent statistics 2022. The next slide. Yes, I just took it in the afternoon. 2022, it is close to 140 crores. And for that, the total number of genetic counselors we have is just 212. And so where are we now, and what are the actions we take? Of course, Sopani very passionately started off. Yes, we have this 1-year program started, and we thought to take courses in India, which has 2 years master's course again. The next slide, please. So genetic counseling as a mainstream profession, is there awareness in the clinical fraternity as such? See, one thing is there's a huge need. People understand. fraternity understand. The population as such, as the Amma today spoke so well, saying there is no awareness at all, but still educated, at least the urban people know what is DNA, what is gene, genetic disorders and all that. But then how much of awareness is there in the clinical faculty, because the medical genetics is less than 6 hours in the whole IMA as such. So I think I will request Shekhar sir to really address this as a clinician.
Well, good evening, everyone. I am very thankful to the organizers of this conference and the officers of BGCI for having invited me to show my ignorance. Let me express that I have very little knowledge about genetic counseling, though I have more than 44 years of clinical experience under my belt. You can see that I don't have a tummy. Having said that, let me start with two concepts. The first one is the all-pervading question of why. So when we ask this question, why, it also encompasses why genetic counselors. I had conversation with this lady sitting by my side 2 days ago. Before that, we were strangers. And then I thought, why not? So it's time. Every time somebody asks you a question, why, it should always be replied, why not? And today is the day we shall start the first step and say, why not genetic counselors in more numbers, right? The second one, thank you. The second one is there is a psychology. Again, the mic is giving me trouble. Okay, thank you. The psychological term, have you heard intelligent ignorance? Whenever we are not sure of something, we intelligently ignore it. So this is the clinician's concept of ignoring genetic counselors because they know very little about it. And to quote Sadhguru, the person from her place, but my senior, 2 years senior from Mysore, he was my senior in Mysore. He says, intelligence of ignorance, the day you accept that you do not know, you've taken the second step towards your goal. With these two, we have to go further. But the very phrase counseling is not a new concept for doctors or the physicians or the medical fraternity, because we cannot talk to every patient that we see. So we back up on counselors. And now the time has come to put a prefix called genetic counseling. We shall take it further. Thank you, ma'am.
Thank you so much, sir. It means a lot because this genetic counseling or the whole thing is to be handled as a team. It's a teamwork. As Sridhar rightly said, it's like nobody is high, nobody is. They are to work together and each of them have the expertise. And to really quote, I was explaining the project which we just completed for the whole of the state to say, yes, clinicians are very important. And again, most of the genetic disorders are there. They don't have a cure. So again and again, as a scientist, I would say, identify to prevent it. That's the first thing we have to do. So to identify is the molecular work, but from the base, again, have the national policy coming up. Again, counselors, we have a huge role to play. And it's all, we need to get together. And so when you say a national policy, immediately if you go to the policy and read, everywhere it's, oh, we don't have the numbers, oh, we don't know the numbers. Unless we work towards getting the numbers, is the policy not going to come into place, because they say the resources will be given only if we know the numbers. But then we should start working to get the numbers. But again, the urban people always, the elite one gets whatever is needed. They can meet up with the clinician, they can order for the test, get it. But I feel as a team as such, as is, India again is known by the rural setups and whatever culturally. And that part of the country needs to be attended. So the rural setup is so important if we really want to know the real burden. we need to know the control setup also. So there's a huge scope. You saw the numbers. Our population is so huge, and we know the number of genetic disorders, and there is enough work. And now the thing is, we need to have our profession recognized by the government, and also the training and education thing set really well. I think all of you will accept that this is the thing which we need to do in the next 6 months to 1 year. And really, because I know lots of genetic counselors now and then call up saying, what to do next, ma'am? We don't know. We are not being paid well. The government doesn't have counselors as such, but they don't have genetic counselors. But having said all this, the quality needs to be maintained. We as genetic counselors should be proud to, in terms of academics or the education behind it, the science behind it, the skills. And I was just asking, sir, because most of us, except a few, and wonderfully, always I quote Suraj, mostly it is women. Is there anything special we can add on to the UGC or the other program? Because most of the genetic counselors, because when you say empathy, patience, you can't just right royally immediately start talking to the family. You need the patience. And let's all accept the medical fraternity doesn't have the time. It's really the time, you know. So this has to be handled by one more person. So let's take it really well. And so one part is that, then the other one is the education, training, accreditation challenges. So when it comes to education, I just want Annie to say a few words here before we go.
Not just me, I think all speakers who have touched upon it, from Alison to Lori, all of them have pointed the importance of education and well-trained counselors. What they have tried to say is that genetic counselors have certain skills, and those skills are not impinging upon the areas of a clinician. Our skills are different, and that's why our training is different. That's why our certification process is different. Now, working with clinicians was only one aspect of genetic counseling. And like Suk has shown to us, Anna Middleton in 2017 has shown us what are the other roles of a genetic counselor, which is what Lakshmi is doing, joining with policy, advocacy groups, we have Prasanna. So the numbers we need are really high. In many countries, Juliana has shown us the lack of numbers there. And also in the whole of Southeast Asia and the Asia Pacific region, apart from, I think, New Zealand and Australia, in public hospitals and public service, there are no genetic counselors, and which is so unfair. Like Lakshmi said, we are not reaching out to it. If we want to be any of the speakers like that, Alice, would you like to say something?
Sorry, Annie, the sound just dropped out.
We just want to ask you that we are trying to get numbers of genetic counselors in India. And for that, we are asking our university board to recognize it as an important subject so that it can be a mandate by the UGC approved course, so that most of the academic institutions will offer it as a course. Did you hear it or not yet?
I heard part of it. I'm not sorry. I'm not. So, are you asking about how best to have multiple universities offer genetic counselor training so that you can scale up the numbers quickly? Yeah. So, one of the things that we have been talking about with the Human Genetics Society of Australasia is our role as a as a provider of education, and I wonder if the Board of Genetic Counselling India has thought about themselves as as a potential education provider, so that things can happen through the board rather than across all the individual universities. That's how we started in Australia and New Zealand.
CI does not want to take the onus of running the courses.
Yeah, fair enough.
Counselors and accredit courses. But we want universities and institutes to come forward to run those courses.
So I don't know. Juliana's here from Malaysia, and they've got the program started there. I guess what happened in Australia and New Zealand was that the HGSA offered a structure for the training where people could do different courses locally and put that together to be an early genetic counsellor qualification. And then once we had enough genetic counsellors, universities started to say, we can see there's a need for this, and we're happy to start offering the training. So it kind of, we needed to start somewhere, and we started with the HGSA monitoring the education of genetic counsellors until there were enough of us for the universities to take over the training.
Anybody else on speakers want to comment on this? So, would you want to say something?
Thanks, Annie. So I think the accreditation of the course in the universities is really important, because even if they do the course and it's not an accredited course, they will not be absorbed in the industry. Right? So I'm not sure how the system works in India, but in Malaysia, for the last, so for the Malaysian poverty credits in collaboration with the university and as a framework. So perhaps
that's our plan also. That
so you need to advocate for some of the universities to take it up. The reason why the course is slightly difficult to also organize is because it's so multidisciplinary. So they actually need to teach you the course. But these days, I think universities are very open to having external specialists come in. So like what you support the course in the university. So some way you can convince them that someone has a course. To have the units of it's an annual.
They all are doing the 2 years master's program, like New Zealand, Australia, or the US with that. We have started. It's only thing we feel very culturally and language. Like every time Lakshmi tells me, please give me a trained counselor who knows Tamil. I'm training in Telangana. So finding a very religiously take my 5 students from different parts of India but hope that they will go back to their state to do counseling. But that doesn't happen.
So, Akrita, you would like to add on the yes.
Sure. Before that, one small comment. It's told why. I would like to say how. I would want to give an answer. How can the number increase? We have a plan. First thing, UGC has to recognize. When there is recognition, people would definitely take the course. And then how to recognize? You have to put genetic counselors under 7th pay commission. Then it will be really great thing. And now in India, nothing is impossible. Because in Hindi, there is man hai to mumkin hai, Modi hai to mumkin hai. We keep hearing this, and this should happen. So next meeting, it should definitely happen. It should happen. Yes. And there are certain questions to our panelists. This question is from Pravalika Sandhu. Is there any stream in genetic counseling that has relation to stem cell therapy?
Genetic counselors are attached to all stem cell and regenerative therapies and also for assisted reproductive technologies, because they are the ones who know what is works and what needs to be conveyed. What are limitations like thalassemia and stem cell? That's what she told this morning, that you do prenatal tests and you do PGT. Also match up the HLA and then plan next week. So that's coming. So genetic counselors need to be aware of this to be able to relate to patients so that they take informed decisions. And also to policymakers so that they can know.
Can Ms. Laurie kindly elaborate on NMS system of genetic counseling applicants in North America? Do we have Ms. Laurie here? We will get this answered. We will directly get in touch with her and answer this question.
Yes, I am here. Can you hear
Oh,
me?
sorry. Yes.
Can you hear me clearly?
Question was, kindly elaborate on NMS system of GC applicants in North America. Further,
Yes.
Is it also required for master's program in medical genetics? How can we strengthen our application and curriculum to increase chances of acceptance?
Thank you for the question. I'll address the question about the national match system first. The national match system, the only requirement, so all applicants to North American programs must enter themselves into the NMS system. And they do that when they are submitting their application. So they have to have a number, an identifier in the NMS system in order to put on their application. So the applicant does this before they know if they even have an interview or not. So yes, it is a requirement, if you will, for an applicant to a North American program, because we all use the match system. I hope that answers that question. The second question, can you refresh that second question for me, please?
Second
Can you repeat the second question?
Is it also, all this process is required for master's program in genetic counseling? That was the question.
Yes, I mean, that's for the national match system. So,
yeah. Okay. Then the third question was, how can we strengthen our application and curriculum to increase chances of acceptance?
Yes. So to strengthen an application, first of all, I would recommend participating in any programs that offer virtual question and answer sessions. For example, the Arkansas program has, I believe, a monthly what we call an open house, where potential applicants can ask questions and learn about the program. And many programs offer something like that. So you want to begin to make yourself known. I think that you do not want your first introduction to a program to be your application. So it's helpful for the program directors to have a connection to your face and your voice before they see your application just on paper. And then the other aspect for strengthening your application is for North American programs anyway, you want to clearly demonstrate that you understand the profession of genetic counseling and that you have tried to learn as much as possible that you can about the U.S. healthcare system. And, I know that this is not possible for everyone, but if you have spent any amount of time in the United States, that also is reassuring to a program director in the United States that this applicant has some exposure to culture and language here. And so those are some things that I think are key for an application to a North American program, or to a program in the US, I should say.
Thank you. So we are aware of the training and certificate courses we have in India as such. So we have the postgraduate certificate course. So these are the things that are up there. So we know bachelor's, then got a master's. So already done master's rights. Then one. So this way we are saying course should get done. And we've got more universities. CC has really become open. Dual for it's the right time. We need to go in and we need more universities. Take up the course, and BGCI we have the syllabus and forms, and was assembly accredited conduct the course. So then we have the certification. The regard this.
Thanks once for congratulations for the wonderful. This exercise should not again. I was talking to him after 3 days, everybody for it. But take as a mission this particular recognition of history. There are international friends are there also. Take their inputs, how they are, but Indianizing. What they are what happened in country. Now that we make India how to follow the qualified or quality pieces. What mistake is it? But because sorry, all the parents what that is only medical is taught. 212 including medical as well as there. Okay. So what I'm each one of you have I stand. So systematically, and with the 6 months, you can write. But make all of them from this. Oh, sorry. Make a core group out of this drafting committee. Make a drafting committee. Inputs take from everyone and right. Good. Then you possible we can make it a certain 6 months somewhere. So all the best, but exercise. Thank you.
Sir, may I request something else? Yes. There is one more aspect, sir. In the medical education curriculum in India, genetics is not taught as it is taught in the Western world. So we have when you map it, you see only 6 hours which is dedicated to genetic counseling or genetics. I think that is too little. So if our clinicians understand the molecular basis of disease, they will be wonderful genetic counselors. Then we, I think this should be taken care of in the medical curriculum in India, traditional curriculum in India. When we map, very little genetics is seen, that to 4th or 5th year. It should not happen.
Questions in the genetics questions in their curriculum, they are not able to change. I want to National Medical Council also, I went over there to change genetics with expert committee of 93, followed by 2005, but they are not changed. So forget it, waste of time. Make your GC sir do what it. So I have done all that, including putting a genetics groups, try to fund the faculty members, 100 crores I kept for them to be institutions. They work out on. Here our quality GCs are required. So focus on that first. I don't think they change.
Let me ask you a question. How many years should a medical student go through to get a degree? How many years should a medical student go through to get a degree?
6 years.
They don't go through 6 years. They go through 4.5 years
Four
and
and
1
a
year
half.
of internship. This question happened 4 years ago when they wanted to change the curriculum. You remember, 2018, you have on many things. Forget it. I was a part of that. I said, if you ask me, a medical student should go through 8 years or at least 7 years. Then you can put all these things in perspective. In 4.5 years to teach them from anatomy to medicine, it's impossible. That's why it is self-defeating.
No, sir. In our university, I work for Gulf Medical University, which is in UAE. We had up to 2009. We had this traditional curriculum. 2009 onwards, we shifted to integrated system, which is US UK based, which was 5 years till last academic year. Now this freshman intake 2022, we have made it 6-year MD program, again to align with TANNETS and American board. So we have nicely integrated. Since it is organ system, we see to it when they study different organ system, even genetic component they study. So when we map it beautifully over foundation year, core medical year, clinical year, you see genetics everywhere.
That's really good. But UGC is giving a lot of flexibility now. You can have core subjects and you can have optional subjects. And those who are interested can take genetics as an optional subject. That can be done.
Thank you, sir.
So there are quite a few questions more you would want to finish, but I think we have to start the inauguration. One more.
One question is quite interesting by Tariq Anwar. He asks, is there any plans to make genetic course virtual and available in different languages?
Again, the Australia person, you saw everything being online, but at least for genetic counseling, we know.
Regulation, if they don't teach, even genetic counselor also has to teach these courses at least few hours. 1 credit or 2 credit courses has to be taught, otherwise they can't understand that. Present day. Similarly, genomics also, genomic variations, even genomics term itself is sufficient for them to understand. Genomic variation has to teach at the medical school and the genetic counselor. Otherwise, the bridging will not going to happen. And the concept of bringing the genetic counselor is very, very good. I think we'll work together. UGC is open. It will recognize the courses. Even I think Dr. Shekhar, I request him, his own university can start this course. He is a leader there, he can start this course. Yeah, we have to involve him and he should start there. We will support him also. This way, we have to take this further. Okay, thank you.
No, I spoke to Dr. Lakshmi about it because her name is Lakshmi. So we expect a lot of money, we'll start it.
One more question, why there is no mention of genetic counseling on the national platforms like ICM? Like ICM, Indian Medical Council Research.
That's what we are working on.
If there is no mention of genetic counseling on national platforms like ICMR.
No, that is exactly we are trying to work. See, they don't want to even, I have an ICMR project, but then it's just counselor. They don't want to make it genetic counselor, or it is not made till now.
Counselors, because our Siddhant Mahendras and also what we are doing. The counseling as an education, genomics, and training and diagnostics and treatment.
As I told, for the national policy for rare disorders, there's a huge need for a country like ours. So that can be one of the key points when we put it in the white paper. And again, in terms of like whatever to consolidate, any other question? Okay, so the numbers are needed, there's no question. So the education, training, the certification, recognition, and the regulation. So regulation is a little tougher part, which we will handle a little later. But the thing is, this education, training, certification, and the recognition of the GC, of the genetic counseling course per se by the UGC and genetic counselors per se by the government of India, we should make it in the next 6 months to 9 months. So we close it here. If there are any other views or anything somebody wants to say, please. So I thank Dr. Takeshi again, where he brought in the thing of registry, which is again very important, and he brought it for the eye. I think if the government of India can adopt one group which is working for long in this, registries which are very important, again, genetic counselors have a huge role. We are the ones who are in interaction and who can document everything wonderfully. And of course, as a clinical curator and a molecular curator, I think that can be one of the key points in the white paper. Yes, Dr.
Just
Usha.
last point, Lakshmi, just to sum up, since this was a good platform and there are good policymakers and people over here, why not make a first core team or something, to take this proposal ahead? So there are good experts over here. You can form a core team under the leadership of these people or something and go ahead later on, just for your help. In case you need any help, you can take the help and go ahead.
Sure, it can. Thank you. Is there any other question from the genetic? Yes, yes.
Hello, ma'am. I'm Dr. Chaitra from Genetics and Genomics, University of Mysore. So, as you said, you have a design framework. So, what we can do is we, as a from the Department of Genetics and Genomics, we can propose initially to start with a certificate course, and then we can scale up to the master's level. So, if you have that supportive team for us, so definitely we will propose this to the university.
So that is what then we have the 1-year course, PG diploma,
Yes.
and the syllabus is and all is set. Only thing is you have to attach the various medical faculties, which we should ensure. Some universities, if they have a medical college also attached, it is easier. Otherwise, we need to rope in and have an MOU with the medical university or college to have those rotations. Otherwise, I think it is really doable, both the 1-year course and the 2-year course after bachelor's.
Okay, thank you.
Ma'am, we also have to benchmark our programs. Benchmark it to international standards, so that, not that we all have to go abroad. Why always we think that we have to go out? We also have to think, why don't people come into India to work?
Yes, again, this quality in all this effort, quality is something which we need to maintain. And of course, genetic counseling, we know languages, Annie said, it's very important. You cannot counsel if you don't know the language. Again, it's very challenging in India, Even the best genetic counselor, if they say I have to go and talk Marathi, no, we can't. And if you don't know, you can't counsel at all. You might be super genius in genetics, but if you don't know the language, you can't counsel. So language, try and learn more languages, then you can sort of really go. And culturally, we are very different. The questions you ask during genetic counseling, it's very different. You take up a US or a European thing, the way they ask questions is very different from how we can ask our mothers or girls in our society, or to say that family. So keeping in all this, and as Dr. Preeta rightly said, with all this, the quality, people from abroad should want to come to India and know, because the diversity of population, diseases, language, culture, no other country except India can give. So let's all, with lots of prayers and lots of our effort, start off. And I'm really hoping it is going to happen, sir. You will again be there next year when we will say it is all happening. Yes, thank you so much. Thank you. And again, is there any?
So we thank all the speakers, chairpersons, and moderator, Dr. Lakshmi B.R. We thank each every one of us for the wonderful interactive session. And this will be followed shortly by the inaugural program. So we request all of you to be seated and for the inaugural function.
Thank you so much, all of you, especially the speakers who are on the panel online, staying throughout the session. A good round of applause to all of them. Thank you so much. And also to our wonderful hosts who were with us. And thank you, panelists and guests on stage. Thank you so much. Let us all see you at the inauguration shortly. Thank you so much.
Hello. Check. Hello. Microphone testing. Hello.
request everybody to be seated for the inaugural function. I request all the delegates to be please seated for the inaugural function. I request honorable dignitaries to kindly occupy the dais. Pranams to the lotus feet of His Holiness Jagat Guru Dr. Sri Shivaratrishwara Rajendra Mahaswamiji, seeking the blessings of His Holiness Jagat Guru Sri Shivaratri Deshikendra Mahaswamiji. Good evening, everyone. This conference has been organized to promote education among genetic counselors, doctors, healthcare providers, and students about the current topics in genetics, genomics, and genetic counseling. Now, I would like to invite Dr. G.K. Madhavi Lata to invoke the blessings of the Almighty.
I'll be invoking the blessings of Mother Saraswati, who is the goddess of knowledge, wisdom, speech, art, and music. जय जय हे भगवती सुर भारती तव चरणौ प्रणामामः जय जय हे भगवती सुर भारती तव चरणौ प्रणामामः नाद ब्रह्ममयि जय वागेश्वरी नाद ब्रह्ममयि जय वागेश्वरी शरणं ते गच्छामः जय जय हे भगवती सुरभारती
तव चरणौ प्रणमामः त्वमसि शरण्या त्रिभुवनधन्या सुरमुनिवन्दितचरणा नवरसमधुरा कविता मुखरा स्मितरुचिरुचिरा भरणा जय जय हे भगवती सुरभारती तव चरणौ प्रणमामः प्रणमामः प्रणमामः
Thank you, madam. I would like to invite Dr. Deepa Bhatt, Organizing Secretary, BGCI 2022, to deliver the welcome address. Pranams to lotus feet of His Holiness Jagadguru Sri Shivaratri Dr. Rajendra Mahaswamiji, seeking the blessings of His Holiness Jagadguru Sri Shivaratri Deshikendra Mahaswamiji. Board of Genetic Counseling India is an organization looking after education, training, practicing genetic counseling as a profession in India. JSS Academy of Higher Education and Research, along with its constituent colleges, has always been in the forefront towards upgrading ourselves in several fields on par with international standards, including genomic research and education. The Board of Genetic Counseling India is organizing the 7th annual international conference from 1st to 3rd July 2022, hosted at our own JSS Medical College, Mysore. The main aim of this conference is to promote education among counselors, doctors, healthcare providers, students about recent trends in genetics, genomics, and counseling. The conference is expected has several international and national renowned speakers who are experts in genomic medicine and counseling. We have 375 physical registrants and around 2,000 virtual delegates who are witnessing this conference. So this conference has provided us an opportunity to amalgamate and translate our vision towards getting this genomic education on par with global standards. So it gives me an immense pleasure to welcome you all on this August occasion on behalf of this organizing committee. First of all, I would like to welcome our chief guest for today, Dr. M.A. Shekhar, who is Honorable Vice Chancellor, Adichunchanagiri University, Mandya. Welcome you, sir. I take this opportunity to welcome our another chief guest, Dr. T.S. Rao, who is former senior advisor for DBT, who has been with us and has given a lot of inputs and also helped us to take this, our vision towards success. We welcome you, sir. I welcome Dr. Annie Hassan, who is president of Board of Genetic Counseling India, who has brought this profession into practice in our country. We welcome our Honorable Vice Chancellor, JSS Academy of Higher Education and Research, Dr. Surinder Singh, who is instrumental in taking this academy to greater heights. Welcome you, sir. I welcome our Director Academics, Dr. P.A. Kushalappa, who has been backbone for our all activities. I extend my very warm welcome to our dynamic and beloved principal, Dr. H. Basavanagodappa, who is the guiding force for all our activities. Welcome you, sir. I also welcome esteemed senior members of BGCI who have been in the audience and have been very supportive towards this conference. And I also welcome our Director Research, Dr. Prashant Vishwanath, to this event. I welcome our Organizing Secretary, Pooja Raisam, who has borne all the efforts and who has been very, very helpful for me to make this event possible today. I welcome Dr. Akila Prashant, who is also organizing secretary, who is pivotal in establishment of this Department of Medical Genetics in our institution. We are glad to welcome Dr. M.N. Suma, Vice Principal, Pre-Paraclinical, Dr. Manjunatha. Welcome you, ma'am and sir. And in absentia, our Honorable Pro-Chancellor, Registrar have extended their best wishes. We welcome you also, sir. I extend a warm welcome to all the delegates who have made a huge effort to join us today. Welcome you all. Thank you. Thank you, madam. On behalf of everyone, I would like to welcome Dr. Deepa Bhatt. I request our Honorable Chief Guest, Dr. M.A. Shekhar, and the other dignitaries to symbolically inaugurate the program by lighting the lamp. College under the aegis of JSS Academy of Higher Education and Research. So, on behalf of BGCI, I request Dr. Annie Hassan, President BGCI, to give us an overview of Board of Genetic Counselors of India.
Hello. Good evening to all those present on the dais, off the dais, and online. Because we shouldn't forget the 2,000 registrants who are there virtually for our meeting. It is my proud privilege as the President of the Board of Genetic Counseling India to welcome all of you to the 7th Annual Board of Genetic Counseling meeting on behalf of all the members of BGCI. And I would like to take this opportunity to thank JSS management for joining hands with us to make this 7th conference in hybrid mode so that we could meet after the pandemic, enjoy the academic feast planned by the organizing secretaries, and also have virtual participation. It is rightly said that our differences define us, but our common humanity redeems us. This is very true for genetic counseling. We belong to different regions, different countries, different cultures, different languages. But the pain of having a loved one with a genetic disorder and the pain of transmitting it and the fear of transmitting it to our near and dear ones is universal. And genetic counselors are the ones who hold your hand through this journey till you make informed decisions about management, prevention, and treatment of these genetic disorders. I would like to describe myself as an educator and a perpetual learner. What I want to learn and what I want to impart is that all the advancements in genetics and genomics should reach patients, families, caregivers, and the society at large. And this, I believe, is possible only through genetic counselors. Since we founded the BGCI in 2014 and registered it in 2015, I've had the opportunity of working with wonderful young people who are enthusiastic and motivated. And that is why I feel it's the passion and motivation which has taken the BGCI from zero to this level, where we have 212, not a very big number, but passionate people together. These young people are the ones which inspire me and motivate me. And although the task is daunting, that globally it is accepted that we should have 5 to 12 genetic counselors for every million population, and we are only 200. But I'm sure with all the young ones taking one step forward, holding hands together, helping people, we will reach our goal. So please see to it that BGCI is something which you believe in, and the policymakers, the academicians who are here will help us realize our vision and mission. Thank you so much.
Thank you, madam. I request our dignitaries to felicitate Dr. Annie Hassan. Thank you. I request our chief guest, Dr. M.A. Shekhar, Vice Chancellor, Adi Chunchanagiri University, to address the gathering.
Good evening, everyone. I'm sorry. Words fail me now. Jai Shri Gurudev. Let's begin with seeking the blessings of Paramapuja Mahajagadgurus of our Suttur Mutt, without whose vision we would not be sitting in such a beautiful hall today. So let's seek their blessings for a very fruitful outcome for BCGI and Genetic Counselors of India in future. Let me share a secret with you today, a small secret, of course. When Dr. Basavangowda called me and said, Shekhar, are you free on July 1st? I said, what for? I knew he would trap me for some funny things like this. Today it's not a funny one, I'm very sorry. And he said, your student wants to talk to you. And I was pleasantly surprised to listen to a very sweet voice, Dr. Deepa. I proudly say she was my student. And I am a little bit jealous to say my friend Basavangowda is my colleague. We are of the same age. Look at him. I look 15, 20 years older to him. So it could be a genetic study for you people. I'll share one more thing. You're looking at Dr. Deepa. She looks full now, right? Sorry. When she was my student, she was 1/4 this size and she had a hair as long as she was. She's probably 5 feet 2 inches. Her hair was 5 feet 1.5 inches. I kept telling her, whatever you eat, it goes to your hair. That's why you are so thin, and look at her. She has a very short hair and she is plump. So whatever she is eating is going to her. I was just joking. Just to lighten the thing, because I was just telling Dr. Lakshmi, I will be opening up my ignorance if you ask me to talk about genetics and genomics and genetic counseling and all that. But anyway, the love and affection of my friend Sangav and my dear friend, the Honorable Vice Chancellor of JSS, has brought me here. I'm so happy to be amidst you all. Let me not talk about genetics and genetic counseling and all that. I will leave it to great people of BGCI to do that. I'll share one or two incidences. I hope you remember a great personality is still around us called Gaur Gopal Das. I just remembered him today, Gaur Gopal Das. I hope youngsters should Google him, and he has very, very hilarious way of putting things across, the philosophical things. And one thing I would like to share with you today is called as the CAR concept, CAR concept. He starts his video, it's just 3-4 minutes video. He says, when I'm driving in a Maruti 800, I see a Benz whizzing through. He says, how I wish I had Benz. If you are in the Benz and you see some other car, oh, how I wish we had. So there is no end to our feelings. So he has come out with a concept called as CAR concept. CAR. C stands for change the changeable. A for accept the unchangeable, though they are important. And R for rise above unthinkable. So today the CAR concept is change the changeable. What is the change that we should bring in? Change the mindset of stupid clinicians to accept genetic counselors. Accept the unchangeable. Please accept clinicians for their ignorance. And R, rise above the unacceptable. It is time you rise above, bring a white paper. By next year, you have at least 500, genetic counselors on board. Can I expect that? Thank you. How can I go further? What is the importance of genetic counselors? They were all talking in the mindset of somehow bringing clinicians together with these people. And I thought I should open my mouth. I thought it would be more ignorant, but now I can take the chance because they've asked me to give you the inaugural address. So I can have the latitude. All you have to do is, you genetic counselors, please go to marriage counseling. You have a huge, I can say, playing field. Then the clinicians will become jealous and they will invite you automatically. I will charge 10,000 rupees for this advice. Just 10,000 would do for the time being. Maybe next Benz car. Why do you think we need genetic counselor? We were just having a very, very in-depth concepts just before the inaugural time. I think it is very, very important, not because genetic diseases are difficult to treat or whatever it is, but if you remember in 2003, what happened? Human Genome Project. Post-Human Genome Project, the genomics, all those omics, bioinformatics, biological studies, all of them have taken off in such a fast manner. You have very, very clear results in the form of treatment for these genetic diseases. Unfortunately, the mindset of a clinician is genetic disease means untreatable, unmanageable, impossible to prevent. It's not so today. With this mindset, because genetic counseling can lead to a lot of good, not only for the families, not only for the clinical people, also for the people of our community. It's very important that we take the first step today. They have already taken. They are unhappy because not many are coming. And let me tell you why not many students would like to come into the GC certification or master's degree. It's only because employability. The day employability increases, let me tell you, they will come and ask voluntarily, please take us in. Then you can increase the fee structure. Okay. So with this, I just shared why clinicians are a little bit do not have the mindset. I remember the psychology. I again repeat it. Some of you have already heard about it. There is a phrase in psychology called as intelligent ignorance. We are so intelligent after literature, rather after education. We try to ignore which we do not know. So clinicians are intelligently ignorant. They like to put aside this genetic counseling, but you say counseling, they will jump on it because they don't have time to talk to their patients. If there is a counselor, they do a great job. So what you do to accept clinicians, tell them, let's start counseling. What counseling? Genetic counseling. Maybe you will be accepted faster. But Sadhguru, I hope you all remember Dr. Lakshmi's place. I was telling her that he was my 2-year senior in Mysore. He says, the day intelligent ignorance becomes intelligence of ignorance, the intelligence that we accept that we do not know, we have done a lot of great work. So having said that, I'll stop here. Best of luck for all of you people. Any help from our side, we are always open to remarks, not brickbats. Thank you.
Thank you, sir. I request the dignitaries to felicitate our chief guest. Thank you. Now let us see the journey of BGCI.
Hello, I'm Dr. Annie Hassan, and I thought I'll take you through the journey of the genetic counseling profession in India. The seed of this was laid when in 2006 I bumped into Suchita Bhatt and Maya Thangavelu at the American Society of Human Genetics conference. All three of us came together. Every opportunity I got in that meeting, Maya and Suchi introduced me to people, including Diane Baker, who was from the first batch of genetic counselors at Sarah Lawrence. We all sat together, discussed, thought about it, and they said they would support me from the US and I would have to take steps in India to start the certification program, but before that, to have courses to train genetic counselors.
I first met Annie to talk about genetic counseling at the Mumbai Conference of Cancer Genetics, which I'd been involved in helping to organize with Professor Kumar and Rajiv Tharin in Mumbai at ACTREC. The conference was very full and interesting, and at the time I met Annie Hassan, who started to tell me about her ideas about genetic counseling in India and how important it was and how she would like to promote this. She had a huge amount of enthusiasm, and I immediately caught this enthusiasm and was telling her about my experiences of genetic counseling and teaching genetic counseling in the UK. And I was very pleased that she accepted a gift of my book about cancer genetics, which included some information about genetic counseling as well. So she was telling me a bit about the proposed teaching, and I was very pleased afterwards to be invited to join the advisory board for the National Board of Genetic Counseling in India. And I felt this was a great honor And I was able to help develop some parts of the curriculum and with the website, and later on to help with developing some of the exam questions and so on. Later on then, the next year, 2018, she invited me and my husband to come to the conference in Hyderabad. So we went and joined the conference, which was really very exciting and very, very good. Full of lots of new ideas and counselling, obvious counselling skills now being shown off by the genetic counsellors from her department. It's wonderful that what Annie has achieved. She has a great passion for genetic counselling. I think she's managed to do an enormous amount from those early years in developing a genetic counselling course, and in now having genetic counsellors who are working throughout India. So it's so important to have genetic counsellors who can understand these issues and can discuss them and explain them to people, to the patients, and also to other doctors who haven't had a background in genetics. I've been really honoured to be part of this in any way and to be able to have contributed to this.
Genetic disorders can present itself in any population. Genetic counseling is an important component in the diagnosis and management of these disorders. For effective counseling, language and knowledge about the culture of the population are essential. This was one reason why I encouraged Dr. Hassan to start a formal training program for genetic counselors in India in 2006. With the many languages spoken in India, it is essential that every state develops a training program for genetic counselors so that counselors are equipped to counsel in the local language. Developing training programs in other regions and states will also help in increasing the number of counselors required for the size of the Indian population. Developing regional training programs will also provide exciting new opportunities for the next generation of genetic counselors in going beyond the science involved in genetic counseling and developing skills required to counsel in local languages and enhancing sensitivity to cultural issues.
We decided that we will take only 5 students and we'll encourage that these 5 are from different states of India so that people can be counseled in their vernacular language.
I started my career in human genetics in 1973 after a master's in botany. At BJ Medical College, Pune, Dr. Mutalik had returned from Victor McCusick's lab, and together with Dr. Patke and Kati, they had started a genetic clinic where I learned karyotyping. In 1974, they gave me an opportunity to start a similar genetic clinic at JJ Hospital, Bombay. And there I got the help from Dr. Sumati Nair, who had returned from Great Ormond Street, and she gave genetic counseling and taught us how to maintain a good rapport with clinicians and patients. And later, after my PhD in 1979, I started an academic lab at SSG Hospital in Baroda, and that's how the field spread. Later, at conferences, I met Dr. Annie and admired her enthusiasm to start genetic counseling officially in India.
After my training in US for over 3 years, I was very much convinced that genetics is required for us in order to prevent various birth defects and genetic disorders. I approached government agencies, I approached various hospitals. I was working in JJ Hospital then, that we should start this in a hospital. But the most important thing was counseling the patients to make them understand, telling doctors the importance of counseling, which could be pre-test as well as post-test. I thought now this is the time that I should spread awareness all over the country, going into various conferences and giving talk. Counseling requires pre-test and post-test. Again, doing it alone myself was not sufficient. So I thought, let me just take some training classes, courses, and help people to spread this message. Started genetic counseling clinic and went on adding on to newer tests as they were available. Nothing was easy, but however, my colleagues like Dr. Prochi, Dr. Annie, they just took it up and they said, "Ki, yes, we are all there with you. Let's go ahead with these kind of services, counseling services. Even for the counselors, they have to have the patient access. They should have the laboratory training, which I went on offering. And I think now after completion of 20 years and Human Genome Project, it's a real joy for me that not only that it is well understood, but the training which has been given to the students, they are also helping various organizations. At the end, I would like to say, with the development in science and available technology, hopes of the patient is raised and the responsibility of the physicians and the counselor is increased.
India is a very large country with 1.35 billion population. We have very few medical geneticists in our country. So to cater to this large population with rare diseases, rare genetic disorders, we need lot of trained manpower. That is where I thought genetic counselors are necessary, and taking help from Dr. Shubha Phadke and her guidance, and going through the program in the international universities, we started the first program in genetic counseling in Manipal. I have an important message to the counselors. We need to work as a team where we can contribute better to the healthcare. All counselors need to work with a clinical geneticist or a medical geneticist, or at least a very well trained pediatrician, fetal medicine specialist, or neurologist or hematologist, so that counseling can be done better in the medical or hospital environment.
Genetic testing has to be understood well to be appropriately used for patient management while one trains to be a counselor. Specialized training helps in communicating effectively with patients and their families. With the idea of bringing genetic counselors under one umbrella, senior professionals began putting efforts towards the formation of a board of genetic counseling.
First course of genetic counseling started in 2007, Kaminini, where we discussed whether it should be a 1 year or a 2-year course, and we settled for 1 year because we were doing something for the first time. We wanted to know whether these young people who had got the genetic counseling training would get a job. The management of Kaminini supported me, and most importantly, Pragnya Rao joined me, and she was the one who gave the shape to the first program. She made it into blog. She talked about eligibility, selection process, examination process, and so on. All these people started getting jobs. Jobs in industry, jobs in hospitals, but none in the government sector. So we realized that the numbers are too few and the work is immense. To do that, what we decided is that we should have a board of genetic counseling which takes lateral entry of various people who are interested in genetic counseling and taking this profession forward.
Thank you. I would now like to invite Dr. T.S. Rao, former Senior Advisor, Department of Biotechnology, Government of India, to address the gathering.
Thank you. Good evening, everyone, and my lotus feet of Swamiji blessings. With that, I will just start with that. Dignitaries on the dais and off the dais. And it's wonderful to be here today. And thanks to the management of Kanne and Lakshmi being part of this. And it's my dream coming true 30 years back when I started the program of human genetics and genome analysis program with lot of problems which we face, along with my vaccine development program simultaneously. But this has reached a stage where really we need to take up the uh, requirement of our demand of genetic counselors in the country. With a lot of things we started with Umeed and also Nidan Pendra programs, but somebody has to attend this particular issue also. It's very important to provide quality counseling to our suffered affected families for the large number of genetic diseases prevalent in the country, especially thalassemia, muscular dystrophy, and cystic fibrosis and all other things, hemophilias. So I think we never address it. Probably we missed it. We are not got to that information to ICMR or DBT or Health Ministry. The proper paper to us with the pushing, this is required. Probably that's what missing. I'm since morning I'm seeing that one. No, I never seen such a quality request from the your organizations, including the Human Genetic Society also present over there. But they never mentioned this type of things. Our counseling is happening, the training is being in-house, and they are working on that. But today I could see the internationally, nationally, how importance and also this program. Only recently, Manipal, we started with a 2 years program with Shekhar, but we need many more. So 212 something you mentioned to that, it is not enough because 1.4 billion people and a lot of genetic disorders prevalent in the country and problems what we face. Because infectious disease, because vaccines, we reduce it. But genetic problems, still we are not yet attended properly. And role of genetic counselors are excellent because their role is very crucial. What I could see that today morning, one session I attended that, see, you clinicians and basic scientists are talking, but you're forgetting your customer. The patient is there, but you are not bothered about patient. How to tackle that patient, how the family to be taken care of that, it is not addressed well. That's what I told Chendak later on. What is this all these years? What are you doing? So see, some of these issues has to be consolidated and put properly to the concerned government agencies so that we can recognize the UGC approved curriculum and also accreditation from the Medical Council of India and the DHRs, ICMR, DBT, everybody. See, this is our problem. It is not an international problem. This is a problem of ours where large number of genetic consanguinity is more in our country, especially in the south side, lot of consanguinity. So we need to tackle in that fashion, See, we worked on diagnosis, counseling is a part of that was there, but focus was more of diagnosis and treatment of genetic disorder and also providing the all these funds to the infrastructure development and also strengthening the existing units. So I raised a fund from 6 lakhs to 600 crore for genetic clinic. Into ICGC, I am now paying 240 crore to the International Cancer Genome Consortium project with Kalyani as well as ACTRAC Mumbai. So some of the funds to the event to them, those are counselors to be paid properly because here also what happened, each this certificate course, people will be paid 20,000, 40,000. No, it will come like that. No? We have to honor and also empower those counselors in a proper salary and also this good designation to give a part of your academic excellency in their designation. So we need to work out all those issues and I'm sure I will try to understand the problem and we will try to work out. Let us see how we can move to progress well. But thank you very much for inviting me for this. It's a great honor and I'm really enjoyed overwhelmed with coming over and learning more of things. Thank you very much, sir. Thank you.
Thank you, sir. I request our dignitaries to felicitate Dr. T.S. Rath. Thank you. I would like to invite Dr. H. Basavanagaudappa, Organizing Chairperson, Principal, JSS Medical College, to address the gathering.
Good evening to one and all. And the outset, I seek the blessings of Jagat Guru Sri Shivaratri Rajendra Mahaswamiji, founder president of Mahabodhi Pita, the present pontiff Sri Jagat Guru Shivaratri Deshikendra Mahaswamiji, our chancellor, with whose blessings all these great things are happening. This platform, raised platform, was created for people like us, not for people like Shekhar. He has grown tall both in height as well as in wisdom and knowledge. That's why we have called him as chief guest. And we can do genetic study on this also. I will not address, I'll make only 2 minutes. Respected Vice Chancellor, Surendra Singh Ji, Shekhar, good friend and Vice Chancellor of Aditya University, Dr. Rao, nice to see you here repeatedly. And, all the dignitaries on the days after days. And when Deepa Bhatt came and approached me that we want to do this program here, we've been offered, I'm a little hesitant. Will she be able to organize or conduct this program efficiently? Because it will be an international event and there will be so many people involved in this. And if we fail somewhere, I was a little hesitant. And then I knew her capabilities. Though she is basically an anatomist, the moment she came and approached us, along with Akila started looking into form the Department of Genetics, and she started straight away with the practical installation of the practice of genetic counseling in JSS Hospital. And when I was discussing with Prashant, who was a younger student, when 46 years back when we joined, like myself and Shekhar, genetics was hardly there in some corner in one sentence. When we became PGs in 1982, kind of a small paragraphs and small chapters appeared in the curriculum. Now you have a big chapter, both in UG and PG curriculum. That only means that we have understood the genes better. And then whenever the bouncer question was there, it used to be from genetics. So that was our fate. Okay. I only wish the BGCI all the very best in evolving to great numbers, great qualified trainers who will take care of the requirement of the country and go ahead and do the better work. And I fully appreciate the Deepa Bhatt who is balancing the work of genetic counseling as well as a best teacher in the Department of Anatomy. Similarly, Dr. Akila has been doing wonderful work in a lot of research in genetics, and he's running the course of MSc genetics, and that will possibly go on. And then a lot of our scholars are using that. Recently, she conducted 1 week long hands-on workshop on cytogenetics, and all the participants were so happy that they were given a hands-on experience of genetic workshop. So these kind of committed workers are there in our university, and all these activities are adequately supported by the academy through our wonderfully supporting Vice Chancellor, Registrar, and our Swamiji ultimately, our Pro-Chancellor who is there with the whip to be on us to go on doing research and publish and make the institute and the university known to the world. And we have figured in Times Higher Education, we are among the top 400 universities in the world, and we are ranked as 34th university in the country. And that's all because of the great support given by the academy. And we thank the BGCI for selecting this venue to host the conference of 7th International Conference of BGCI. I thank all those who are physically here, and please carry home the great learning experience, only positive things. If there are any shortcomings, please excuse us. I thank all those who have logged in online and wish all of you the next 2 days a great learning experience. Thank you all.
Thank you, sir. Now may I invite Dr. Akhila Prashant, Organizing Secretary, to propose the vote of thanks.
Good evening, all. I offer my humble pranams to His Holiness for blessing us for the conduct of the successful for this conference. It's a great honor to render the vote of thanks on behalf of the organizing team of BGCI. Immense gratitude to our invited chief guest, Dr. M.A. Shekhar, the Vice Chancellor of Adichunchanagiri University, Mandya, for inaugurating the conference and sharing his car with us, the knowledge of car. I offer my sincere thanks to Dr. T.S. Rao for being with us in spite of his busy schedule and sharing and helping us, helping the BGCI with the policy making. Uh, I I offer my sincere gratitude to Dr. B. Suresh, Pro Chancellor of JSSAHER in his absentia. He's always encouraging us for all the events happening in this institute. We are grateful to Dr. Surendra Singh, Vice Chancellor of JSSAHER, for support and his encouragement in all our activities. I also thank Dr. Kushalappa sir, Director Academics, for being a backbone for all our events. I thank Dr. H. Basavanagadappa, Principal, for providing all the support for the smooth conduct of all the programs in the university. I thank Dr. Prashant Vishwanath, the Director Research of JSSAHER, for being with us during for the inauguration. An event like this cannot happen overnight. It requires meticulous planning, and I thank the entire BGCI team headed by Dr. Annie Hassan for her support and planning of this event. I extend my thanks to Dr. Suma, Vice Principal, Dr. Satish Chandra, all for the support in organizing this event. I'll be failing in my duties if I do not thank all the colleagues and this teaching and non-teaching staff for contributing enthusiastically to make this conference successful. Also, I extend my appreciation and recognition to all the industry sponsors for their support and contribution towards organizing this academic feast, and also thank all the patients and their families who had come to share their experience today morning in the pre-conference workshop. And the sincere thanks to the media people who are there for giving us the IT support. And thank the organizing secretaries, Dr. Deepa Bhatt and Dr. Pooja, for their support and their planning of the workshop. And finally, special cheers to all the delegates and participants who have come from far off places for their cooperation and giving a true sense of the having this academic piece. I thank each one of you for contributing either directly or indirectly to organize this event. And I hope you have a happy stay in Mysore and go back with a lot of genetic wisdom. Thank you.
Thank you, madam. Thank you all for being with us. I would like to thank Akhila, Dr. Akhila Prashant. Now let's listen to our renowned international expert, Ms. Diane Baker, who will join us live to deliver the keynote address through the talk, Conversation with Diane Baker, Genetic Counseling Then, Now, and the Future. I also invite Ms. Pooja Rayasam to kindly take over. Hi, Diane. Hi,
Hello, can you hear me?
Can you hear me?
I can hear you very well.
Welcome to
How am
India
I coming?
virtually. Welcome
Am
to
I
India
coming?
virtually.
Uh,
Can you hear me clearly, or is there a disturbance?
There, that's better. I can hear you very clearly.
Okay. So we're very, very happy to have you here. And we're just going to wait for Lori for a minute. Yeah.
Fine.
Hi, Lori, can you hear me?
I can, Pooja. Can you hear
Oh.
me?
Hello. So, Lori, welcome to you too to India virtually. We're very happy to have both of you here. Diane, it's an absolute pleasure because we're all young genetic counselors here who are eager to hear from you as to how things started because we really want to take the profession forward. So before we begin, Lori, would you like to introduce Diane? You've known her longer. Lori?
I'm sorry, Pooja. Can you repeat that?
Hello, Lori, can you hear me?
I can, but I couldn't hear your question.
Oh, I just wondering if since you have known Diane longer, would you like to introduce her first?
Oh my goodness. Well, so Pooja, we should have two introductions, the formal one and the informal one. So I will be happy to provide the informal introduction. It is my pleasure to be joining, interviewing and joining Pooja with Diane Baker. Diane was my mentor and teacher when I was at the University of Michigan. Diane and I have many, many memories of a very stressed out young woman who basically had a really bad case of the imposter syndrome. And, but yet Diane encouraged me all the way through my program. There were ups and downs and successes and failures, and she was steadfast in her encouragement and her belief in me that I could do this and that I could contribute to the profession. And Diane has a very special place in my heart, always has, always will. And it's just an honor to be able to join her today. Thank you, Pooja. Thank you, Diane, for agreeing to talk with this group. I know that they will get a lot out of what you have to share.
Thank you, Lori.
Thank you, Lori. So the official introduction to Diane Baker. So the first time I was so excited about this conference was when Annie ma'am called me late in the night saying we have to get Diane Baker as our keynote address speaker. And I was like, okay, how are we going to accomplish that? We searched for your email, we searched for a lot of contacts, and finally Annie ma'am came through as usual. And she ended up reaching out to you, and we were so excited. I have never heard Annie ma'am so happy in my life. Ma'am, never, sorry, that was the first time. But yeah, to those who don't know, Diane is a pioneer and leader in the field of genetic counseling. She graduated from Sarah Lawrence John Marks Graduate Program in Human Genetics in New York. She went on to become a founding member of the Genetic Counseling Program at the University of Michigan, serving as its director and a member of its faculty. During this time, she served on the boards of the National Society of Genetic Counselors, the American Board of Medical Genetics, the American Board of Genetic Counseling, and the American Society of Human Genetics, and completed a congressional policy fellowship in the US Senate. These days, Diane is working with Sarah Lawrence College to help them envision and build a genomics institute to meet biotechnology workforce needs. So we are very happy to have you here once again.
Thank you, Pooja. If I may just make a few opening comments, I want to thank everyone in the audience for being here. And I know you guys have had a long day, so thanks for hanging in there. And I just want to say what an honor it is to be here and to have this opportunity to speak with you. I only wish I could be there in person and see you and meet you all. So we'll just consider this an initial introduction. And I also want to say, for Dr. Hassan, how nice it is to see you again. And also Maya Thangavelu, who was present in the video. Maya and I were classmates at Sarah Lawrence. And I have deep respect and affection for Maya. So it's a delight to see her and to realize we've got this connection also through Lori, who was a student of mine and someone I remain close and connected to. And so I just want to thank you all for the invitation and tell you how delighted I am to be here. And I really hope we can have a conversation. So I've invited Pooja and Lori to let's have a conversation together. I am not going to know as much about the landscape of services or challenges or opportunities in India as you do. So, but I know with Pooja and Lori, maybe we can have a conversation and bring things to focus in a way that is most useful to all of you. So if that's a good jumping off point, Pooja, maybe I'll hand it back to you.
Thank you. So why don't we start with how and where it all began?
Okay, well, there's where the field began in the United States, which was with Sarah Lawrence College, which is where I ended up going. And that's on the eastern side in New York State. And they started their program in 1969 due to a very visionary individual named Melissa Richter, who was aware that there were families grappling with loved ones, with adults, with children, with newborns, with genetic conditions or birth defects. And they seemed to her to be alone. They may have a diagnosis, but there was this whole issue of support. And she said, we could create a profession. We could create a professional who could serve these families, who could focus on them. And I think all of us really hearken back to Melissa Richter as our sort of godmother in birthing this field and the way the field has grown and the way all of us have come to be part of it. How I got into genetic counseling is probably like a lot of you. It's not necessarily a logical story. I came from a family where college education wasn't really a goal, and certainly not for girls in the family. And so I thought, okay, what am I going to do? I think I want to go to college, but I don't know what I want to do. So I thought, I'm going to get a degree that shows I'm educable. So I got a degree in statistics. And as I'm about to graduate, I took a course in human genetics. I had to fill an elective. And I have to tell you, I was supporting myself by working 2 jobs, and I would go to school part-time and just come on campus and take a class. So I never felt connected with my education. It was just something I had to do. I knew I needed it. And when I went to this genetics class, it was the first time I wanted to go to class. I didn't want to miss a word. The topics, the science, the emerging connection between how this science was going to be relevant to families, to decision-making, to communities, just grabbed me. And there was a woman who sat in front of me in class who I'd heard been through a genetic counseling program. And I would, well, we didn't have assigned seats, but when I got to class, I would maneuver to find a seat near her. And I would tap her on the shoulder and say, tell me again about that genetic counseling degree you got. How did you get in? What were I mean, she couldn't get rid of me. I just was like stuck on her anytime I was in class. And I said, I'm going to do this. I don't really know what it is. I don't know how to do it. There was just something about it that captured me. And I think it was the human quality, the humanity of what I was experiencing about it, between what a family was going through and how do they take that journey. I didn't have an answer to that, but I thought, I want to see if I can be part of that journey. So
Wow. But
quick score.
I mean, that's, one thing that I think is very common among all genetic counselors who are assembled here today and those who are with us virtually is the fact that they want to feel connected to people and they definitely want to give back to our community. Because, I mean, I think more than anything else, it's that which connects us. After that, it's the thrill of genetics itself.
Punja, I was really struck when Dr. Hassan said in her opening comments, differences define us, but our common humanity redeems us. And that's true in every setting, every culture, every country.
Absolutely. Absolutely. So, our audience today, they are like, if you can say Annie ma'am has started the program in say a few years ago, the current bunch is the one that's going to be like the bunch of soldiers taking it forward. So we want to really prep our army because we have a huge country to actually help out.
Yes.
So as of now, as you might have heard in the previous talk as well, like we have very few programs, right? But the number of programs and the number of genetic counselors that are being produced are increasing day by day. What were the biggest challenges you came across when you were at our stage? I hope
Yes.
this helps our people to be prepared so that at least we know that, somebody who's gone through that.
Okay. Yeah. I came out on the early arc of this journey for the field of genetic counseling. And we experienced a lot of hurdles. Some may be what you're experiencing, and some you may have skipped right over. One was simply recognition. As I was a first-year student, I was hearing stories of other graduates who were working as secretaries because they were just trying to get their foot in the door in a hospital, in a clinical setting where they could make a contribution. And I was a little nervous, like, oh, I guess there isn't a well-worn path for us, and we're going to have to create that path. And I think that is something the genetic counseling career, the genetic counseling field has taken on everywhere, is like recognizing you need to create a path. You need to take responsibility, not just for being well-educated and ethical and well-prepared, but looking for the opportunities to move yourself and this access to this information forward. One of the things that helped us a great deal in the US was that in 1979, legislation was passed, federal legislation called the National Genetic Disease Act. And I don't know if there's any efforts this way under this in this area in India, but there was recognition that genetics was so specialized and most hospitals, healthcare centers didn't have the access, that we needed the federal government to come in and make funding available. And states applied for this funding. And Michigan, where I grew up, applied for this funding and got funding to hire 5 genetic counselors. There were no genetic counselors in the state. And so I applied for positions. I was applying all over. I applied for one in Michigan. They made me an offer and I thought, I grew up in Michigan. I should go someplace else. So I said, no, I shouldn't go back home. And then later they called me back and they're like, oh, come on. come and interview for the, and so I thought, they're right. I should. So I ended up, it was a great position. I accepted it. And what a lot of the states did is they hired genetic counselors and assigned them to hospitals. And then, so I worked in a hospital setting. I did pediatric genetics. I helped in our newborn screening program, but I was actually employed by the state health department. So it's a model to consider where federal or regional legislation helps a community have access to this service through a genetic counselor. But I know you have a lot of different models in India, but that was certainly a hurdle. And honestly, pay was a hurdle. It was a real hurdle to get a salary that you could live on and that was commensurate with the education you had.
Actually, I think 100% of our audience is going to agree to that. Whoever agrees, I want to hear a clap. So
And
just the entire day we've been talking about how a profession is not recognized, how the kind of salaries we get, nobody is motivated to take up this profession, So, but I'm telling you, who you see here, they're all warriors because in spite of that, we are here. So,
yes.
Yeah.
And we all helped each other. Now, the internet was not what it is today. In fact, the internet didn't exist when I graduated. But we shared position descriptions with each other in ways that we really developed our IQ about how to describe our skill set and our impact in healthcare in ways that hospital administrators would value. Oh my gosh, that's a huge audience. Thank you for the pan. Wow. And so by helping each other think about how to promote, not maybe promote, but describe our work and the power of its impact. And we share that with each other. And the other thing is, in many medical centers, in many positions, you have to write an annual report. And you can say in your annual report, and I don't know if this is typical for all of you, but you can say, well, I saw this many patients, or I published, or I did this. But if you can reframe that instead of simply what the check boxes are into something that has impact about. So in the state of, in the city of, for the hospital of, we have, where you make it a team, we have enhanced access to the specialized service. And think about really describing in a marketing way, and you should not be shy or hesitant about doing this. What is the value to the community? Because hospitals, biotech companies, everyone has a customer base. What do you contribute to that customer base? And you do. You may not, you may think of it in a different way, but think of it in the bigger way and think of the way to describe that so that your employer and your community can go, oh my gosh, that's so valuable. I got to hold on to that. I don't know if this is something, but it's something we grappled with early on, is how to really frame the value of what we're doing. We also had to go through accreditations. We had nothing. We have no credentialing. But I want to tell you a little story that I think is encouraging. And then, Lori, I want to invite you also to see, because you know me and know my journey. So if you want to direct me, please do. But when I became a genetic counselor, we had 5 areas of practice. We had medical genetics, we had clinical genetics, they were different, cytogenetics, molecular genetics, and genetic counseling. So we had 5 areas of genetic specialists. And I can tell you today that the most thriving, robust area are the genetic counselors. The other areas have declined in volume, declined in interest. They still exist and they're very important. I don't mean to misrepresent things, but the growing and expanding field for genetic counselors in the US is amazing. Many, as you already know, working in cancer, working in pulmonology, working in research labs, working in molecular diagnostics, and working in a variety of teams and forms of supervision and forms of leadership. We have our fastest growing career ladder is in biotech right now in the US. So what's happened is I came in where the master's prepared genetic counselors were fighting with 4 MD, PhD fields for recognition and travel funds to go to meetings. And now today, we're the largest and most thriving facet of that community. So Lori, jump in with me and help me with what might be more useful for our audience.
Well, Diane, I think that everything you've shared thus far has been incredibly useful, at least as I've experienced as an outsider, observing the growth of the field of genetic counseling in India. I think one of the things I would like to, and you've already, addressed this in some manner, but I wanted to really ask you to unpack a little bit more about, do you have any stories or experiences to share around working with other members of the healthcare team? Any anecdotes, anything, because I would imagine that at the time you were entering the field, how challenging it could have been at times to see a master's prepared individual who is in a profession no one knows about and how you and what you can contribute to the healthcare team. Can you elaborate any more on that?
Sure. And Lori, keep pushing me if I'm not hitting it. So I remember early on in my field, I'm the first genetic counselor. I'm in Ann Arbor, Michigan at the University of Michigan Medical Center in a pediatrics clinic. And I was basically getting to do a pedigree, and that seemed to be all they had me doing. And there's a part of my brain going, okay, well, maybe this is how I get my foot in the door. Maybe this is the way to get started. But I thought I could do so much more. And one day, one of our pediatric geneticists were in clinic, and he came to me and he goes, Diane, can you work with this couple? I think I need your help. And I was like, oh, okay, what's going on? So they were a lovely couple, came in. The husband has achondroplasia, short stature. The wife is average stature. And in fact, she's an opera singer. He was a sports newscaster. And they were pregnant for the first time. And she did not realize that she might have a child with achondroplasia. And what happened is they had come in for counseling on this. They had been told that, and the wife is in tears. So I have no relationship with them. I'm asked to walk into the room in the middle of this crisis. And I did. I was intimidated because I thought, I don't emotionally know or experientially from the half hour the geneticist already had with them exactly who these people are. But I walked in, introduced myself, asked them to tell me what's unfolding now. Tell me how you're feeling. And we had this great counseling session. And the wife was able to say, if a young man with achondroplasia walked up to our door, knocked on the door and said, oh, your husband is my father. He didn't know that I was born. I have achondroplasia. She said, I would welcome that young man into my life. That would be the man I love's child, and I would welcome him. But somehow the fact that I'm carrying a pregnancy and I might have done something that would cause my pregnancy, my child, to have to struggle in any way in life, she said, I don't know how to deal with that. Well, what happened is she had pointed all of us to where the issues were. It was her sense of, am I responsible and how do I understand that? And her sense of, but I love my husband and I would love any child he had with achondroplasia. And we were able to bring those threads together and help her begin to build a relationship that wasn't based on fear, but a relationship based on hope and excitement about her pregnancy. Now, I'm not saying we got there in one session. I'm saying we started that journey. But what that did for me is I was able to go back to the pediatrician and say, let's involve me sooner. Let's make a plan for our cases in case conference and talk about which ones, instead of which ones need a family history, which ones are going to be potentially more laden with counseling issues, and let's assign me to those. And so what I did, Lori, is try to take the hurdles where I didn't want things to continue that way. And when I had as I call it, a learning moment with my geneticist, I tried to say, okay, here's how we can both be better the next time we see patients together.
Thank you. That's a beautiful story, and actually one I had never heard you share. So thank you for sharing that. But it opens the door for me to explore just a little bit more around that psychosocial component of what we offer families and our training. Now, I know from the few times that I visited India and visited with Dr. Hassan and Dr. Garisha that they both value very much the psychosocial aspect of our work and the training. Yet at the same time, I know in some of the programs that is still a struggle to have someone teaching those components, or perhaps, and I do not know this as fact, so this is a projection on my part, perhaps taking that model of genetic counseling with the psychosocial aspects from North America and trying to apply it in a different cultural setting. And so can you just speak to that aspect of our work more and the training for that?
Yeah. Okay. I think I understand what you're asking me, what you're asking, Lori. So let me first tell a personal story and then come and talk about a more global perspective on the US and Indian training models. So I can remember the first time I counseled a conservative Middle Eastern family. And I had read the chart. I was meeting them at the bedside. They had a newborn with a genetic condition. And all the notes said, talk to the father, talk to the father. Now, I come from a cultural orientation where you talk to both parents. And I knew the mother would be present, but they had all said, be sure you just talk to the father. So I walk in, the parents are seated at the bedside. And just because I couldn't stop myself, I kept making eye contact with the mother. And as soon as I made eye contact, she would drop her head. And I thought, oh, okay. Yes, I walked in this lovely Middle Eastern couple who already had 2 healthy children, and they had a newborn with a genetic condition. And I had read in the chart, talk to the father, but I didn't listen. I talked to the mother, and I made eye contact with mother, and I would look at the mother, and as soon as I looked at her, she would drop her head. And, when you're trained in my culture and in my program and in my own practice, I try to equally connect with both parents and engage them in their concerns and questions and hopes and dreams. And I realized I'm blowing it. I am not helping this couple. I'm not helping them at all because I'm hung up on my orientation. And I gently shifted and I looked at the father and I spoke to the father. Now, I would sometimes say, and your wife may have a question about, but I didn't ask her questions. I really finally listened to what my colleagues had been saying in the chart, talk to the father. And I thought, I'm going to help the mother more if I do this. And now, since that first experience, I've learned a lot about Middle Eastern culture, because in Michigan, we have a growing Middle Eastern population, and I've had much more experience. I think I've done better. So I think part of it is we all learn at our own pace, and we all have to fail ourselves before we can pick ourselves up and say, okay, I'm not going to do that again. But I think when it comes to cultural differences, we have to understand that they're real, and we can't impose one model on a culture and expect that it's going to work. I think there are some things that are valuable in our model that we use in the US around communication and around building a relationship and rapport with a couple, but I don't know that that works in every culture. And I think this is something that each culture has to evolve for themselves. What do we know sociologically, psychologically, in family medicine about how families and cultures work and communicate? And how can I work within that understanding to be effective and to be helpful. Now, Lori, I don't know that I really addressed, so come back at me if I didn't get where you're going.
No, you did. You did. I think that was exactly sort of where I was headed with that, because that has been a question of mine and something that I wanted to explore, when I was in India and observing. And so, no, I think your case example as well as that explanation was fantastic. Thank you.
And I mean, it's important to say you asked a big question. I mean, what you asked about is at the heart of the communication and empathic relationship we try to have with patients. And I think in some ways we both each individually have to continue to work at being in our best game, but we also have to understand the trends and the changes and the tumult around us and how can we work, because I think working with a 20-year-old couple is very different than working with an older couple who's looking at adult onset condition. I mean, I think your communication style, the way you build rapport, it's going to be different, and you have to have a palette of approaches and models to work from.
Yes.
Yeah, and sometimes I just wonder, like, especially in India, we have so many different cultures. Every different state has a different language and different cultures. Sometimes I just wonder if, by empowering the women, are we creating more harm for them among their family members than if we just talk to the senior most person or just fit into what their dynamics is, right? Because we are trying to empower them to make their own decisions. But ultimately, they are going back to live with their family. And I just feel we're going to put them in a worse spot than they were before if we hadn't spoken to them about, their rights. Has anybody else felt that way? No? Okay. The audience is not agreeing with me.
Punja, that's a big question. That is a big question. And I think in some ways you and your colleagues are best positioned to answer that. And I suspect it's a dynamic that's evolving. I mean, the way you may answer that today is probably different than the way you answered it 5 years ago or 5 years in the future. I mean, that's probably a rich area for conversation amongst those who are gathered here today.
So if I may just give an example, like off the top of my head, like if a family comes to you where that in the family dynamics, that the mother is not being treated fairly. Let's pick an X-linked disorder, and we know that it is coming through the mother, and she's facing extreme, torture at home mentally. That it's all because of you that I have these kids. So now, see, as a counselor, what would you say? You would ask the husband, if you were in that position of your wife, right, where you were the carrier, would you want your wife to treat you this way? Right? We believe that everybody has to be treated equally, isn't it? So in such situations, if you go empower the women and say that, what, it's not your fault, it's your genetics, we can't do anything about it, you should take a stand for yourself. But what if due to our empowerment, the husband throws her out of the house?
Oh.
And it's not like all women here have financial independence. I mean, it's just a question I'm throwing out there for us to think, right? I mean, if we say, so, I mean, I know a lot of situations where we test both the parents for X-linked disorders, just because we don't want the family to know that it is coming through the mother only. So that's where we are right now. Like, if people in other parts of the world look left and right, we have to look left, right, top, bottom, everywhere to ensure no vehicles are coming on the road. So
it's a challenge. It's true for X-linked conditions. It's also true for autosomal dominant conditions with variable expressivity, where a parent has a very mild form and then they have a child with a much more involved and complex presentation. And it really comes down to the issue of blame and how that works in our culture. And I think there's a way to confront that directly without, and you have to, I mean, and I think this is where role play helps and case examples help, because there are many ways, there are ways to approach this where you can say, this is something you had no control over. As with a recessive condition, you have no control over it. And this is what we know happens by chance or by statistics. And people, if people are open and amenable to hearing the fact that no one had control over this, no one had control over a spontaneous mutation, it's something that happened, and try and get them to talk about why are they feeling that there's blame here, and who is, and because if you can talk about the blame, you can realize, well, no one did anything. It was a chance. And by helping them have a conversation with you, that may give them some tools to go back to the family to have a conversation. In a short session like this, I know it's going to be hard to really tackle this, but Punja, you brought up a very real and very important circumstance, because there is, if one chooses to, you could just blame, well, because I picked her as a wife, it turns out it's X-linked, but we all know we have no control over this. And I feel like I'm not giving a very good genetic counseling reaction right now, but I think this is something that is our work, to help a family understand truth and understand that it is also chance and that no one did anything here.
True. True. Okay, at this point, I would like to shift a little and go back to one of my original questions. So, in your journey, right, from like the initial years to now, did you get more support from clinicians? Did you get more support from government, or did you get more support from the industry?
Oh, that's interesting. That is very interesting.
I'd really like to know.
Initially, we had a great deal of support from state governments, from public health departments, because almost every state in the US has a public health department. They see this as a public health service, and there was a great deal of support. But we were often not working in the health departments, we were working in the hospitals. And it was interesting. There's always a little turf issue, the pediatric neurologist or pediatric pulmonologist would love that we were working with their cystic fibrosis patients or their Duchenne muscular dystrophy patients, but sometimes our own geneticist colleagues would be like, I'm taking the medical students in, I don't need you. And there were definitely some turf issues, but I think it took them seeing the output of my role and seeing the benefit to the family, and sometimes seeing that over time, because we would see families again. And when for my physician colleagues to see that had an impact. I think there were also times when I was working with them and you could see they were kind of like, oh, I'm not sure how to respond to this. And I would lean forward and say, well, let me ask you a question. And they could see that I was comfortable with some of the emotional terrain that they were like uncomfortable with. And that's different for each physician. So that was something that helped. And I would say today, in the US anyway, biotech loves genetic counselors. Industry loves genetic. They cannot get enough because, and you know why? Again, I'm going to say it comes back to Dr. Hassan's statement. It's about our humanity, because it was mentioned in my introduction that I'm working with Sarah Lawrence, and we're working at creating a new program that's going to be, we hope, a feeder into biotech through certificate programs, not genetic counselors, but technical people. But they all employ genetic counselors. They said they do our marketing, they do our product development, they do our writing, They work on it and they interface with the boards, they interface with the customers, because they said there's this humanity. The genetic counselors understand the consequences and the risks, and that there are families who are going to make their informed decision to not use something. And for that family, that is probably the right decision. And they didn't feel their arm was twisted. They felt they could say, you know, we don't want this right now. We don't need this. Maybe in a couple of years, but right now, no. And what industry is finding is that that's not something the rest of their staff always has. And it's something they can count on the genetic counselor staff for. So it's been this evolution from sort of government to geneticists to industry.
Right. Interestingly, I mean, I just have a quick question to our audience. How many of us are currently working in the industry or employed by companies? Raise of hands. Oh, and the remaining? Hospitals.
Pooja?
Oh, sorry. Hi, Lori. Can you hear me?
I could not. I'm sorry if I interrupted
Oh.
you.
Okay. So we were just taking a quick show of hands among our audience. How many are employed by the industry? If we can again put that. Okay, that's actually not a lot. The hospital. Okay. And industry. Yeah, looks like that. And the remaining? Self-employed. NGOs. Okay. So we have about 60% of our audience who are working, are employed by the industry currently, and 20% by the hospitals and 20% by social organizations like NGOs.
Yeah.
So that's one thing that I think, as far as genetic counselors are concerned in India at the moment, I think industry is going to be the biggest supporter, at least for the near future. And maybe now with all the efforts that the BGCI and all of us are putting, maybe soon the government and possibly then the geneticists. I'm not sure, but we're working towards that. That's interesting, isn't it? Usually you got help from the government first.
Yeah. Yeah.
So that is another agenda of our meeting here this 3 days. So we also had a very fruitful discussion just before our talk. So Dr. Lakshmi, who's our vice president of the BGCI, is going to be writing a white paper on like why it's important for us to have genetic counseling education that is accredited or acknowledged by the government, and genetic counseling position has to be offered by the government. So I think today we have made a very huge step towards the same. So I think our conversation came at a good time.
Well, good luck. And I congratulate you on your 7th annual meeting. That is an achievement and something to be proud of. And you're building your network.
Yeah. We're actually very happy about that. Lori, do you have any questions? I have too many.
Did you ask if I had some questions, Pooja?
Absolutely. Dr. Annie wants to ask a question.
Ah.
Ma'am,
Hello, Diane.
Hello.
Hi. Thanks for
Hi.
joining us. Yeah, I really appreciate this. We had one question that you have developed a master's program, and it is the master's program qualified people who get the certification. And the rest of the world is more or less replicating that, right? But in India, we have a really large gap. We are 200 plus people, and we want to make them 20,000. Okay? And we have to do it fast because this is the need of the hour. So we were thinking that we should have lateral entry. We have people who have done life sciences. We have people who have done PhDs in human genetics and life sciences or medical genetics related fields. They need to learn certain skills to become a genetic counselor. And we thought we could have modules or observerships or attachments which would train them for the skills they don't have, complementary skills, but they have to get certified by the board. Would that be a good idea? And your comments on that?
You know, I'm going to step back from that and come closer. I'm going to step back to the bigger picture, which is, I think, to make sure there's collaborative agreement on the goal. And you said the goal is to increase the number of service providers. And I think to be sure that there is broad representation from those with investment in that goal and that everybody agrees. And that's the most important piece is, does everyone agree about this goal of increasing the service provider population? And actually get that written down and say by 2025, or let's say 2030, let's give yourself some space. These are the number of providers we want. And then the second goal is, and what is the standard of performance? Because if it's certification, it's certification. But maybe what you want is even a tiered environment. And what that allows is for people to enter with a certificate or enter with a life sciences degree, as you said, and then get a certificate, and then maybe work up to certification. You could actually, be able to describe that. We have a tiered system that you can enter into practice at any one of those tiers, or you can then at some point move up to the next tier, and here are the requirements to get there. I think this is the time as you're building to have a collaborative, broader agreement, maybe amongst health institutions, amongst the professional organizations. In fact, your organization is probably uniquely suited to lead this, about here's our goal, here's our standards, and now let's build to meet those standards. And maybe the build is we need more genetic counseling programs. Maybe the build is we need more certificates. And maybe the build is we need to give more nurses a module so that they can become certificate qualified. So I think there's not one path, but I think there's a path that could work for you. And I think it's really about bringing leadership and players together and getting some sort of hashing out and getting agreement on the goals and how to get there. It may take a little while.
Yeah, we are prepared, I think. So I think as genetic counselors, patience is inbuilt in us. So we're okay to calmly wait and continue doing what we're doing.
Well, and you don't need to wait. I think you're the on the ground providers. You see the need. You know there's a need.
Yeah.
And to lead with that is a good way to lead. There's an unmet need. And let's talk about how we can meet that need and how we can all, because you have an opportunity then to reach out to other institutions of higher ed and say, hey, your talented life science students may want to know that here's a pathway for them.
Right. I think Lori had another question. Lori?
Yes. Can you hear me, Pooja? Diane, can you hear me?
I can.
Okay.
Hi.
So I have a couple questions, but the one I want to shift for a moment and ask you, what concerns, if any, do you have for genetic counseling globally, or what you know, suggestions would you offer, you know, India based on the developmental pathway of genetic counseling in the U.S.? You know, maybe they don't have to go through some of the hurdles that you did, that the profession did. But that, you know, so kind of there are kind of two questions embedded in that perhaps. One is just concerns in general, if there are any, for the profession, and then any suggestions, you know, in addition to what you've already offered for India as they develop this field.
Okay. Let me see. That great questions. So when it comes to concerns, I'm going to speak again with my biases, and I come from a US bias, and also after 2.5 years of COVID. And in our country, we are having a clash between trust in science, well, around trust in science. We've had a big uproar around anti-vaccination, some of it anti-science. And so I'm projecting because it's been a big concern for me. So to me, a global need is trust. And how we, because it's a need I have now in my country, is how to build trust in science and an ability to talk about it so that people feel comfortable delving into it and don't feel threatened by it. We have deniers on climate change. We have deniers on, again, vaccinations. So that is just something I feel is right in my face every day in my country. And so I would not want to see that spread. And I think one way that it would help ensure that is to also think about how you're building trust in the institutions that you have for healthcare and for technology and for genetics and genomics. And that's at a big picture level that no one of us alone can do. But I think organizations like yours, and through even your website and your communication, can think about how we're also building trust for the current and future patient population. And again, I know that's a big picture issue, but I will say that's been a concern for me, trust with the basic population.
I mean, we may have a similar concern in India too, because I would like to just say that today we had Dr. Ratnama with us, who's been working in a tribal community, identifying sickle cell and beta thal affected individuals and helping them get testing done. So one of the things she came across the most, her biggest challenge was people in the tribal community believed that their children were possessed rather than understand that they actually had a genetic disorder and they needed a genetic test. So she was just sharing how she had to individually connect with each patient or each family, and only then, like, you know, she was able to teach them, or, you know, help them identify that it was not that somebody was possessed, but it was actually a genetic disorder, and everybody needs testing for it. I mean, I think that way we are on similar page, on the same page.
Yeah, a different facet of that. Yeah. And Laura, you had a second part to your question, which now I've forgotten.
Oh, it's okay. It was a bit tangential to the question about concerns for the profession, but the second part of the question was just as you think about sort of the pathway in the U.S., because that's your experience, would you have any suggestions beyond what you've already commented on for India as they are rapidly growing and developing genetic counseling, you know, in their country? I know it may not feel rapid all the time to them, but from an outsider's perspective, it is. And so I just wondered if you would have any other comments, thoughts about that.
You know, it's tough as an outsider to have the insight necessary to but thank you for the opportunity for asking it. I think this really needs to be a response that forms somewhat organically, but within India, but also is driven by the people who care about it. And I think that's the people at this conference, but I'm sure you've got partners outside of the room that you could draw on. And maybe it's some of the leadership in biotechnology or hospital leadership. I'm not sure about your healthcare systems, but because your growth is going to be more sustainable if it has buy-in by all the players.
Can you repeat that? It's going to be more sustainable
If you have buy-in from all the major players like healthcare systems, public health, academic institutions, maybe biotech and industry leaders. And again, your organization has the potential to be a neutral convening body because you're a professional association. You care about professional standards and access to service. And maybe that's something for you to talk about taking on.
I think at this point, Lakshmi, Dr. Lakshmi, who's our Vice President, had a question for you.
Okay.
Hi, Diana. This is Lakshmi.
Hello.
So, okay, I have two things to tell. Initially, Dr. Annie was wanting me to share, like, we have the level 1 and the level 2 in our BGCI certification program.
Oh, okay.
So you were telling we could rise from this to that. So initially they have around, they need to have 20 log cases, and we have the examination and the interview, which is at level 1.
Yeah.
And when after 3 years, they can apply for level 2, where they have more than 50 cases to be logged in, and they have reflective cases and things. So they raise from level 1 to level 2 with more maturity and more experience.
Okay.
So this is something which is happening in BGCI now. So this is in terms of when we have lateral entries and various ways to encompass and bring in more genetic counselors into the system.
That sounds great.
So the other thing is the trust, the last part you spoke, where we need to have people taken, they have like the public health system, the government, the academics, which really takes in this genetic counseling as such. So as Pooja was mentioning, the need in this country, in India, again, we have around 28 states, and each of the state has its own language. And a genetic counselor can never do their job well if they are not familiar with the language. Science is one, knowledge about genetics, testing, all fine. But if they really need to be a good genetic counselor, they need to be fluent with the language. So this is something which is very important, and more if you need to have it as a public health initiative. And today when we say genetic disorders, it's just not the urban. The way the scenario in India is, yes, you have the cities, then you have the villages. And the population in the villages are much more than the urban. And the urban, they anyway reach the clinician, they might have the money to do the test, and then they might get the counseling. But if you really want the numbers, it is then in the rural. We have to reach them. The numbers are big. The public health system does not address. Even the medical system doesn't have genetics in it, to say the truth. So I feel, as you said, we have to bring in lots of stakeholders in it. Now we have the national policy coming in, the registry initiatives coming in. So if you have to put in resources, we need to know the numbers as a whole. So I feel reaching out to the rural. And here we don't have clinicians even to serve in the city. So they coming into the rural to the villages. No, it doesn't happen at all. So here the genetic counselors have a huge role. They have the science, they have the techniques, the genetic testing knowledge, they can train. So the way we have worked, I had an NGO called MDCRC, which is now 10 years, and we have been working with Duchenne's. And to say the whole state, we have covered Duchenne's, where we say identify to prevent. That is the first step. You identify the rural level. So how do you identify? So we train the complete health system, the village health nurse, to just the symptoms, quick symptoms. Oh, if it's Duchenne, okay, it's a boy. So they just go down door to door and say, okay, how many boy, how many guts, okay, boy. So these are the symptoms: frequent falls, waddling gait, toe walking, Gover's sign. So this any person, even if they are just school educated, the village health nurse with the videos, they understand. So for every village health nurse, they have 1,000 houses under them in the village. So even during the training, they say, oh, I know the boy is there. Oh, I know here, this house, the boy is there.
Yeah.
So it helps us identify at the grassroots level and then bring them to the primary health center where we have a normal MBBS, that is just the clinician. He doesn't have any specialty. But then he does his homework. We train them also. When we started training, initially the doctor said nothing can be done. We just ask the parents and the child to go back. We say no, we can prevent it. The next child, we have seen mothers with 4 and 5 children affected. If we had a public health intervention there, we could have avoided that. When there's no cure, there is no point. And again, at that economic level, the way they suffer is huge. So then after that, we bring them to the neurologist to do the final before we take the blood sample. So the way I feel is, as you rightly said, we have to bring in as many people as takers for the genetic counseling. We have to educate the academics, the medical institutions, the public health institution, the government to recognize. And I feel even 20,000 genetic counselors is not enough. We need a huge, because the population in India is so much, and the number of genetic disorders and the heterogeneity is again so huge.
Yeah.
But wonderful. And as you rightly said, the effort has to be consistent, and we have to earn the trust. Because when we go, we take the sample, we do a pre-test genetic counseling. With the report, we do a post-test genetic counseling. Then we do a pre-test carrier counseling. With the thing, we take the sample and do the post-test carrier counseling. And we are very careful. It's very sensitive. And you know, India is a patriarchal society. Most of the mothers say, please, you say the report is not ready, or you say the reports are not okay. They don't want to take the report in front. So every family is different, and we go down to them to counsel and give it. And the trust we build doesn't come in one sitting. It takes time to build the trust and then bring it. But it's a very satisfying. And when you know, you have really educated that, I would say most of them are illiterate about and give them the genetic knowledge, tell them in their language, prevent and help the daughter not have a kid like this. This profession is something which is very satisfying. And thank you so much, Jaina.
Thank you for educating me. That was a wonderful description. Thank you. You know, you also made me realize I neglected to include another stakeholder, and I don't know if they exist. I don't know what the representation is in India, but in the US, we have a lot of patient advocacy organizations.
Absolutely. I was just
Or
going to
parents
ask you
work,
about that.
and those are wonderful voices to bring to the table. That is the lived experience that everyone listens to, and they could be great partners in any plan you want to make.
Actually, I was just going to ask you about that, because we just had a conversation also today morning, and we found that who better than patients to advocate for them? I mean, because they know everything that they have been through. So today morning we had a patient interactive session as well, like where we heard from a few patients, and I think more than anything else, our collaboration has to include them as well. That's the only way I think it's going to be sustainable. So, but do tell me if I've missed something, but I think overall in this conversation, we've got lots of pearls of wisdom from you. And I would just like to point out these to our audience once again so that we have some food for thought. So, I mean, what I've understood is in the current scenario that we are in India, in genetic counseling, I think it's very important for us as genetic counselors to be patient, make our own way, not be shy, fight for what we really stand for, ensure that we cover all aspects of our training by ensuring that there are role plays, that playing out different scenarios. And last but not the least, and the most important, be collaborative, right? So, and one more thing, when you spoke about trust, right? Agreed, we all have to work together. We have to trust all the industry, the clinicians. But I would just like to give a food for thought to all our counselors here. How many of us genetic counselors refer our patients to other genetic counselors in India? If a patient comes to us and it's not, and the patient does not belong to our specialty, how many do we pick up? How many of us pick up the phone and call other genetic counselors? Only when this entire room, all of us lift our hands, then we are in a position to say that yes, we as a community are working together, and then we can collaborate with others confidently. I think we should definitely reach there. And I think we are on that path. Uh, sorry, Diane, can you hear us?
You dropped out for a minute.
Oh, I'm so sorry. Till what did you hear?
That we're on a path.
Uh, I said we are on the way because, like, we are just a few of our genetic counselors who actually even, work together, because mostly we work in the industry and the industry is competitive, right? They're all competitors. So, but ultimately, I think now we are a good group of people who are interested in working together and who understood the importance of collaborating with each other.
Sure.
And oh, Suraj has something to
Yeah,
say.
I just could not uh, resist getting up and talk on behalf of all my colleagues here. Uh, a big thanks to Diane from all of us on behalf of the forum.
Thank you.
Because
Thank
the points that you said, only 200 of us, and genetic counseling as a profession, we are at a stage here now, how it was in the US several years ago, that we are introducing this profession to our clinicians and other healthcare colleagues in the country. And when you said what sort of an impact with the patient could be projected in terms of presentations or measurables, that was the takeaway message for all of us. I have now shifted to a hospital-based job, being in an industry and then an NGO. Then now, when a lot of things like training and accreditation goes on to increase the numbers, a few of us are getting into mainstream places where we are trying to make this profession visible. And in our day-to-day life, we feel that resistance, a clinician would doubt us whether this person can do it. So in order to prove how we can do today, Diane's talk has to be scripted and played to all our genetic counselors in the profession to get that, that energy to go on and make this profession more visible. Thank you so much, Diane.
Thank you. It's been a pleasure to be with you. A wonderful group of people. I wish you all the best. Hang in there. Thank you.
Thank you. We need that. And thank you, Lori. Thank you so much. Lori has been making me feel very comfortable over the last few days because we've been deciding how to go about it. And she was really, really, really helpful. So I just want to thank Lori for this. And thank you so much, Diane.
You're
And
most
I also
welcome,
want to
Pooja.
thank
My
Dr.
pleasure.
Annie for making this happen. She was really persistent, and she got us an opportunity to interact with you. So we thank you so much once again. And
Thank you, Pooja. Thank you.
have a great day.
Thank you. Thank you all. Have a great meeting.
Hello, everyone. Just yeah, we can. Before that, I just want to say everything. Sorry, say something. So the whole point of this session was for us to understand that we are on the right path. We all are there for each other, right? And ultimately, to reach the ideal golden number for India, each one of us here has to produce at least 1,000 to 5,000 genetic counselors. Yes or no? So that's the aim. So going forward, I really want you to look at the next 2 days as a collaborative opportunity. Seek out other genetic counselors who have similar thought processes, similar goals, similar aims. Work on projects together. The one thing that we need the most in our country right now is Indian data. How many of you, when you're talking to your patients, actually research or look up Google and find Indian data for your patient's disorder? Yeah. So the one way as counselors we can contribute immediately is by collaborating with others, share data, and say, see, we don't have to go somewhere. We have a unique genetic pool. We have our own data. And when we have contributed so much to our society and our country, will clinicians stop associating with us? They will come running, right? That is another way. We have to make them come to us. And we are not trying to differentiate or alienate anybody. We are just showing where our specialty lies, and we are just doing what we do best. So I just hope that all of us can look at the next 2 days as a collaborative opportunity. Look at every session that way, every talk, everything that has been organized the next 2 days is to make us think in those lines. And we really have to increase our numbers. It's the need the need of the hour. So once again, thank you all for coming here, even those who are there virtually. Now I just want, Annie ma'am wants us to look at the video of genetic counseling in India. We are just going to play that. But I really hope you have a very good 2 days. Please enjoy your stay. And we have a lot of fun activities also planned for you outside, like a lot of you have seen. Take this opportunity to get to know each other, and let's all work towards the same goal. Thank you so much.
Selection process, examination process, and so on. All these people started getting jobs. Jobs in industry, jobs in hospitals, but none in the government sector. So we realized that the numbers are too few and the work is immense. To do that, what we decided is that we should have a board of genetic counseling which takes lateral entry of various people who are interested in genetic counseling and taking this profession forward, on the advice of Professor Shirley Watson, whom I met regularly in the cancer genetic meetings at Tata Memorial, Mumbai. And she told me that maybe you have to take the bull by the horns and start the board of genetic counseling yourself. So then we took like-minded people, one from the north, one from south, one from east, west, sort of, and came together and we started the Board of Genetic Counseling in 2014. Here I need to mention the role of Mr. Percy Italia. He gave this board a shape. Being a chartered accountant, he told us all the nuances of accounting, how to the NGO, what is the rules of meetings, making an executive committee, and so on. So the whole shape was given by him.
I'm Dr. Lakshmi, one of the founding members of BGCI, Board of Genetic Counseling India, and this year I am the Vice President of the board. It was in 2012 I met up with Dr. Annie in Chennai, and our conversation brought out the common vibe between us, the need to have more genetic counselors in this huge country, and established genetic counseling as a profession, and this made us get together.
In 2014, Board of Genetic Counseling India got registered as a society. The executive committee was formed and the members put together the course curriculum, uptake criteria, the examination pattern, and the selection processes. We then reached out to practicing counselors to come together as an organized group. The philosophy of BGCI was all encompassing with grandfathering members, new associates who again joined the team. Eventually, after a couple of batches, the course was now industry ready. So we worked towards having natural entries. Otherwise, genetic counseling as of now was restricted only to universities and did not have the desired reach to have adequate uptake by clinicians who we know due to paucity of time and skill in the area would be needing particular expertise of trained genetic counselors.
I am Dr. Kodati Vijayalakshmi, Chairperson of the Examination Committee of BGCI. The BGCI aims to deliver quality genetic counseling services to the society through well-qualified genetic counselors. The Examination Committee is responsible for certifying the genetic counselors. BGCI has been following a standard examination process successfully since its inception in 2015. Written examination will be conducted every year, and the successful candidates will be interviewed by a panel of external examiners comprising of a genetic counselor, clinical geneticist, and a psychologist. The examination committee is constituted by experts from various specialities of national and international repute.
Coming to the examination, in 2019 executive meeting, we thought, why don't we have it as online or computer based? And so we started making the plans. And in 2020, we had planned the BGCI conference, the annual conference, which was an international conference, and the exam, which is going to be computer based in Coimbatore. But alas, 2020 March, we had the pandemic. And so we had to do everything virtually. So this effort of making it computer based, we shifted it to online exams. And again, the conference for the first time, the 5th International BGCI conference became virtual. So here, both the conference and the examination went online or virtual. And it was a grand success. The next year again, 2021, the conference was virtual and it was a grand success on a wonderful platform. This year, we are going to have it as hybrid, where we have both online participants and speakers.
I'm Dr. Jayavya, Secretary of Board of Genetic Counseling India. In order to connect with BGCI as an associate member and to join us in creating awareness of the importance of genetic counseling, BGCI is welcoming geneticists, scientists, technologists, and counselors to submit their detailed CV with relevant experience via email ID mbgci2014@gmail.com. If shortlisted by the EC committee, a telephonic interview will be conducted. Once convinced about our mutual interest and benefits of association, you will receive a certificate with validity for 3 years, for which a membership fees will be charged. In addition to this, BGCI will also be happy to accreditate the genetic counseling course conducted by our institute. The rules and regulations for the same can be accessed on the BGCI website. Any queries can be mailed at the former mentioned ID. Welcoming everyone to work towards the common cause of furthering genetic awareness in India.
Genetic counseling has tremendous role in management of the burden of genetic disorders. It facilitates better understanding of the importance of genetic testing and consequent benefits to the individual families and society at large. Huge endeavor is necessary to popularize genetic counseling on one hand and to develop the professional pool for delivering the services on the other. Board of Genetic Counseling India has been preparing such professionals with the required expertise.
Genetic counseling as a profession has become more recognized. Genetic counselors are being sought out by various institutions and clinical specialties. Our trained counselors are being offered good placements, and the job satisfaction is very evident, as you can see from our practitioners' experience.
That I did my undergrad in genetic engineering from SRM University, where when I actually discovered the profession of genetic counseling, and I was like, yes, this is exactly what I want to do for the rest of my life. The program itself is structured in a way where you have immense exposure, both practically and theoretically. Cut to 4 years, I'm working for a corporate company now. Been doing a lot of sensitization programs, meeting a lot of doctors, doing a lot of clinics, meeting a lot of patients. And the most beautiful part of it is making a lot of differences.
I found out about BGCI when I was pursuing my master's in applied genetics from Bangalore University, Karnataka. During that time, I was clueless what to do and how to do genetic counseling. So while browsing, BGCI website popped up and it showed way of getting into community hospitals, which helped me to understand the major framework of genetic counseling and being a genetic counselor, what we should do and what we should not do. So that part of the course, which had a lot of clinical inputs in the form of clinical rotations, helped me to understand the way genetic counseling works in each and every department of human anatomy, if I want to say. This has definitely helped me in gaining confidence and you know have a way forward in the field of genetic counseling as a genetic counselor.
With the advent of genomics, genetic counselors are looked up to in every medical specialty. True to the same, we enjoy taking integral roles as a point of liaison, connecting other eminent health professionals for patients in addition to our routine counseling and support services. This dynamic profession is rapidly advancing, ever changing, creating new roles and possibilities. Yes, proud, responsible.
I'm providing pre-test and post-test genetic counseling to the patients and families with hereditary cancer syndrome for the last 6 years. Since I have been working in a cancer center in Ahmedabad, it provided me a very good opportunity to interact with clinicians, specifically medical oncologists and the surgeons, to make them aware and educate about different hereditary cancer syndromes. The genetic diagnosis is actually helping them taking important surgical and the treatment decisions, which is bringing a lot of change in the lives of patients and families.
What are the different career options when it comes to genetic counseling? Genetic counselors may work in healthcare setups such as hospitals and clinics and provide genetic counseling services. They may also work as a part of genomic diagnostic companies as variant analysts, provide pre-test and post-test counseling, and act as subject matter experts for their marketing teams. Further, genetic counselors may also be involved in research projects. They may also work as a part of rare disease advocacy groups and NGOs. And many genetic counselors also work in groups who are involved in drafting rare disease policy. So the career options when it comes to genetic counseling and for genetic counselors are many.
Seeking genetic counseling is beneficial in many ways. For example, it helps couples facing difficulties in planning a successful pregnancy by helping them choose the right reproductive options. It guides couples who already have an affected child plan their next pregnancy. Genetic counseling also educates families with children facing intellectual and behavioral challenges. Genetic counseling helps in calculating personal cancer risk in individuals with a positive family history and also helps them explore appropriate treatment options for their dearest ones affected with cancer. And the benefits are many more. If you in person want to seek genetic counseling or want to refer a friend or a family member to a genetic counselor, please do reach out to us.
From 0 to 200 plus has been the journey in these years, and I'm hoping that this will grow into a big tree which yields a lot of flowers to give fragrance to in the life of patients and families, and fruits for all the counselors who have made this possible and will take this forward. Thank you.
The genetic counseling program in India has come a long way, especially with the establishment of BGCI. And it is really, truly wonderful to see this growth and expansion of the program.